Pune-based Genova Biopharmaceuticals, a subsidiary of Emcure Pharmaceuticals, is working on India's first mRNA-based vaccine for COVID-19. Genova has received funding from Department of Biotechnology and plans to start Phase 1 clinical trials in October 2020.
For COVID-19 vaccine, Genova is using next generation technology which combines mRNA and adjuvanted nanolipid carrier. This vaccine will be very low dose injectable, sustained release due to its self-amplifying mRNA platform. This will ensure safe and efficacious vaccine.
The advantage with Genova's mRNA vaccine is that it is rapidly scalable. So Genova can tap into the vast specialized nanoparticle capacity that has been already created at Emcure's sterile parenteral sites to make close to 200 million doses. Additionally, our team is already partnering with different OEM manufacturers to install 1 billion doses capacity.
Led by the visionary founder Mr. Satish Mehta, who has given many innovative and first in India products to the country. Emcure is committed in its fight against COVID and is working towards Swasth Bharat, Atmanirbhar Bharat. Jai Hind!
So, good morning, good afternoon, and good evening to all the viewers. I say this because in this program that we have viewers from almost 28 to 30 countries in various time zones across the globe. It is said that an eternal optimist seeks out the good and the best in some of the worst perplexing situations. This definitely holds true for the current scenario of COVID, which is a bad phase for humanity. But a definite good that has come out of it is the ability to stay globally connected and united with continued digital exchange of thought processes and academics. We've had some fantastic sessions in the past few months on myomectomy, anatomy, endometriosis, oncology, and last month on complications. So today I, Dr. Saumil Trivedi, welcome you to yet another unique webinar under this UPLIFT banner on the third eye in endoscopy. Now, what is this third eye? The third eye is a third-person perspective to what happens in your operating room. Sometimes we are so focused as surgeons with our surgical efforts, and especially in situations of complexity, there are sometimes a third eye perspective can open an altogether new avenue. So some of the best opinions are truly given by our beloved unbiased anesthesiologists who work with so many different consultants and colleagues from various fields. So today's session, that is the third eye in endoscopy, covers three facets, which changes the vantage point from which a person views essentially the same thing. First is endoscopy encounters from the eyes of the anesthetist. Second is what the two eyes of an endoscopist can miss, that is our energy sources. So how do they work? What are the mechanics behind their functioning? What complications can occur which can be missed? And last are our esteemed colleagues in other fields like gastrointestinal and vascular surgery, who sometimes help us through difficult pathologies and complications with true multidisciplinary approach. So coming to the first session, that is on anesthesia. So today, advanced therapeutic laparoscopy is performed routinely in every surgical field, be it general surgery, be it gynecology, urology, and developments in ENT, GI, and thoracic, etc. have really reached the zenith. At the very introductory part of laparoscopic surgery, irrespective of it being diagnostic or therapeutic, anesthetic considerations were much neglected, possibly due to the early intoxication amongst the surgical fraternity about the varied surgical possibilities. The surgeon failed to recognize the implications of insufflation hazards and to the various possible anesthesia-related complications. Possibly there was a faltered notion of not realizing that for excellent surgical result, anesthesia brilliance is as much of need. So before I introduce the first speaker for the first session, this dialogue from the movie Bagban is really stuck in my head. Even though in the movie it was addressed by Amitabh Bachchan to Hema Malini, I feel it is really apt for our anesthesiologists. It goes something like this. तुम हो तो हम है तो सब है, तुम नहीं तो कुछ नहीं, कुछ भी नहीं. So on this note, without any further ado, let me introduce the first speaker of the session, that is Dr. Parna Thakkar. Dr. Parna Thakkar is a senior consultant in anesthesia. She is currently affiliated with Sir H.N. Reliance Foundation Hospital, Mumbai. Her major achievements and honors include fellowship in critical care postdoctoral fellowship, neuroanesthesia research from Ohio State University in the United States, special training in liver transplant, bariatric anesthesia, peripheral nerve blocks, and labor analgesia. She has to her credit numerous publications, national and international, and has presented numerous lectures and presentations in various parts of India. So without any further delay, let me hand over the podium to Dr. Parna Thakkar, who will be speaking to us on anesthesia in endoscopy is a different ball game. Thank you.
Share screen.
Ask them.
Yeah, just 1 minute. Yeah. Yeah. Am I seen? Am I audible?
Yes, ma'am, absolutely.
Okay. Yeah. Good afternoon, all. Greetings from Department of Anesthesia, Sir H.N. Reliance Hospital. Anesthesia for endoscopic surgery, a different ball game. The dictionary meaning of the word is it's a different or it's a difficult situation. I would add one more word to it. I would say that anesthesia for endoscopic surgery is not only different and difficult, but also it is very demanding. Let's see how. What is different about this surgery? Creation of pneumoperitoneum, use of carbon dioxide, various positions and extremes of position during the surgery, use of injection vasopressin and glycine. What makes it difficult? So an obese patient or a patient with previous history of surgery can make surgical dissection difficult. Also, patient with pre-existing heart and lung conditions can make anesthesia management difficult. Why demanding? Because hypertension is absolute no. Normotension is advocated. Hypotensive anesthesia is required by some surgeons. Adequate relaxation is required all through the surgery. Now, one has to be very, very sure before handing over this patient to the surgeon and before starting the surgery that everything is in place. So make sure that everything is working, everything is in place. Go through your surgical safety checklist, double check everything, because once the surgery is started, like in robotic surgery, there's very little change that you can make like in robotic surgery. A demanding surgeon can sometimes make the surgery more demanding. And also there are lots of challenges to face during the surgery, and that is why the surgery becomes more demanding. So let's see what are the challenges that we can face during these surgeries. Let's take few examples. A 45-year-old female patient with no comorbidities is posted for lap hysterectomy. The surgery was started half an hour back, and suddenly there is a number of 85 showing on the screen, and the saturation has dropped from pre-induction of 98% now to 75%. And I was called urgently from the other OT, and I saw that patient was in steep Trendelenburg position. Another example, 26-year-old obese patient with BMI of 30 and multiple fibroids is posted for lap myomectomy. Vasopressin is injected, and very soon after that, the sudden bradycardia, BP is not recordable, the pulse is hardly palpable, saturation is not recordable, and patient looks very pale. Now, these are the times of difficulties and challenges during laparoscopic surgery where all the three eyes should be seeing what they are supposed to see, and also everybody from the surgical team, not only the anesthesiologist, not only the surgeon, but everybody in the OT should be on the same page to tackle these emergencies. And that is why anesthesia for endoscopy is very demanding and challenging. Laparoscopic surgeries have come a very long way. They've become very, very popular, and they have almost replaced the open surgeries. That's because of the benefits that they offer. So what are the benefits or the advantages that they offer? Small incision, less tissue handling, less blood loss during the surgery, hence less post-op pain and faster recovery, less morbidity, and early discharge from the hospital. ERAS protocols, that is enhanced recovery after surgery protocols, also highly recommend laparoscopic surgery. Also, because the patients can be discharged home soon after the surgery, laparoscopic surgery has become very, very relevant during COVID pandemic. Now, whenever a patient is subjected to surgery, the surgical trauma induces surgical stress response. There is neuroendocrine, metabolic, immunological, and hematological response to this surgical stress response. Now, these are the various stress stimuli that the patient experiences during the surgery, during or before or after the surgery. Now, this is the list of all these stress stimuli: starvation, dehydration, hypoxemia, anesthesia, systemic inflammation, opioids, blood transfusion, blood loss, tissue injury. Anything that's abnormal will result in stress response. It will result in catecholamine surge, and it will result in insulin resistance and catecholamine release. Now, in laparoscopic surgery, apart from all these stimuli that the patient experiences during a routine surgery, there are added noxious stimuli. And these noxious stimuli are abdominal inflation, positioning of the patient, and injection of vasopressin. Now, let's see how body reacts to these noxious stimuli. So, what happens? Yeah. So, this is pneumoperitoneum. So what happens during pneumoperitoneum? So the normal intra-abdominal intra-abdominal pressure is 0 to 5 millimeters of mercury. Now when pneumoperitoneum is created, that time there is compression of aorta, which results in increased systemic vascular resistance, and that increases the blood pressure. Compression of IVC reduces the venous drainage to the heart, and it reduces the cardiac output. There is compression of the renal artery, which reduces the blood supply to the kidneys, and hence the urine output drops. There is compression of renal veins, which also results in venous congestion, and that stimulates the renin, angiotensin, aldosterone axis, and there is release of vasopressin and urine output drops. Also, because of pneumoperitoneum, there is sudden stretching of the peritoneum, which can result in vagal stimulation, and the heart rate can either increase or it can drop. Because of pneumoperitoneum, there is upward shift of the diaphragm. So this is the resting position of the diaphragm in supine position. Once general anesthesia and muscle relaxants are given, the diaphragm moves upwards, and it moves further up after pneumoperitoneum, and it goes even further up after lithotomy position. So now diaphragm is completely pushing the lungs, and that is why there is reduction in the tidal volume, minute volume, and FRC of the patient. Also now, because diaphragm is pushing the lungs so much, there is rise in the intrathoracic pressure, which can increase the airway pressure. Now more pressure is required to ventilate the lungs, and this can make the lungs prone to barotrauma. Also, because the diaphragm is pushing the lungs, there is VQ mismatch, the lower alveoli collapse, and it results in atelectasis and hypoxia. The diaphragm at 15 millimeters of intra-abdominal pressure and in Trendelenburg position experiences a pressure of about 50 kgs. So you can imagine with pneumoperitoneum how much of the pressure the diaphragm experiences. Now also because of carbon dioxide insufflation, there is rise in the PaCO2, that is the arterial carbon dioxide. PaCO2 starts rising, and that is reflected by the end tidal carbon dioxide. So For after 15 to 30 minutes after carbon dioxide insufflation, the EtCO2 plateaus, PaCO2 plateaus, and if there is any change or any increase in the EtCO2 thereafter, we need to search for a cause. Now, as the PaCO2 plateaus after 30 minutes, there is no further increase in PaCO2, and we have to make changes in the ventilation, and alveolar ventilation has to be increased by 10 to 25% to keep the PaCO2 under control. Now, with the cephalid displacement of the diaphragm, there is um, the carina is also pushed up, and it can result in endobronchial intubation. When the abdominal pressure increases, even the esophageal pressure increases, and patients become more prone to gastric aspiration. Now, with induction of pneumoperitoneum and with head-low position, the venous drainage from the central nervous system decreases, and this can result in raised intracranial pressure if the surgery is prolonged. Also, because of hypercarbia and carbon dioxide insufflation, there is vasodilatation of the cerebral blood vessels. Now, if the surgery is prolonged, then that will result in cerebral edema. And during the surgery, our aim is to maintain the end tidal carbon dioxide between 35 to 40 millimeters of mercury, maintain normocapnia, and make ventilatory adjustment. Now, if cerebral edema is already set in, if the surgery is got extended, then a patient will have temporary neurological dysfunction at emergence. Now, effects of kidney, we've already seen that when the intra-abdominal pressure is more than 15 millimeters of mercury, the GFR reduces by 25%, and there is decrease in the urine output. Now, anesthesiologists have to be very, very careful while giving IV fluids at this time. IV fluid should be given very carefully, as it can result in volume overload. Now, with pneumoperitoneum, the splanchnic blood flow also reduces, and the liver blood flow also reduces, and that results in acidosis. Now, pneumoperitoneum, it affects almost all the organs in the body, and similarly, carbon dioxide insufflation and resulting hypercarbia also has effects on almost all the systems of the body. In the lungs, it increases the peripheral vascular resistance, and it increases the pulmonary artery pressure. It makes heart more prone to arrhythmias, and myocardial depression can occur. Also, the hemoglobin affinity for oxygen is also altered due to hypercarbia. And as I told you earlier, if the patient is hypercarbic at extubation, there may be temporary neurological dysfunction, or patient may remain very drowsy after the surgery. Role of anesthesiologists during pneumoperitoneum and carbon dioxide insufflation is to blunt the response of the body to pneumoperitoneum and to prevent adverse effects of hypercarbia. Now, anesthesiologist plays a very, very important role during this phase. And as a peri-operative physician, the role of anesthesiologist is not limited only to the intra-op period, but also the role of anesthesiologist should be extended to pre-op and the post-op period. In pre-operative period, the anesthesiologist should also be involved in patient selection and optimization of the medical conditions. ERAS protocols highly recommend optimization of the patient before admission to the hospital. Patient selection. Laparoscopic surgery is best avoided in patients with raised ICP, patients with right to left shunt. It is also relative contraindication in patients with poor cardiac function, severe valvular heart disease, severe respiratory disease, and severe chronic kidney disease. How is the pre-optimization done? So, if relevant in female patients, patients are asked to stop smoking and alcohol 4 weeks prior to the surgery. If that is not possible, at least few days before the surgery also will help. Patients are started on physiotherapy, breathing exercises are started, medical optimization of the condition like diabetes, blood pressure, anemia, and obstructive sleep apnea is done. Also, breathing exercises started. Obese patients are advised to lose weight, and dietary modifications can be done. Undergoing a surgery is like running a marathon. How we prepare ourselves before marathon, similarly, we have to prepare the patient. So dietary modifications have to be done, dietary deficiencies have to be corrected, weight loss in obese patient, and also physiotherapy. So once the patients are optimized and optimized medically, after that only they are admitted to the hospital, so that the hospital stay reduces after the surgery. Also, beta blockers can be started in patients with history of myocardial infarction. This reduces the catecholamine response to the surgery. Beta blockers are started 1 week prior to the surgery. Alpha-2 agonists like clonidine can be started, but they cause sedation. Paracetamol, NSAIDs, and steroids, when given just before the surgery or the prior day of the surgery, can reduce the intra-op requirement of opioids. As we discussed earlier, the incidence of ischemic heart disease, fortunately, after laparoscopic surgery is less, 0.3 to 0.6% in patients with IHD. So incidence of myocardial infarction is less, but we have to optimize the patients with beta blockers. Patients with COPD also have to be optimized with bronchodilators and steroids. Also, a point to be noted here is they may have baseline hypercarbia. So carbon dioxide insufflation and pneumoperitoneum, they may not be able to tolerate. So that has to be kept in mind before you start the surgery, and you should be ready to convert into open surgery whenever required. Now, morbidly obese patient, they have already pre-existing intra-abdominal pressure is high, so they tolerate pneumoperitoneum better, but they are a big challenge as far as the ventilation of the patient is concerned during the intra-op period. Now, the best pre-medication that can be given to the patient is patient education, and ERAS protocol highly recommend that. Now, once the patient is admitted to the hospital, spend enough time with the patient, answer all their queries, explain them about the type of anesthesia, regional, general, post-op ICU, pain control, everything. Talking to the patient decreases the anxiety and fears. They experience less post-operative nausea, vomiting after surgery, and less pain after the surgery, and the overall well-being of the patient improves, and we can discharge the patients early. Avoid fasting longer than 6 hours. Why? Because fasting results in dehydration, and that because of that, during pneumoperitoneum, they experience lot of changes in the systemic vascular resistance. Also, antacids and antibiotics can be given 30 to 60 minutes prior to the surgery. ERAS protocol also recommend carbohydrate loading with a clear carbohydrate solution, like in the form of fruit juice, clear fruit juice or something 2 hours prior to the surgery, but that may not be possible in Indian scenario. Also, antibiotics have to be repeated during the surgery if the surgery goes on for longer than 4 hours. DVT prophylaxis should be given in the form of either low molecular weight heparin or DVT stockings. Enema should be avoided whenever possible, because it results in dehydration and electrolyte disturbance. If enema is given, IV fluids can be started pre-operatively. Anesthetic management, pre-oxygenation is very, very important. Usual induction with opioid and propofol or etomidate is done. Shorter acting muscle relaxant may be preferred if you want to avoid ventilation and gastric distension. Now, endotracheal tube remains the gold standard for anesthesia for laparoscopic surgery, and fixing the tube at the black mark is very, very important to prevent endobronchial intubation during the surgery. Ryle's tube may be put if required, and use of nitrous oxide is controversial. Also, use of LMA is optional, but one has to decide. If it's a shorter surgery, maybe LMA can be put. Eyes should be padded and covered. One has to be very, very vigilant while positioning the patient. Stapping of the patient is very important when we are giving head load to the patient. Otherwise, the patient can slide down. Head should be kept in neutral position to avoid stretching of the brachial plexus. Lithotomy has to be given very carefully, and pressure points have to be padded and covered. Change in the leg position at regular interval also can be practiced if the surgical duration exceeds few hours. Now, before pneumoperitoneum, moderate fluid loading before pneumoperitoneum, slight head low position, and use of compression stocking or pneumatic compression device can maintain the venous return, and also it will maintain the cardiac output. So before pneumoperitoneum, if you've given moderate amount of fluid or slight head down, then that will really help to maintain the cardiac output. As you can see in this diagram, the one in the blue are the volume loaded patients, and they show less increase in systemic vascular resistance after pneumoperitoneum in laparoscopic surgery. Intraoperatively, dexmed infusion can be started to blunt the response to pneumoperitoneum. Also, beta blockers, anti-G infusion can be kept in mind. Slight hyperventilation before carbon dioxide insufflation is recommended to prevent hypercarbia thereafter. Intraoperative monitoring is very important, and it's an essential and integral part of the laparoscopic surgery. ECG, SpO2 and ETCO2 monitoring are the standard monitoring which should be done during laparoscopic surgery. Also, temperature monitoring should be done because patients are more prone to hypothermia, and warm fluids and warmer can be used. Urine output should be monitored all throughout the surgery. Hypothermia is very common, as we discussed. When vasopressin is being injected and when pneumoperitoneum is being created, that time be very vigilant and keep an eye on arrhythmia and ETCO2 vasopressin. Now, vasopressin is a vasoconstrictor, and it can reduce the blood loss mainly during lap myomectomy. The normal concentration of vasopressin that is used is 20 milligram 1 ml is diluted with 200 ml. But even the smallest dose can cause adverse effects, and generally at a time 40 to 60 ml is injected of this dilution, and if more is required, it can be repeated after 20 minutes. But we be very vigilant and be on lookout for bradycardia, heart blocks, and severe peripheral vasoconstriction and other adverse effects of vasopressin. The safe dose recommended is 2 to 6 units during the surgery. Dilution is also very important. Now, during ventilation, as we discussed earlier, during pneumoperitoneum, the ventilation has to be adjusted. As you can see here, the same tidal volume which is given before pneumoperitoneum is now creating more of peak pressures, and the end tidal carbon dioxide also has increased. So that is why pressure control ventilation is a preferred mode of ventilation, and when the patients are on volume control ventilation, the peak pressures and the plateau pressures are more. So pressure control ventilation is a preferred mode of ventilation to prevent barotrauma. Also, it is preferred in obese patient, and it improves oxygenation. Pressure control mode also can be given in a different way by PCV-VG mode, which is available in the newer machine. So that guarantees the volume per minute to the patient. So volume control will result in barotrauma, and pressure control reduces the risk of barotrauma. Also, PEEP of 4 to 5 centimeter is beneficial. It improves oxygen and can be added, but excessive PEEP can cause barotrauma. Post-operative nausea vomiting prophylaxis is very important because it can be very distressing and can delay the recovery and discharge. Dexamethasone is given at the start of the surgery, ondansetron 30 minutes before the reversal if the patient is more prone for post-op nausea vomiting and has other risk factors, then metoclopramide and droperidol also can be added. Now, the pain management has shifted from opioid-centered regimen to multimodal analgesia. So 2 or more non-opioid based medications are combined with the central or the peripheral nerve blocks. and this reduces the stress response to the surgery, and it reduces the requirement of the opioid, and hence the opioid related side effects like nausea, vomiting, and also if less opioids are given, it can promote early discharge. Low concentration of local anesthetic promotes early mobilization. So peripheral nerve blocks like TAB blocks before reversal can be combined with NSAIDs, COX-2 inhibitor, gabapentin, ketamine, lignocaine, steroids, and other drugs to practice low flow, to practice multimodal analgesia. Now, hysteroscopy. The glycine and sodium chloride are used most commonly for hysteroscopy. Glycine is used for for operative hysteroscopy when current is used. Goals of the anesthesia are keep a watch on intake output of the fluid when hysteroscopy is going on. A fluid deficit more than 1.2 to 1.5 should alert the anesthesiologist. Avoid low BP when resection is going on, because that will lead to more absorption of the fluid. Watch for hypertension and bradycardia because that indicates excess fluid absorption. Other complications are hyponatremia, electrolyte imbalance, and arrhythmias and overload pulmonary edema. Seizures occur due to hyponatremia, and because of glycine there can be visual disturbances in the post-op period. In post-op period, once a patient is extubated, early nutrition prevents ileus and reduces the IV fluid requirements and insulin resistance and improves muscle function. Early mobilization prevents pulmonary complications and reduces the incidence of DVT and improves muscle strength. Multimodal analgesia, as I told earlier, should be practiced. And the key take homes are: no monitors can replace a vigilant anesthesiologist, and implement ERAS protocols whenever possible. Happy Ganesh Chaturthi, and thank you very much to the organizers for giving me this opportunity. Thank you very much.
Thank you, Dr. Parna. That was really an excellent presentation, and you very clearly elucidated all the physiological changes that occur during complex laparoscopic surgeries. I'm sure there will be a ton of questions which the audience and even me have for you, and I request you to stay back. Moving ahead, I have the pleasure of inviting our next speaker. That is Dr. Vijay Shetty. Dr. Vijay Shetty is the head of anesthesia at Fortis Mulund in Mumbai. He has numerous publications, national and international, to his credit. He is currently the secretary of the Mumbai Anesthesiologists Society and executive member of the Indian College of Cardiac Anesthesia. He is a part of the team organizing the popular meeting, the MASCON, and a part of the team conducting the first successful heart transplant and heart-lung transplant in Western India, and has to his credit more than 100 plus cardiac transplants in under 4 years. So I invite Dr. Vijay Shetty, and he'll be speaking to us today on tricky encounters as an anesthetist in gynec endoscopy. Over to you, sir.
Thank you, Somil, for your kind introduction. I'll quickly go to my slides. Is this visible, Somil?
Yes, sir. Yeah.
So at the beginning, I'd like to thank Dr. Prakash and Dr. Somil Trivedi for giving this opportunity to speak. Thank you, Parna, for that excellent introduction to what anesthetists undergo when they are on the field of anesthesia while doing these cases. I would also like to thank the Minimal Access Society for doing this, because very often I used to think that there is no point in one discipline talking about one thing when it actually affects multiple disciplines and multiple people. So thank you once again for this opportunity. Hopefully we can take this ahead in the times to come. Well, my disclaimer is that I am an anesthetist. I am as simple as they come. I like my cup of coffee in between the cases. And whenever somebody speaks, usually you think that he's an expert on that. And I would like to say that I'm not an expert in creating complications, number one. And secondly is that even though as a HOD, I get to go into any OT that has complications. So I would have seen many complications across disciplines, but certainly I'm not an expert in creating them. I bring you greetings from Fortis Hospital, Mulund, where we have departments which take care of, anesthesia department take care of general and transplant work as well, including cardiac, liver, and so very proud of the heritage that we're building up there. But today endoscopy is seen in multiple fields, right from bariatric pregnancy, pediatric, cardiac surgery, thoracic surgery. But always the surgeons were not very happy to take it up. For example, when it came into minimal access, came into cardiac surgery, which is my bread and butter actually, he said that the surgeons have made the surgery more painful for the surgeon than the patient. Thankfully, gynecologists and other branches have stuck to it. And today, we are at the receiving end of a lot of complex work getting done by very well with the experience that we are building up. However, as Saumil said in the beginning and Aparna said after that, when endoscopy or any surgery advances, anesthesia has to keep up. So whenever we move ahead together as a team approach with surgeon, anesthesiologist, and the OT team too, the nurse and the technician as well, there are a number of newer anesthesia approaches that are available and that can be actually put to true good use in these complex situations. Minimal complications and rapid recovery is what we aim at. Whenever we build a minimal program, obviously we want to replicate or even make better whatever results we had with the open one. Many of our young surgeons would probably forget that surgery was done in an open way once upon a time. But what we need to remember that the surgical trespass, that when you go inside somebody's body, actually you're trespassing something. And that has to be balanced by excellent anesthesia for us to be able to give those results. This is how anesthesia started. This is how the first anesthesia was given, WTG Morton in 1857. And this is how the people were around and there was always a proximity. Later on, when we were training, we were taught to keep the hand on pulse and at all times. And if a senior walked in the OT and your hand was not on the pulse, you would be thrown out of the OT because that's strict. But now you can see the anesthetist is hardly touching the patient. He's far away, watching monitors which are indirectly telling what the patient is undergoing. And as a young anesthetist, again, young anesthetists also would have to be trained to keep a hand on pulse. And that is the difficulty that I am facing right now. But one thing is not changed, is that the longer it takes, the more the chances of complications. Irrespective of whatever, like today we are doing transplants or even big complex surgeries of big tumors which go on, or aortic surgeries go on for 12, 14, 16 hours even. But it's a given that if there's a standard time for an operation, that needs to be adhered to. And very often, young surgeons especially, they try to stick to this timing and try to hurry up. And the only thing that can make you hurry, like one of my favorite statements is that if you want to go fast, you need to go slow first, because slow is smooth and smooth is fast. So being smooth is probably much important than being faster. And that is one thing that I want to convey for any young surgeons. And most of my things that I'm saying is to address to young anesthetists and young surgeons only. That you need to be experienced and you can't become a great surgeon before first becoming a good one. And if it takes time, but then don't make complications as you go along. However, for a standard surgery, if anything, for a standard procedures, that is standard timing. And the surgeries that take longer time are expected to have more complications. So let's begin with the Trendelenburg position. This is how the original Trendelenburg was. Assistant used to hang this patient upside down with his knees at the level of the assistant's ears. And this has got number of changes that Parna has already talked about. And about passive regurgitation that she talked, I just like to mention that now, because of the ERAS protocol, many centers are actually giving the fluid, and they're even evaluating whether the gastric emptying is good. Prolonged fasting, it seems, is actually, if you keep a patient fasting for 8-12 hours, maybe many busy gynec surgeons and obstetrics, gynec and lab surgeons, I know that the people are waiting in remote centers and they're going to come with the car with all the equipment and all, and the patient is fasting for 12-14 hours. What happens in that duration is that there is buildup of the gastric acid in the stomach, and actually the patient has got much more volume than if you had fed him, he would have less volume. So it is important not to keep the patient fasting for that long, and it's also very clear that prolonged fasting is going to cause much worse. Your glycogen stores are going to come down. The patient is going to be much worse shape. So especially if it's a major surgery, please make sure that the patient has got optimum fasting, and you could certainly allow some water to go in at least up to 2 hours prior in most of the scenarios. There is a repositioning checklist that I like to have, and I run it through mentally. But just like the WHO work checklist, as we go ahead and as we give more and more complex positions, we need to make sure that this checklist is adhered to every time. There has to be somebody in the OT who's taking care of this, or multiple people taking care of at least something that belongs to them. So I think the best person to take this checklist would be the anesthetist, because that is always believed that the most important jobs about patient safety get attested by the anesthetist. So I would say this, for example, the airway. If I say, if his ET tube or LME is properly positioned, I need to know whether the ventilation, that is the ability to remove the CO2, is good enough, whether his oxygenation is good enough. Have I auscultated? Is the adequate monitoring available for the risk that the case entails? Circulation, whether I'm monitoring the patient enough, all my lines are enough, and whether they're accessible. Disability check. Remember, however well your operation goes, at the end of it, if we gave a patient a new problem, it is as good as it would have better not to operate, having operated. This part has to be always be with us, that first we should aim to do no harm. And there are standard protocols that are to be followed, like your protection of the eyes or neurovascular bundles, make sure there is not passive extension. Often you're given a good position. Sometimes the hands are outside, like in some lab surgeries. And by the end of the surgery, you realize that the surgeon has pushed the arm board so high. It's nothing to do that he's done it on purpose. With the aim to get a better view and a better position to do the procedures, slowly the hand starts coming up, and by the end of the surgery, you realize that the patient has been hyperextended, and you start worrying whether he's going to have any neurological deficit at the end of the case. Exposure means whatever monitoring we are doing, it should not be in the surgical field. Your ECGs and everything else should be out, because there is a risk of damage and also a risk of burns that can happen with that. I am always happy to do any surgery where the face is accessible. That's the minimum I expect. But because of the newer influx of the robotic surgeries or other major surgeries, the face accessibility remains a problem. Parna just mentioned about the tracheal length. This is one thing I want everybody in the OT to understand, not only the anesthetic but the gynecologist as well. You can see, this is from the article, The Tracheal Accordion by Haraway. He said that anytime you do assume the supine position, you paralyze the diaphragm, which we do when we do the GA. You paralyze the head and the extensor muscles, which again comes once you give muscle relaxation. The Trendelenburg position and the pneumoperitoneum. All these are requisites of a case under GA for lap. You are shortening the tracheal length. The trachea gets shortened between the vocal cords and the sternal notch, which is from the vocal cord to the sternal notch. This is which gets shortened. And this chart shows that if we add up all of these, it can get shortened even up to 2 to 2.5 centimeters. That means if it is the tube edge is just within 1.5 centimeters of the carina. By doing this in a certain patient, it can shift to one side. That means we'll be searching for reasons why we will be thinking that the Trendelenburg or the pneumoperitoneum is causing the problem, but actually it would be endotracheal tube which has gone in. This is one thing that I always would like to remind myself as the first thing to check if the apparatus is working well. This is one thing that so being too high is not too good, because obviously the cuff would be at the level of cords. Being too low is also not good, because you're going to go endobronchial. So in a patient like this, I would certainly, if available, I would like to put in a fibrotic bronchoscope and check that I get a view like this, sufficiently away. This is the left and the right bronchus good looking at me as I exit the endotracheal tube. So this would be one of the reasons. This, you can see the tube is too high. The cuff has come to the level of the vocal cords. In this case, the surgery would happen uneventful, but at the end, the patient would not have his voice for maybe for about 2 months even. So this is something that needs to be avoided, too much out or too much in. So in these cases like this, I just like to remind our surgical colleagues that we have our own endoscopes too, and let us use them whenever we can. The lesson that I want to give here is that take time to position, especially in obese and fragile patients. One more message I would like to give, I see nowadays, is that our students or in gynecology or surgery, they take no interest in when the position is given. In our time, it was very important. In fact, there were not too much help to give the position. So all of us were involved in giving the position. But now the young anesthetists and young surgeons have to remind themselves that unless we learn to give a good position, one, we're not going to get a good exposure. And number two, we are going to expose the patient to the problems that a difficult and abnormal position is going to give. And thirdly, if you're somebody who enjoys surgery or who loves surgery, and the OT is your karma bhumi where you want to perform great work, remember that if this does not happen, there's a lot of surgical discomfort or distress, which is also known as oozing in surgical terms, and because of improper positioning and inadequate management of effects. So give your anesthetist time so that he or she can sort it out. Lung compliance was spoken to by Parna, but in simple terms, if say example abdomen is poorly compliant, that means you push 2 liters, 3 liters, and the airway pressure goes high. Similarly, in poor lungs, or less compliant lungs, like in obese patients and otherwise, you will have difficulty in ventilation, and this would have number of adverse effects. That's why in a patient who's got COPD and other things, often we are trying to do surgeries under regional anesthesia, because it might be difficult to detect it. The compliance is now easily available. A lot of simple monitors even have this loop that Parna showed. This I would urge all anesthetists to make sure that they calculate the compliance and see how the compliance is affected with each surgery, with each position in all the patients. So this is articles which tell about protective mechanical ventilation in obese patient, and we would like to see that some of these is implemented in our patients. Like all anesthetists know about protective lung ventilation. It is the challenge about giving this protective lung ventilation in patients when they're undergoing a lap surgery in a supine. So if you do all these maneuvers and you're unsuccessful, what is the problem? If it is a short surgery, you might get away without any problem. But if it is prolonging, these effects build up. There's risk of hypoxemia. There is increased CO2, which effects already have been told. There is more oozing, and BP and heart rate also will go up. That's why it leads to more. There is a pharmacological misadventure. For example, if my endotracheal tube is inside and I fail to realize that, or my intraabdominal pressure is too high and I fail to warn the surgeon, I will try out different things like beta blockers or excess Dexam or a deep plane of anesthesia, each of which comes with their own set of complications. There are very simple things to do to first make sure that there is a requirement of giving those drugs. In the absence of that, we should refrain from giving drugs which we normally don't give. If it's a part of the protocol, that's fine. Otherwise, always take a step after making sure that the previous steps have been done properly. What are the kind of interventions that I have done when I face with tricky situations? I've done the tube adjustment using video laryngoscope after the final positioning has been given, after the head load and everything has been given. The bronchoscope positioning in difficult cases, I have already said. There are multiple causes of light anesthesia. I think any anesthetist will say that every other day there will be some problem with the disconnection, with empty vaporizers because the inhalation does not go, poor quality drugs which does not act, meaning you assume that the patient is relaxed and actually the drug atracurium has not worked at all, and you are trying to figure out why the patient's internal pressure is high, why the compliance is low, because you are not relaxed the patient adequately. Without adequate relaxation, irrespective of the ventilation mode, you are not being able to give a proper pressure control or volume controlled ventilation. Then there is interaction between technical issues in surgery and ventilation. For example, if you got poor quality equipment and the trocars are leaking, or the surgical site is the incision is too big and there is continuous leakage whenever you're passing an instrument, or whenever something happens and there's a great amount of leak happening, there are frequent ups and downs with the intra-abdominal pressure. And this will lead to frequent ups and downs as far as the tidal volume is concerned. For example, the tidal volume will go from 300 to straight away to 600, 700, 800, even more. Excuse me. So this is not good for the lung, and it is not good for the patient either. So there are extremes of head load that is given. For example, this is as the beginning of the robotic before just do the trials, and this is the feet here, and you can see the amount of head load that is getting. Dr. Trivedi asked me to especially mention that this kind of head load is actually you get very envious after seeing this kind of head load. But thankfully, all our gynec and surgeons are very, very much flexible and willing to adjust and compromise to make sure that the patient doesn't get too much of a head load. This is sort of a very good head load for a prostate surgery, and this is extreme head load. This is the head end, and that is the feet end, and you can make out the extreme level that is being had. But these kind of positions actually make us confident about giving head load in difficult situations also. So again, a young surgeon might be thinking that giving CO2 is like anything, because CO2 anyway we are producing. What's the harm in giving CO2 in the abdomen? However, CO2 has got multiple effects. Stress was already spoken about by Parna. Pain. You have higher abdominal pressure, you have more pain, you have more nerve damages, you have more reperfusion injuries, more chances of hypothermia, and more ECG changes. So if a patient is precariously balanced, it will always be a good idea to give less CO2. And one more thing is that there are multiple things that is about the end-tidal carbon dioxide. Many of us think of it as a monitor. For me, it is one of the indispensable monitor for any surgery. Forget laparoscopy, for any surgery that a GA has been given. So you can see much other than the blood, there are multiple things which are headed towards the heart and the lungs, including tumor cells, amniotic fluid, fat cells, foreign material, hydrated cells, air, CO2, which is what we are talking about today. And it would be pertinent that every surgeon should know how a normal EtCO2 trace looks like. So whenever you look up in your surgery from tomorrow onwards, you look at the heart rate and the BP and say, okay, everything is okay, and look down. Always have the third eye for yourself and look at the CO2 too. You'll find a good trace like this, you'll be happy, and you see a value of 25, 30, 35, 40, that's fine. But you see that it is dropping, then it represents that there is a problem. So this can happen when there is a pulmonary embolism or EtCO2 embolism or a carbon dioxide embolism. You can have this. This is when you are injecting CO2 directly into the bloodstream, but it is not cause a block, but it is high amounts of CO2 is going into the blood or getting absorbed. You see that typically very high CO2 happening, and what is normal after CO2 has gone very high, that means you're obviously giving too high amounts of CO2. So the challenge for the anesthetist remains, how do I maintain normocapnia, that is a normal carbon dioxide, avoid hypoxia, that is maintain a good oxygen without having high airway pressures, because that is going to charge the lungs or causing more and more barotrauma and poor lung effects on pulmonary effects on the lung. So I need to avoid this. So my job is to make sure that the surgeon gets a good platform to perform, but at the same time, it is that the lungs have to be protected well. And this I cannot do on my own. I require good backup, require good support and communication with the surgeon. So I will have to see when the surgeon starts, he has to be careful to start with the low flows and low pressures. So I'll watch the CO2, and even he will watch the CO2 from tomorrow onwards. And if the CO2 will rise quickly, then he will say, okay, something is wrong, and let me just go slowly, or let's see what is happening. So the anesthetist will increase immediate ventilation, like already been spoken about. And the compliance of the lung is also affected, because as you keep increasing the CO2, the more splinting of the diaphragm happens, and the compliance is going to go down. So I would request surgeons to ask, are you okay? All my senior surgeons used to ask me, are you okay? Everything is okay. Maybe they were too scared about anesthesia or anesthetists themselves, or they must be seeing a new face. I used to think such gentlemen they are, or the madam is very good. But now we don't expect, because everybody thinks that he knows his job. Like how Azhar used to say, every boy of my team knows my job, and so on. So we know our jobs, but it's always good to have a communication. Are you okay? Somebody might be having a bad day. Somebody might be paying attention. Let them start doing that. Okay. Again, there are factors affecting CO2. That's why CO2 is the absolute must-have monitor. If you ask me to choose between pulse oximeter and EtCO2, I will choose EtCO2 any day, because the pulse oximeter just tells you that okay, everything is okay, but EtCO2 tells you you're okay and that you're going to be okay, and there is nothing acutely harming the patient. So even if you don't ventilate the patient for 3 minutes, you will have a very good saturation. But the second you stop ventilating the patient, the EtCO2 will fall, or it will become zero. So you know that there are multiple situations, as you can see, where the EtCO2 can help you of elevated and reduced. One of the conditions that you mentioned, Parna mentioned about intravenous vasopressin injection. I'll not go into that. She described what happens there. But there is no BP, there is no pulse oximeter trace. All around there is panic. And you look at the EtCO2 and you find that EtCO2 is coming. You know that it is a vasopressin injection. There is pulmonary perfusion still going on. The patient is alive and there is a ejection going on. And then you can go and start treating the condition. So any panic in the OT, look at the EtCO2. You see a EtCO2 happening, that means that there is still hope. So spontaneous pneumothorax is what is one worrying. This is one condition. This is a rare complication laparoscopic college sister with one article. I've had multiple cases like this with small amount. You can say small sliver of air. This is the pleural. This is the lung line. The pleural line is this is the air here. You can say small. This is a small pneumo which will not have much problems. However, there are few patients. Very rarely you might get patients who got diaphragmatic openings which are congenital, and their divarications which are present, like this foramen of Bogner left and right, foramen of Magnani, and also along the great vessels, the cava or the aorta or the esophagus, where they enter the abdomen. There around those also the CO2 that you're insufflating at high pressure can get in. It can also get into the tissues around, and it can lead to surgical emphysema. You can see example of surgical emphysema here by the side. This also is common, not uncommon, and often they go high up to the neck and sometimes cause difficulty in breathing as well. This is an interesting case which I picked up from the net. It showed that initially after the surgery, the patient had only surgical emphysema, like you can see here. But subsequently, this air has now breached into the pleura and caused pneumothorax. So it is not a lung injury. It is this air which is so much of tension in the tissue that it has caused a pneumothorax. And this was something that happens rarely, but it can happen. So what can go wrong in the OT? It can go wrong what can go wrong is that as an anesthetist, I decide that everything that needs treatment is going to be done by me, and I am responsible, so I will do all by myself. The surgeon decides that I am going to focus on enjoy my surgery. Let the anesthetist do his job because he is responsible for primary well-being of the patient. And the communication between the two happens only when the problem is at its peak. This is not the kind of team that I would like to work in. And some friendly advice to surgical friends that I talk, I smile, I laugh, but be careful when I'm silent means I have a problem. So ask, are you okay? So one of the classic cases that is taught to all anesthetists is Ellen Bromley's unanticipated difficult airway. I won't run through the case, but what happened was it was a standard intubation for a patient who got some cervical spine issues, but it was supposed to be acceptable. And they put in the LMA, they're not able to put the LMA, they continue to try to intubate repeatedly. And subsequently, the patient had a brain injury and she succumbed. And they realized that there were other options like tracheostomy available, or even the post-op did not take proper care. The evaluation said there was a lot of loss of situational awareness. The stressful situation becomes so big that the anesthetist got focusing on putting the tube. Whereas now we are taught that we are supposed to oxygenate. The intubation can happen, but ensure the patient gets oxygenated. So you find the anesthetist struggling for intubation, it is a good idea to remind him, or just put a nasal prongs, give high flow oxygen, just maintain the oxygenation, and the oxygenation has to be going in. The ventilation is not going to save the intubation is not going to save the day. The oxygenation is going to save. So this tunnel vision has to be avoided. And I can give and if you look back at your problems, you will realize you have also got stuck in these kinds of situational unawareness where it was not possible. What we imagine is from the last 6 or 7 decades, I've got so many instruments. So no, of course I have become better. But we all know that increased technology does not mean that there is increased situational awareness. Actually, there is more distractions now in the operation theater than awareness. And we all think that the monitor is monitoring the patient, but the responsibility of the anesthetist and the surgeon to monitor those monitors is forgotten very quickly. So a monitor won't make a patient safe. It is a person behind the monitor or in front of it who's going to be keeping it safe. I had one case like this, a laparoscopic adrenalectomy, where the IVC was torn and we had to open and repair it. It went off quite well. There is a case from China similarly, where the ETCO2 fell from 40 to 15 with the IVC tear, and they decided to go ahead and repair it. They said that the intra-abdominal pressure, high intra-abdominal pressure was sort of sealing the rent to some extent, and they went ahead and repaired it laparoscopically, which was very brave of theirs. And in that transvagal echo with the past, you can see this how it looks. The right atrium and the right ventricle, this is a septum. There's nothing here, there's blood going. But at that time, you can see so much of air going through that. So they tolerated this ventilation, the ETCO, so CO2 embolization, and managed the case. But sudden hypotension is obviously very dangerous. So if you ever have to have a venous embolism and the venous air embolism, what are the things that you do? Most of our patients are already on head low, so that is good. You can give the left lateral decubitus or Durant's position. We have to prevent further entrainment of air. You stop the CO2. That means stop the surgery, just deflate the stomach. You can put in water or just put some mops on the rent if possible. Get your inotrope vesipressor ready because the pressure is going to go down. So you need to be preparing your noradrenaline and adrenaline. You have to remove the gas. We have already done that. And if you have a central line, then you can start aspirating. Now these situations might be rare in lab, but we face such situations in sitting up surgeries or in patients in other surgeries where the patient is the heart is at a higher level, and there can be a aspiration of the air into the heart. Interesting to note that you might be thinking that I am using very low pressures and I am a safe surgeon, but air embolism happens all the while. Depends on how sensitive is your monitor. For example, if I were to use a transvisible echo, which I'm using for all my cardiac patients, if I use it for your lap hysterectomies, every patient, according to Kim, 40 out of 40 patients had some amount of CO2 embolism happening. So he graded as 1, 2, 3, 4, depending on the number of bubbles and how severe they were. And he found that during the dissection of the broad ligament and the round ligament, the more of the venous air embolism was happening. Maybe it's something that you could take care of. Now, traditionally or normally, this much of air or venous or CO2 embolism won't make a difference. However, the patient had a foramen ovale or an opening between the left and the right atrium, which is normally also present in quite a few patients, and they don't have it, which is called, we can lead to paradoxical air embolism. Air from the right side is not supposed to go to the left side, but blood from the left side can come to the right side through the patent foramen ovale, because the left atrial pressure is usually higher. But when the patient goes to laparoscopy and the right atrial pressure goes high, sometimes there can be reversal of shunt, and with the shunt or with the blood, even the air can go. You can see here there is no air going to the left side. Why are we protecting left side? Because it is from the left side that the air can go to the brain and cause a stroke, can cause a renal ischemia, or can cause a cardiac ischemia from the coronary event. So your lungs will hold all those air and will not let it go to the left side. In the absence of that, if a patent foramen ovale is there with the right to left shunt allowed, then the patient, you can see the bubbles have now come to the left side. They've gone to the lungs, but some of them has escaped to the left side. This patient is at a high risk of a stroke. Temperature management, I'll not go much, but we have a number of options of managing the temperature. But first, in many theaters, I know that temperature has not been monitored. It is a requirement for by our standards. But any surgery will last more than 2 hours. The anesthetist should try to get some amount of temperature monitoring yet, just to understand what happens when the patient is under prolonged anesthesia, and just to know that we are not doing enough to make sure the patient is. So you might do a wonderful surgery, but the patient wakes up shivering and cold and a lot of other problems that Parna mentioned. All these things can be avoided by simple monitoring the temperature. You can't warm the patient suddenly like a chapati. You can't do that. You have to prevent the loss of temperature right from the very beginning and ensure that the temperature is maintained. These are the kind of cases that I have done with my team of talented surgeons. They're obese patients, they're fragile septic patients, low ejection patients, significant valvular disease, LVOT and pulmonary diseases. All these patients have undergone laparoscopy surgeries, major ones with the good outcomes. I'm not saying that this is because of because of the individual that I am. It is because of the team and because of the monitoring that is facilitated and because of the constant communications and the preoperative assessment and planning that was done. That is very important. That when you have a difficult situation, don't take it on your head. Involve 2 or 3 people. Let them also share your headaches, and then you go ahead confidently. This picture was shown by Parna also. The dangers of lithotomy. This is only a 90-minute procedure. Still, it ended up with the bilateral lower extremity compartment syndrome because this is a very good Allen's syrup. I think many of you might be having that. They give excellent support in spite of the best equipment, in spite of having DVT compression devices. This lady ended up with a very high. So just even if you just tightly tie the calves, for some example, or new technician has come or union brace. That's what I was reminding you again. That whenever the position is given, the surgeon and the anesthetist have to take special interest in that, because your surgery might go off well, the patient ends up with a fasciotomy, not a good scene. So a lot of times keeping the legs very high or abnormal positioning can cause it. This obviously we're not interested in this particular webinar as such, but this we need to watch out. Another thing that is about the fluid overload in hysteroscopies. We know that nothing is safe. Any fluid that you give can cause a problem. It depends upon the irrigation pressure and the venous pressure. Like Parna mentioned, if you've got hypertension, again, there is a high amount of risk that the patient runs. So electrolyte free hypertension solution, glycine mannitol, they're not used much now, but they can lead to dilutional hyponatremia. But even when you use normal saline, it can cause fluid overload and a lot of problems for the patients. For example, this is one of my typical post-TURP 90-minute procedure. He had some difficulty in breathing. I did the X-ray. There's an X-ray chest, so it's edema. He's got low PO2, but PO2 is low, but his sodium is still okay. Right? But this is what happens in Ohio syndrome, or the gynecologists were not happy with the term of a female TURP syndrome, so they decided to have a separate name. I'm sure you know that better than me. Operative hysteroscopic intravascular absorption syndrome. This is a 36-year-old patient in whom glycine was used, and there was a delayed awakening, the swelling of the face. And this was at a significant high pressure. It was injected, the glycine 1.5%. And you can see the difference between the previous one and this one. The PO2 is okay. Those using edema, the PO2 is okay, but the sodium has gone significantly low. So they have suggested various other monitors, including the parotid area sign, which is a study done by Dr. Sinha and team, good friends. And number of other reports are coming all the time. This report has told us how to treat it. Normally, I would be very scared of treating, doing a rapid correction. In this study, they have advised that you can do a rapid correction of the sodium. Why are we worried about sodium? Because it's got numerous side effects, right from the heart to the sensorium, convulsions, and so on and so forth. And it's got a very poor prognosis if you don't correct it early. But if you correct it too rapid, it can go to central pontine myelinolysis, which is again irreversible condition. So this team has corrected the sodium, which has fallen down to 74. And it got it within 8 hours. They got it up to 120. They said they have encouraged rapid correction. This is acute hyponatremia. You could correct it. So I just like to end with one intra-op catastrophe of a lap pelvic surgery in a thin female, no comorbidities, excellent experienced surgeon. The central line was there for post-operative indication. And here I want to remind, just to watch the screens. This is around a 12-second interval. The surgery started off with the pulse rate of 70. With the ETCO of 26, BP of 120 by 60 or so. You can see this is within 12-second interval that ETCO is okay. Here is 20. When the trocar went in and the ETCO, the carbon dioxide insufflation was started. You can see every 6 seconds this is falling by 2, 24, 20, and then it becomes 17, 15, 14. This is a 12-second interval. And what happens? Heart rate, sudden tachycardia. The BP was once recorded as good, and subsequently it fell. And if you see a 1 minute record, you can see that this is how the CO2 has fallen, the ETCO2 has fallen. That's why we give great regard. And more than anybody, I can credit the anesthetist for picking this up right the moment it happened, informing the surgeon, who stopped and seeing the blood that is coming out open, and there was an aortic injury which was salvaged out. And here you can see it remained low for quite some time. The arterial line was put subsequently because we need to monitor this patient even. So the pressure was applied after opening, arterial line was put, supports were started for persistent hypotension. The HB had fallen down from 12 to 3 and then to 2 even. So the ventilation, the ventilation was quite good. The oxygenation CO2 was quite good. There was not a problem at all. Even the lactates were good because we achieved significant early control of the bleeding, and then we had to just to salvage the situation. There was a rent in the part where the aorta divides, or the division of the aorta. The iliac was sutured again. Patient had excellent outcome, was extubated the next day. But that is not all that goes on. See, once the perfusion is started, you can see here that the BP was quite good, and as soon as the limb is released, there is a reperfusion. The ischemic limb blood might come back to circulation, and you can see how the blood pressure falls. These are all challenges that we need to be awake. Though the surgery is gone up well now and it is salvaged, but then you can see that these small tricky things can keep happening. So our eyes have to be peeled up and open for these kind of situations. And I would, it will keep going down to 48 or so. So in the end, the pupils were good. 8 blood, 600 FFP, 2 SDPs. The HB went up to 9.5 when we shifted. ABG was excellent, reducing lactate trends. Urine output good and clear. These are the parameters that were shifted out. Now, this would not have been possible if we not picked it up at time, and we had not anticipated the problem, and the surgeon did a fantastic job of going up. And obviously, everybody feels bad when this happens. These are all the things that happen to somebody else. And most of you are thinking that I don't know how we reached there and all, but this can happen to anybody. This can happen to anybody at any point in time. And what we need to understand is that we need to build up teams which can salvage the situation. So she was extubated, limb perfusion is good. And one more thing that we had was and if you have an equipment of seeing how much blood and products, these are the point of care coagulation testings, this is the first place which shows the platelets functions were abnormal. And after we get the platelets, you can see the trend is recovering. So these are the equipments that are available. The one thing that I want to warn for all anesthetists in laparoscopic OT is the fixation error. For example, if you see a beautiful robotic surgery going on like this, and you would always be thinking, fantastic work going on, I should, and your mind gets diverted from your actual job, which was to see the monitor, the patient, and the screen. If you just keep doing what I am doing here, looking at the screen and looking at how the robotic arms are moving, what I'm doing is I'm distracting myself from a primary responsibility of looking after the patient. So fixation error, a good anesthetist knows when he's falling into the error, and he will come out of it he snap out of it very quickly. But that's why I want you to remind you that don't get caught into this error. And I wish for all my surgeon friends and all my anesthesia friends that I always believe that God whispers in your ear when you're doing something bad, or you're stuck somewhere. So may the Lord Ganesha always whisper in your ears all that is good. Thank you so much for your patient hearing. Thank you.
Thank you, Dr. Vijay Shetty. That was indeed a very elaborate review of all the tricky situations that can happen in the course of a laparoscopic surgery. I think you've covered everything very well. And sometimes as surgeons, when we are so obsessed over the surgery, we don't realize what is happening in the background. So thank you for clarifying all the things that you guys do in the background. Now, one thing I would like to emphasize, which you actually touched upon, was something concerned to the speed of the surgeon. Now, that is something I want to reiterate, is because many youngsters, including me, are very fascinated by fast and speedy surgery. So just a point of caution that I would want to elucidate with this example. There are Virat Kohlis, there are Sehwags, and there are Rahul Dravid. All three are good batsmen in their own place. So you cannot ask a Rahul Dravid to suddenly start batting like Virender Sehwag. It is more important to gain efficiency and proficiency rather than chasing speed. As the golden dictum in even driving goes, speed thrills but it kills. So first step is always achieve proficiency and excellency in what you're doing, irrespective of the time. And then you chase the speed aspect. So that's a very good point that I just wanted to reiterate. Now, joining in this session now would be the moderator for the session. That is a very young at heart and a person who never ages but very senior in terms of his experience and his work is Dr. Sanjeev Upadhyay, who is the consultant anesthesiologist at Mayflower Women's Hospital in Ahmedabad. Is the consultant anesthesiologist at Mayflower Women's Hospital in Ahmedabad. He is also the consultant anesthesiologist at Sterling Hospital, has more than a decade's experience working as a cardiac anesthetist, is a DNB teacher at Sterling Hospital in Ahmedabad, has successfully completed the Asan International Visiting Scholars Program in Anesthesia for Living Donor Liver Transplantation at Seoul, South Korea. So I welcome Dr. Sanjeev Upadhyay to moderate this session and to interact with the experts. There are numerous questions which I have for all three of you, but I would like you to take the reins and have an elaborate discussion on the practical aspects which as a gynec we all should know in anesthesia. Dr. Sanjeev Upadhyay.
Hi, good afternoon. First of all, thank you very much, sir, Dr. Prakash, sir, Dr. Saumil for inviting me and giving me the opportunity. Now, this Sachin Tendulkar and Sehwag, both of them have backed well. Now, I just want to tell both of them are from corporate setup and they are having all machines and all monitors and everything. Now, suppose some young gynecologists want to start setup, private setup in a rural scenario. So what minimum requirement of anesthesia as well as what the minimum requirement as far as the monitoring is concerned, which is must. Without that, they cannot start laparoscopic surgery.
Dr. Shetty, can I request you to please stop your screen sharing if you could?
Yeah.
Yeah, and please take the question, sir.
Yeah. So.
Anna?
Yes. In my 25 years of practice, I've spent half the time in private practice and half the time in institutes. So like I've spent almost about 12, 13 years or maybe even more in private practice. So when I began my practice and when I joined my residency in 93, so that time there were no monitors available, only in institutes like in Tata Hospital and all, RGMs were available. And as Vijay said, that we've learned our anesthesia just by keeping the hand on pulse. When I started my practice in 97, that's the time I had bought my pulse oximeter. And I think only 2-3 places in Ghatkopar or only 2-3 anesthetists in Ghatkopar had pulse oximeter at that time. So we've come a long way, like from an era of no monitoring to now we are having everything at our disposal. But if a young surgeon, as sir asked, wants to start a setup in a rural place, as I mentioned in my slides earlier, ECG, SpO2 and EtCO2 monitors are the basic thing that can be offered to a patient, and that will really improve the post-op outcomes of the patient, and you will be able to detect the complications early. And as I said earlier, a vigilant anesthetist, no monitor can replace a vigilant anesthetist. So anesthetists have to be very, very vigilant, and if you have these 3 monitors, I think it should be fine. Temperature monitoring is optional, but you can prevent hypothermia by giving warm fluids, you can give warmers, and you can wrap up the patient. So all these things are very important if you don't have those specific monitors, but ECG, SpO2 and EtCO2.
Yeah. Madam, then optimizing the patient properly. So what about the hemoglobin level? At what hemoglobin you accept for the surgery and you say that no, at this hemoglobin I will not give anesthesia?
So if a patient has any pre-existing cardiac conditions, like if the patient has history of myocardial ischemia, IHT or something like that, then the limit is extended to 10 gram%. But otherwise, in a young, healthy, fit patient without any comorbidities, 7 to 8 grams is acceptable.
What is the protocol for securing the blood?
For blood, cross-matching should be done. And if the surgeon and the anesthesiologist can interact pre-operatively, and if you feel that the surgery is difficult or there may be some difficulty, then maybe 1 unit, or depending on the patient's hemoglobin, the few units can be cross-matched. If it's a difficult surgery, multiple fibroids or something like that, that the surgeon would know better. So I think I always, in my practice, I just inquire whether the blood is cross-matched and how much is kept ready. But I think I let the surgeons decide, because they know better about the surgery. So I let the surgeons decide whether they need the blood or not, unless it's a medical condition which where I have to intervene and say that no, patient is very low on hemoglobin, so you keep the blood ready.
Sir, if I might ask one question, which I think is the burning question for all the gynecologists, and this is a question asked by Dr. Vijay Nahata as well. So, tips of how to get a steep head low in cases with normal parameters and patients with different comorbidities. So, in short, how do you manage an efficient, optimal, and an exaggerated head low? And I would request Dr. Vijay Shetty and Dr. Sanjeev Upadhyay himself to give his inputs on the same matter, please.
Shall I start?
Yes.
Actually, before starting for the head low, it is very much required that you see that your patient is normovolemic. Patient should not be hypovolemic from very beginning. If the patient is admitted early, then you start your IV fluid as soon as patient is in the ward, and then you bring the patient with proper volemia. You start giving head low very slowly and increase the intra-abdominal pressure very gradually. And you see that no fast head low or no fast head up or no fast intra-abdominal pressure rise should be there. So that is the primary prerequisite to give the head low. Now, what are the problems? There are cardiovascular problems, there are respiratory problems, there are neurological problems because of the head low. So how to manage the head low? You see that I prefer volume control ventilation than the pressure control ventilation, because there are few issues I tell you regarding the pressure control ventilation, that you have to be constantly vigilant regarding your pressure control ventilation, because in between surgeon many times they reduces their intra-abdominal pressure. So if you adjusted your intra-abdominal pressure, then there are possibilities that very fast tidal volume will be delivered when the intra-abdominal pressure is low. So I prefer volume control ventilation. Then you see that your every parameter, especially the EtCO2, especially your SpO2 is maintained well. If your EtCO2 is maintained well, but your respiratory mechanics is not working well, then you start, generally what I do, that I reduce the tidal volume and I increase the respiratory rate. So in that way, I can take care of EtCO2. And by chance, if my oxygenation is not maintaining, then I increase my FiO2. Still it is not maintaining, then I change my inspiratory-expiratory ratio from 1:2 to 1:1. Then still it is not maintaining, then I ask surgeon to reduce the intra-abdominal pressure and use the intra-abdominal pressure which is optimum for the surgery. And doing everything, if still I am not able to maintaining, then I ask to reduce the head low, reduce the intra-abdominal pressure and go ahead with the surgery.
Right, sir. Dr. Shetty, would you like to add something to what sir has said?
Yeah, I think sir has said most of the things that is important. What I want to remind is that the team has to be familiar with the equipment. For example, if you might get used to one table for one position, and the next day when you go to another table, it might not have the same features that you are looking for. There are skid features. You would have to have a fabric which is anti-skid. Secondly, the way we secure our patient's arms or put them inside, or sometimes we have the arms outside, sometimes we have them inside. But what we fail to notice with the extreme relaxation that we provide, there is actually a lot of telescoping and untelescoping of the patient that happens. That is, your arms are held and your head starts lagging down, or your pelvis gets pushed inside, or your chest gets pushed into the neck. So these are all things that are actually happening. And even if you do it gradually, you'll have to make sure that important parts of the body, for example, just above the thigh, you put a band, or somewhere obviously in the abdominal surgery, you can't put anything on the abdomen. but you have to make sure that your shoulders and your arms, upper arms, are nicely put in. There also used to be some shoulder braces that will come, so that the patient, we should use them actually, and the patient's weight actually comes on the shoulder, which is very good, and you also make sure that your pillows and your head doesn't lag down too much. But what happens once was that the shoulder itself, it gave a big abrasion on that. So you need to pad everything properly. Don't assume that anything is going to protect. Like I always say to my fellows that the patient is unrepresented in the OT. So the only people who speak out for them are the anesthetists and the surgeons, are the people who are working around him. So we need to ensure that we are taking good care of this patient who is not able to speak for himself. So we need to be very sure that everything is taken. So once we build a good, I'll tell you one more example. One technician is very good at giving positions, and the day that he's not there, you'll end up having some problems because we have not seen how he is working, nor have we made sure somebody else is going to be working as good as him when he's not there. So we need to be part of this positioning. That is very important, I think.
Dr. Sanjeev, you have some other questions for the panel, please?
Now again, same thing regarding the hemoglobin. If you are not having blood ready and some mishap happen, then what is the more important? Infusion of the fluid, blood, or how to manage that case? That I just want to ask Parnaji.
We face this situation many a times where we don't anticipate major blood loss. Like sometimes in private setup, I've had situations where I've just gone for a very small procedure, like half an hour procedure, and landed up with lot of blood loss, and the blood was not even cross-matched because it was just a very small procedure. So, and also like those were the early days of my practice, so where nothing was really available in the OTs. Like I just had one colloid available, so the blood pressures were dropping, the BP was 80, 70, and there was massive blood loss. So first and foremost thing is secure another IV line. That is the most important thing. So I had secured another IV line, and I started one crystalloid on the other side and one colloid, and immediately drew up a blood sample and sent it for cross matching, and then be in communication with the blood bank, keep calling blood bank that you need it urgently, and mobilize the blood. So basically, most important, when the BPs permit and the blood loss has just started, even if you take one extra IV line, it really doesn't matter. But secure an IV line before the patient collapses. So secure an IV line and then start with crystalloid and wait till blood arrives. If you have colloid, give 2, 3.
In this situation, will you request a surgeon to open up, or you will go ahead?
One cannot pressurize the surgeon. Like the surgeon should not pressurize me to do something because I know my subject best. So like we should not cross the limit. You may suggest, but you cannot force your decision onto the surgeon. So you may suggest, you may communicate better with the patient, with the surgeon. You may keep telling him that there's no blood loss, the BP is dropping, the vitals are going down. So keep updating the surgeon. But finally, this decision to open up lies. I think surgeon only should make that decision.
Madam, one more question for you, which is directed to you, is by Dr. Sindhuja T. So is DVT prophylaxis required for all lap surgeries? Do you recommend it for all laparoscopic surgeries, DVT prophylaxis? And if at all, when do you start it, until how many days?
So actually what happens is that many of these surgeons, they are not very comfortable with starting low molecular weight heparin before the surgery because they fear blood loss during the surgery. There are centers which give it pre-operatively, especially in obese patient. But at the same time, there are bariatric surgeons who give it pre-operatively or soon after the induction they give it. and there are some surgeons who do not even give it till 24 hours. So like we have to see surgeons' comfort also, and then like the anesthesiologists and surgeons as a team, they have to set up the protocols. But in India, still say 60 to 70% of the people are still not giving low molecular weight heparin pre-operatively, and they are more comfortable starting at 24 or 36 hours the surgery. But as I said in my slides, if you hydrate the patient well, and if you put compression stockings or Flotron, and if you mobilize the patients after surgery, yeah, so early ambulation, even if they are like in immediate post-op period, encourage them to at least flex their legs. And these things, if they are started early, I think that can prevent TVT. And in high risk cases, yes, please start it.
My question to all the three experts right now is what is the role of regional anesthesia in laparoscopy today? Especially many times I have faced this challenge because I have gone to many government hospitals wherein probably there is sometimes a paucity of anesthetists. So many of the times they might be moving around from one OT to the other, and they would always prefer for any laparoscopic procedure being done under spinal anesthesia. So this is also a question addressed by Dr. Indira Nayak. Is it medical legally safe to give spinal anesthesia in endoscopic gynec surgery? So your take on use of regional anesthesia in sole regional anesthesia and endoscopy today. Dr. Sanjeev, you can answer the question.
Actually, sole regional anesthesia is not recommended. I don't know regarding the medical legal aspect, but it is not comfortable to patient. It is not comfortable to anesthetist. Even it is not comfortable to surgeon to perform the surgery solely under regional anesthesia. But yes, you can combine your regional anesthesia with general anesthesia. That is an excellent alternative for ERAS protocol. What Dr. Vijay and Dr. Pragna were talking regarding their lecture, because giving regional anesthesia, especially I am telling you regarding the epidural anesthesia, along with the general anesthesia, it takes a lot of care regarding intraoperative hypertension. It takes a lot of care regarding intraoperative respiratory mechanics, as well as it gives post-operative analgesia, very well analgesia. You can avoid opioid even during the surgery and even after the surgery. So epidural, I would say even epidural or spinal anesthesia is having advantage that sympathetic block will lead to parasympathetic overactivity, which constrict the intestines. So intestine will also be more friendly with along with the regional anesthesia for general anesthesia. So solely regional anesthesia, I do not know. Regional in a way, spinal or epidural. But it is combined with the general anesthesia, then it is an excellent modality of anesthesia, I would feel, in the laparoscopic surgery.
Right. Dr. Shetty, your take on it?
Vijay, your screen should be continuously on. Don't switch it off. Your video has to be seen. Right. Handsome Vijay Shetty has to be seen.
Okay. So I remember Sanjeev sir gave actually the very answers which are close to my heart too. But I remember reading something 4-5 years back. Somebody done a what do you call not a multi-center study, but he literature search, and he had Dr. Bajwa, I think, and he had because we had presented it I read it about it for some other meeting. He had said that there's a re-emergence of regional in the laparoscopic surgeries. See, we have done cardiac surgeries under regional anesthesia too. But obviously, like all the things that Dr. Sanjeev said, it is not comfortable, the surgeon is not comfortable, the patient not comfortable. But there might be cases where regional anesthesia might be like you cannot give him GA. And those cases, usually you will end up opening and doing a job and then giving the patient post-operative pain and such. But if you were very skilled, because I know a lot of surgeons who do surgeries under regional anesthesia, and it is actually, I would say, the patient is willing, for whatever reason, willing to accept that pain and the discomfort. The anesthetist is good at his spinal regional and giving the proper level. The surgeon is accepting that discomfort that is bringing on to himself. And if the surgeon is not willing, There is no way that I'm going to, like Parna said, we're not going to insist on a surgeon to getting the surgery done under an anesthesia, under a regional anesthesia. So the regional anesthesia is reserved for obviously very high risk cases, in which case you would anyway not do a lap surgery, I would say. But
that is what I want to tell.
We are still having a lot of surgeons and surgeries being done under regional anesthesia, but that has to be entirely the prerogative of the surgeon to say that I am happy to do it. And when there is a risk proposition coming in about GA versus how do we decide the best anesthesia? We would say if 100 cases are done in the city for this surgery, what is the anesthesia that is given? Okay, the anesthesia that is given for laparoscopy or is a GA. Now, this patient, is the GA safe or is the GA safe for him? Are there contraindications for GA? Then the answer is yes or no. If it is say yes, the GA is unsafe for this patient, then we get into a discussion and decide how we go about it. However, you can understand very clearly, if the surgeon is not happy doing it under regional, even for a normal patient, it would be very difficult to expect him to do this patient under regional in high risk patient. Correct? So I would say for a good outcome, we have to give the surgeon what he wants to do, and unless there is specific contraindications or say negatives that we cannot provide it to him, only then this goes. So that's why team discussion has to be done very quickly. There are people who have done under spinal and steep head low, give high levels, and they've done high epigastric repairs too. So that everything can be done, but are they safe is a question. And medical legal, like Sir said, I don't think anybody can point out anything, but if something were to go wrong, there are some cases in the literature where it has been done, so you could show that. But whether you would be absolutely safe in the court of law is difficult to say.
Dr. Sanjeev, you wanted to say something? Yeah, please.
So Vijay sir was telling regarding the condition where you can say no for the general anesthesia and you can do it in a spinal. What are the conditions? What are the disease where you are not able to give general anesthesia, but you can offer the spinal anesthesia? In my understanding, very few cases where you say no for general anesthesia and yes for spinal anesthesia for laparoscopic surgery. But this is for the open. This is for the open discussion with Parnaji and Dr. Vijay.
Yes. So, if you're asking, sir, obviously, this is for the benefit of whenever a surgeon comes across an anesthetic who says that GA cannot be given. Actually, like I showed in my slide, we have got very poor respiratory reserve in whom GA could not be given. We have done laparoscopy surgeries in them. We have patient who has got one lung and we've done laparoscopy surgeries for them. We got patients who got EF of 20% and we've done laparoscopy surgeries for them. Here, it is my belief and the belief of those people who administer anesthesia that we can accept a small period of uncertainty and risk to give the patient the best benefits of laparoscopy in the post-operative period, like early recovery, less pain, early mobilization, early initiation of blood thinners and all. So if this belief is strong in anesthetist, there would be hardly any contraindication for giving the proper anesthesia for the proper surgery, right? But the third eye in this discussion is the patient. When an anesthetist or the surgeon explains this risk of anesthesia, how the patient interprets it, or how some smart doctor who is related to the patient interprets is different. If the patient gets advice, you get it done under regional only, and then it becomes very difficult to contradict or counter, because we can only give case scenarios and research articles. But I think one thing that stands by us is our experience in doing these high risk cases, and I would recommend that everybody should have a list of patients that are done on high risk patients under general anesthesia, or for example in this topic of discussion, whatever high risk patients you've done, they should be your work which you can present to the patient. This is what we do. In our hospital, we always say this is high risk patients are commonly done under laparoscopy surgeries, under robotic surgeries even we have done. So those examples are not only heartening for us, but also acts as evidence for providing to the patient that yes, this anesthesia can be provided.
Dr. Parna, would you have any scenarios wherein you would definitely refrain from giving general anesthesia?
Recently, we had one patient who was COPD and her PFTs were very bad, and she had very bad obstructive disease and irreversible obstruction. Then once the patient was admitted, then we optimized the patient, and then we repeated the PFTs. So they were little better than before, But patient said that she cannot even lie down flat, like she's that uncomfortable. And like we were in dilemma, and she needed an open coli because it was empyema, and also she was admitted with sepsis, which got little better. Now, these are the patients with severe lung disease that you would be tempted to give regional anesthesia, and you would refrain from giving general anesthesia also post-operatively. If the patient goes on ventilator, weaning them off would be very difficult, and also patient will have a lot of patient will spend a lot of money on the ventilator, also being in the ICU and the ventilator. So patient's economical condition, patient's mental preparedness, then the surgeon's preparedness to do it under regional. Like if I'm used to nicely relaxed patient, and if I'm having a difficult case where I'm anticipating lot of additions and the surgery itself could be difficult, like my choosing regional anesthesia is not really going to make much difference if the surgeon is not comfortable operating under regional anesthesia. And my worry would always be that it should not be half of regional, half of general, because so many times what happens when you give a high regional anesthetic, you might, for some surgical steps, you might have to give more sedation to the patient, or more of some sedative drugs too, so that the patient doesn't react to those stimuli. So you should not land up giving almost like a general anesthesia in regional anesthesia. Otherwise, the very benefit of regional anesthesia is also lost, because that will also cause respiratory depression. So surgeon has to be very comfortable. Patient has to be mentally prepared that I'm going to be lying awake while the surgery is going on, and what works best in my hands. Like if I'm not comfortable giving levels till T2 or giving very high regionals, like what is suited to me is also very important. So I think it has to be a combined effort where the surgeon is comfortable, the anesthesiologist is comfortable, the patient is comfortable, and you can give a benefit of trial to the patient. So you may start with regional, but explaining to everyone in the team that you might have to give general anesthesia if the surgery demands, or if the patient doesn't do well. So never have just plan A ready in your mind. Plan A is yes, 99% of the time, but always plan B has to be there. If this doesn't work, then what am I going to do? So always have GA at the back of your mind ready.
One last question before we close the session, and there will be an extended Q&A session happening at the end of all the 3 sessions. So I would request all of you to stay back, or at least join back at around 6:30. What is the role of regional anesthesia when we are talking about hysteroscopic surgeries, and how does regional anesthesia affect the fluid dynamics? So is it safe to do hysteroscopic surgeries in spinal, or would you prefer a local or a GA or a short GA?
As far as my understanding, if we are going only for hysteroscopy, that hysteroscopy is not likely to convert into the laparoscopy, then it is advisable to do under regional anesthesia, because whatever the complication, suppose we have given general anesthesia, then we have got very few parameters by which we can understand that patient is having some problem. Right. Because the major thing is that patient's consciousness, patient's irritability during the fluid overload. So that part is much better conveyed to the anesthetist when patient is wide awake, rather than patient is anesthetized. Because if the patient is anesthetized, only hypertension, bradycardia, some after a lot of sodium reduction, there is a ECG change, and consciousness of the patient only we can realize after the extubation or at the time of extubation. So only hysteroscopy, then my preference is to give regional anesthesia. But if it is likely to combine with the laparoscopy, then general anesthesia is preferable.
Dr. Shetty, any additions to that?
No, I think that's perfectly said. This is exactly what we follow for our prostate surgeries as well, that we prefer regional, with the basic idea that we are able to monitor the patient's neurological status, which is direct outcome of the hyponatremia and volume overload. So regional definitely is safer and better. But any procedure which is going to last for a little longer and has other implications, then it's better to secure the airway and get it done.
Sir, any changes in the fluid dynamics? What I want to specifically target is sometimes because of the spinal anesthesia, there can be the capacitance of the venous vessel increases and there can be pooling. So can there be masking of the fluid overload symptoms because of spinal?
I tell you, sir, always see, you can take care of peripheral vasodilatation by one is volume, and in certain cases you can start vasopressure from very beginning to reduce your peripheral vasodilatation. So in that case, and even low spinal means for the hysteroscopy you need not require very high spinal. Low spinal, low volume of the drug which has been given to spinal anesthesia. So less peripheral vasodilatation is likely. So this is much better to take care rather than to give general anesthesia and end up with the complication.
I agree. What sir is trying to indicate is that maintaining the blood pressure by pharmacological means, which is not such a big thing in other surgeries, but in this surgery we have to be a little more careful to maintain a good BP whenever hysteroscopy is done under regional or even otherwise.
Thank you so much, all the experts. With that, we'll close the session. But please, yeah, sure.
One thing I just want to ask means I want to talk with Prerna ji and Vijay ji. None of you have talked much regarding the IGL or LMA in laparoscopy. So, what is the recent? What is your understanding of using supraglottic device for laparoscopic surgery, especially gynec laparoscopic surgery?
Yes. So, Prerna, you want to go first?
Yeah, whatever. You start.
So I won't have a long answer, but I can say that it all filters from the personal preference of the anesthetist. We have in my department people who are comfortable with both, and we let it at that. We don't believe that somebody puts in an LMA is a superior anesthetist as such, but we have conducted obviously laparoscopy surgery, lap colis and such surgeries with the anytime. But however, when a Trendelenburg is required or when access to the airway is going to be difficult, then I don't prefer that we put in a LMA. There are two things about the LMA or rather the LMA problems that I am thinking is that a difficult LMA position might make it more difficult to maintain it for the length of the surgery. However, a lot of surgeons are doing it. A lot of anesthetists are doing a lot of laparoscopy surgeries with this with the LMA only, with or without relaxants even. So we are quite okay with that. For hysteroscopies and other surgeries, it is quite good. But for something which is a steep head loss required, probably I will be a little difficult. There is a limit of some 30, which is helping us to prevent regurgitation and aspiration. But since we say that the risk of aspiration is very, very minimal, the LMA seems to be a very for people who want to be using it, especially with the newer generation LMAs.
Dr. Parna?
Yeah. So LMAs, if it's a short procedure, like if it's just a diagnostic hysteroscopy or diagnostic laparoscopy and not much of surgical dissection is required, then I may put LMA. But if you are anesthetizing a difficult or obese patient, or it's going to be first you have to discuss with the surgeon and you have to see what are the USG findings, how is the whether it's just the hysterectomy. If the patient is posted for myomectomy, then how many myomas are there? So it has to be tailor made. It's not that LMA is good and general anesthesia is good. General anesthesia is gold standard. But if the surgeon is going to require steep head low, if more of surgical dissection, or if the surgery is going to go on for a longer time, and if there are no contraindications, or if the patient is obese and where I'm anticipating some difficulty in ventilation, then I would surely go for general anesthesia and endotracheal tube and not LMA. So because displacement of LMA during the surgery is also another problem. Like say 1 in 100 patients or 2 in 100 patients, you might have to replace the LMA by endotracheal tube. So if you are doing, say, first or second case with the surgeon, and if this happens, like he's going to he's not going to like it. So if you're very comfortable with the surgeon and if you're doing it, then it's fine. But explain to the surgeon before putting LMA that I'm putting LMA, but means if the surgery exceeds, then if he's open about putting endotracheal tube halfway during the surgery, then it's fine. Otherwise, I always put endotracheal tube.
Thank you once again. I think there are 20 questions which I have myself, which I will definitely be posing to you all in the extended Q&A session. So please stay with us. That brings us to the close of the first session, and I thank you once again. So coming to the second aspect of today's webinar, which is what the two eyes of the endoscopist can miss. That is know all about what the energy sources are, the mechanics. And the first speaker for the session we have is none other than the convener of the UPLIFT, that is Dr. Prakash Trivedi. Besides being my father, he is the pioneer of endoscopic surgery in India. He is a leader and a mass motivator and an untiring and passionate teacher. He has done extensive research on fibroids and has one of the largest study on in-bag morcellation in the world. He is the current ESAR president and the past president of FOXI and IAGE. There is a colloquial statement always made about energy sources that the magic lies in the hand of the magician and not in the wand. But let's witness the magic of the various wands available to us. And I invite Dr. Trivedi to enlighten us about the various things to know about energy sources. So over to you, sir.
Yeah. Thank you very much, Somil. Before I start sharing my screen, I have to first, for the first session, I would like to tell that we are born, and I'm totally dedicated to Dr. Bajani, our anesthetist, Dr. Deepika Desai, then Pranesh. Then, of course, in institutes, Jaslok Anesthesia Department, then Vijay Shetty and Pranav, Vijay Fortis, I think so. All, and maybe 800 workshops I have done with different anesthetists all over India, and all of them are the root cause for which we are sitting here and we are talking so many different things. I will be talking on the subject which I love the most, this subject I feel is the crux, because everything changes, every now and then there is always a discussion and argument related to this is our one of the operation theater, and it is only shown because you name any energy source, we have two operation theaters. Every energy sources are there, all the anesthesia monitoring parameter, 3D, etc., and all, because it's a university recognized teaching center, so we can't compromise. So a lot of work is done, and at the same time we have to be practically clear that we have to have more. I can't say that I don't want to move from an X car to a Y car with a simple logic that energy equipments, whether in endoscopy or ART, is essential requirement and it is not luxury. So I will be sharing with you a lot of aspects about an energy. You will have to pay a lot of attention because this is not a very easy subject. In older days, we used to always tell for genetics. The genetics, you can remember only the day when you read in the morning, and by evening it is forgotten. Whenever we talk about surgery, we have to remember that all of us have been groomed and taught by all our teachers, whether surgeon, urologist, gynec, which is known as an Holstedian principle, wherein dissection is to have safe access, then you resect a pathology, then you reconstruct a pathology, and then most important is most important is you also have to remember that the tool which you use, whether it's suturing or whether it's sealing, whatever it is, has to give optimum wound healing. Current times are very bad. I don't have to remember Hippocrates. I only remember Nilesh Gadge, because in the entire phase of our COVID time, he is the rock anesthetist at our place. Excellent person, very sweet, very, very well organized. And we all are grateful to all the anesthetists because of whom we are here. Hippocrates very, very long time back told, fire succeeds when all other methods fail. So the balance is between what cuts and what coagulates. When we talk about energy sources, you have to remember there are two types of energy sources. One is the electromagnetic, and I will not go into detail about cautery, electrosurgery. So it is ESU, electrosurgery unit may be monopolar, bipolar or laser. Mechanical can be ultrasonic, can be sutures, can be stapling. Now in principles of surgery, very often you realize few people are using the same energy source in so beautiful fashion, whereas many others are not using in the same fashion. So that's the reason why I told you that you will have to concentrate on what we are trying to emphasize. The most important principle is the collagen-elastin ratio, which predicts the burst pressure of arterial seals. Arteries with high collagen-elastin ratio has a high burst pressure. So the total collagen and collagen-elastin ratio are more accurate predictor of arterial burst pressure rather than the size of the vessel. Higher collagen is good for coagulation, which is more in arteries than in vein, worst in lymphatics. And more elastin is worse for coagulation. So sometimes you have to remember that you get a lot of lymphoseals after a radical surgery, depending on what type of energy you have used. Sealing of the vessel is always augmented by platelet agglutination, and then that leads to a permanent clot. After this is achieved, then you transect the burst pressure at 90 degrees Celsius is good enough. And the angle of the instrumentation achieving this is very important. So you have a 5 millimeter vessel, but if you hold it oblique, it will become 7 millimeters. So the entire dynamics will change. As I told you, lymphatics needs more compression, and the traditional bipolar has less compression. Harmonic also has less compression. Very regularly we see a lot of surgeons dipping too much in fat and very nicely with cautery, not knowing that fat is the worst conductor of electrons, unlike muscle, nerves and very other structure. So there's no point in wasting time with an energy source in adipose tissue. You have to understand, you have to do something different. This is a very standard simple thing. We exchange the term anyway. Electrocautery is electrocution, means somebody holds a wire and touches you and you die, direct current. Nobody uses that. What we use is ESU, electrosurgical unit, wherein body forms definitely apart from where the current is flowing. On top of it, there is so much of oscillation of electrons going inside the tissue cell that it generates different type of effect. Further, we have to remember, this is a very classical principle of how we remember voltage, current, power, a simple thing. So this is a tank we see on the 13th floor. Count this tank to be on the 14th floor. So it is having pool of electrons and it flows through a small outlet. So the higher the height, higher will be the voltage. The small lumen is through which the current is going to pass. Now once the current is going to pass through small lumen, then once the current is going to pass through the small lumen, then depending on the obstruction it gives. For example, if you're talking of a tap or a tap with a tubing, so it flows nicely. That flow is circuit. But when you obstruct partially, then it may become more powerful in terms of force, in terms of going. So impedance or resistance is ohm, which is current multiplied by voltage. And wattage is the most important thing because it is voltage plus current. So when we are talking about a standard monopolar, you remember that you are on the 13th floor or you are on the 7th floor. When you're talking about a vessel sealing device, then you remember the grand, stylish bathroom of yours with the tank which you have inside. That is low voltage. So that simplifies most of your thought process very easily. So certain terms are very important. Circuit, as I told, is flow of electrons. Current is always in amperes. Voltage is volts. Resistance, Ohm's law, all of us know. Power is wattage. Energy is, wattage is energy or heat produced or used over a period of time. So that gives you the wattage which you have actually utilized. Now, oscillation is something very important. In fact, it is said that if I rub my two hands from morning till evening and I touch an open fibroid, it generates so much of heat that it will cut through. But that we cannot do it. So physicists utilizes oscillation thousands of times per second. Why I'm telling physicist is because in household, 60 hertz is the one which is used. This is used actually because it is useful for whatever we do, but it will have neuromuscular stimulation. So if you're going to use the same, you will electrocute the patient. So the medical physicists have taken the oscillations to 100 kilohertz. So there is no neuromuscular depolarization. So no neuromuscular side effects. You go a little higher, the orthos and all will know QSA, wherein 200 kilohertz or 3.2 is the one which is useful. And when you are watching a TV, it is 60 megahertz. So energy is thought to be one small little box. But energy, and when I talk of energy, there is only one man comes in front of me, and that is Dr. B.S. Sastry. The only person whom I always feel that there is only one person with whom I can relate with any aspect of energy is him, and we discuss a lot and we learn a lot. I learn a lot, and that is important. If we see neurosurgeons were very intelligent, and all of us are very much worried now, sparing surgery, not to do this and that. Who started electrocautery? It was Harvey Cushing and Bowie, both neurosurgeons, in 1923 to 28 used the monopolar. Now, grounding, we have to remember we no longer have ESCs which are grounded, they are isolated. Again, William Green, a neurosurgeon in 1946, felt why the hell should current go through normal nervous tissue? So you need a bipolar. But eventually when bipolar comes, Gynec is always in picture. Klippinger, a Gynec in 1960, formed the dedicated bipolar. However, he didn't have enough compression because his bipolar was more for fulguration of endometriosis, many other processes which can be modified by changing the handle. Now, these are the various things. The lower one you forget, nobody grounds nowadays. So it's isolated. And of course, in the rainy season, we have seen all these things happening in actuality. Various effects are there, but the most important thing you have to have hemostasis and desiccation. Whereas dissection, vaporization, fulguration, coagulation obviously is important, but it becomes very easy. But there's a huge difference between hemostasis and desiccation. So how do you have the mechanism of hemostasis? When with whatever form of energy you're holding a tissue wherein you want to achieve hemostasis, there is tissue shrink. As the tissue shrinks, there is platelet formation, a thrombus is formed, and depending on compression, the intima to intima apposition takes place. When the intima to intima apposition takes place, it will form an irreversible clot. Traditional bipolar. I am telling you the very nice development traditional bipolar, which are low voltage but have very less compression. So they are better than monopolar. What happens with monopolar, when you hold something which you want to coagulate, the current stops flowing. So monopolar volt jumps to 5,000, to 7,000. Again, the current doesn't go, no signal, it still jumps further. So monopolar in laparoscopic surgery is the most dangerous instrument. Then we have bipolar we discuss. There is advanced bipolar. There is a vessel sealing device, and I divide this into two generations. First generation of advanced bipolar or vessel sealing device. The first generation of advanced bipolar where they had good compression. Now, first of all, when you're talking about advanced bipolar and VSD, you have shifted yourself in your stylish bathroom. So you're having all exotic types of tanks because you are having low voltage. You can control everything. So there is good compression. And this machine has the intelligence. So when the tissue dries, electricity stops. It doesn't get fooled like monopolar and once this happens, once a good seal is formed, then you have separate device which is a mechanical transaction device. Now, why did I tell you first generation and second generation? As you saw in my film, from gyrus to N-seal to Thunderbeat to ligashore, you name any energy source, all we have. The first generation advanced bipolars and the vessel sealer had the cardinal mistake that it could compress, but the current electron spread laterally. So because it spread laterally, that is the reason why our first ureteric injury with energy source was in 2005. So we didn't realize that company says it is safe, but it was not safe because ureter is hardly half 5 millimeter away from the uterine artery. And if we have a 10 mm, as I will be showing you all this energy device. Second point you have to remember is some of the compression in the first generation is a V-shaped compression, which means the base is compressing more, not the tip. The second generation vessel sealing device are the ligashore, Thunderbeat, and so on. Now here the advantage is they will have the same effect, same apposition, same collagen formation, but beyond intelligence and smartness, their current flows in between the two jaws only. Further to add, they have protective boots or coating or PTC, and the compression is parallel, means the tip is compressed as much as the base should be compressed. So that is the reason why the second generation vessel sealer are superb and fantastic, and if you dissect it well, there is no problem. But if you hold a ureter and use vessel sealer, don't blame the vessel sealer. Now this is the tissue effect which happens with energy. When we go to 50 degrees, there is irreversible tissue damage, protein coagulum, little disorganization. 90 to 100 is the time when there is dryness, weld and sealed which happens because vaporization of water starts desiccating tissue, and this is where desiccation becomes important. Now I am monopolar, this temperature is going to jump to 150. So that is where you have carbonization or charring and all those things will start. Now ultrasonic energy sometimes it is very important to remember a lot of brilliant people this came in 1990s. As I told you, it utilizes the principle of oscillation, vibration of piezoelectric crystals, and ultrasonic energy can lead to seal and also coagulate. So a harmonic scalpel, suppose if I use the spatula only, it will just oscillate. So it can just do nothing. It can never coagulate. But when I am using a harmonic ace, then it has two blades, one active blade and another buffer. The active blade oscillates 55,000 times per second. So it generates more coagulation at the base, which is called as the node, than at the tip, wherein it is more current, which is called as the antinode. So harmonic scalpel, when it is compressed and when this oscillation starts, it breaks the hydrogen bonds in the cells, protein denaturation takes place, it leads to a sticky coagulum, and the friction, then it cuts, and because of negative atmospheric pressure, it causes that beautiful cavitational effect. When you go to NSEAL, it has two blades, as we'll be seeing, but the positive and negative inner central golden part is the return electrode. And PTC, which is very important, which is positive temperature coefficient, a positive temperature control, and this PTC prevents the thermal spread, and it has 6 nodes from where it will spread from one instrument to the other. So when you're talking about ligature, when you're talking about such system, maybe NSEAL, the spread is not more than a millimeter or more. However, you have to remember in NSEAL, you have to use your hand. Your hand goes to dissect the entire tissue. And because the hand goes to dissect the entire tissue, you have to make an effort. Left side, there is no problem. But when I go on right side, it is not easy for my hand to use that. And that is where we moved from NSEAL to ligature. Something about the electrosurgical, there are many smart cauteries available, and there are a whole lot of things. It is basically radio frequency. So intracellular conversion of electromagnetic energy to kinetic, to thermal, to vaporization, to fulguration, to frictional forces of the protein, and final change can be charring, or if there is sugar, it can be caramelization. Now this is where I started in 1994, more than 25 years back. Harry Rish's famous instrument, the most dangerous, is the monopolar spatula. It works like, it's like a spoon, but works like a knife in butter or knife in cheese. But the problem here is, if you see, current is not that very high, but it is on the 14th floor terrace. So voltage is high. Now if you are on cut mode, you are still on 5th, 6th floor. But if you are on the coag mode, the voltage is 3000 to 9000. And that is why you have coupling, capacitance coupling, burns, all sorts of things can take place. I would not hesitate to tell that monopolar I use only to make an incision of fibroid. Otherwise, monopolar is not there in my laparoscopic table. Maybe PCOD puncture. And obviously in hysteroscopy is again a different wherein mono and bipolar can be used. Now bipolar obviously was better because, Kleppinger's forceps, if you remember, he didn't want to approximate it. So here what happens is the voltage is less. So here there is a better amount of, certain amount of hemostasis will take place. But Kleppinger's forceps doesn't meet, the blades don't meet. So that is the reason why this spring action blade was formed, and thereafter the Bessinger handle was formed. However, you have to remember that bipolar may be good for hemostasis. Desiccation is a different ball game. So if you see here bipolar, the lateral spread will take place through intracellular heat, steam. We always say till the bubbles stop, but when the bubbles stop, it has already spread to surrounding tissue. This is the messenger, which is the single most big instrument designed in the last 10 years. And here, because you can compress it, so bipolar has its own advantage and it has its own role. Then we have to start understanding, this is the waveform which I was telling, monopolar, 14th floor. Then you come in between bipolar, you are somewhere in between, you are on the 5th, 6th floor. Vessel ceiling, you are in your own pleasant area wherein you decide what sort of system you want so that it is most safe. You have to remember that when we are using with all this energy source, any patient you are using, there is nothing like learning curve mein to aisa hota hai. If it happens to your mother, your sister, your daughter-in-law, it is the same, because somebody is somebody's sister or mother or daughter-in-law. We began our expedition with this plasma kinetic. We were so thrilled. 210 mm port, and suddenly, you know, those time I think so I had Aditi Singhi as one of my assistants. And, you know, surgery, hysterectomy big was over so fast that this is the first generation machine. So from the right side I can finish, I can change the telescope, and for the left I can take in the center. But if you see here, the tip is 8 to 9 millimeter naked. So what happens is it can really spread the energy, and the sharp instruments come in between. Around the same time, Martin Maxey came with a Roby tip. See the Roby tip, see the spread you are getting on the sides. See the gyrus transector, which is the plasma kinetic. See the spread which is happening. You know, by the time we realize, lots of people had enough number of injury because we kept on believing whatever company is telling is perfect. Now, this is very important. This is an hysterectomy. If you'll see, you will find whatever the size is, there are 2 uterine and 2 ureter. You see the amount of lateral spread with plasma kinetic is giving. The current new plasma kinetic has changed a lot of things. And these are the instruments which cause lateral damage, and these are the reason why many people wanted to do only with bipolar and Caesar, because they were scared of the cost and the side effect of any energy source. This I am intentionally not going to cover because my great friend Shailesh will be covering, but everybody will have. You know, I have 6-7 ureteric injuries, 6-7 bladder injuries out of 37,000 surgeries. There are many surgeons and gynec who are so great, they never had any ureteric injury. They are all like Ganpati, you know. They can't make mistake, because even Shankar Bhagwan can make mistake. So basically you have to remember that I will not talk about any complication. Now this is a very interesting instrument, a bipolar morcellator, which I had used first time in 2003 in B. Ramesh's workshop. The circuit is completed from the inner cutting and the outer part. The new PKS has a smoke evacuator because this generates smoke, and smoke is a big issue. So here now we come to the vessel sealing typical. So this is the N-seal. As I told you, it is low voltage. It identifies, it increases the temperature. It realizes the impedance. It finds out, it senses that the current has stopped. So it modifies the noise, and parallel will go because your knife blade has to move from the base till the distal end. So you get good coagulation, but my thumb is not happy because I have to move it with my thumb, as you will see in the next picture. So suppose if you see an articulated N-seal, you know, I used to very regularly joke that with an articulated N-seal, I can do the left uterine from the right side and right uterine from the left side. Now if you see this jaws, this is the golden part which comes, and that is the PTC. So that golden part completes the circuit. So this movement which is seeing doesn't happen automatically. It happens with your thumb. So it is an excellent instrument, but slowly we started, feeling that we have to use our thumb a lot. You can have something which much more better. However, this had excellent amount of hemostasis and could tolerate any amount of burst pressure. Then when we went further, I think so the instrument which probably made dissection such a joy. We used to do birch. I used to use monopolar Caesar from the same company. Ultrasonic we discussed. The passive blade is the Teflon coated. The active blade is the one which is there. It was Piers Jacks, Mark Davidson and Joe Emerald who made the harmonic as a useful source. This is the birch part. I will not go into the birch part. I will show you the mechanism of a harmonic. So this is a harmonic. All of us are used to harmonic Ace, harmonic recent one, and this sends beautiful rhythmic. It is not using any current. It is not using any electricity. It's oscillation, oscillation, oscillation. It goes and oscillation generates everything. And the buffer blade is the buffer blade which gives you an idea that you can use it. What happened is, as it was a very good dissector, people also wanted that let it have some sealing effect. So there is further modification with a longer blade. And if you see the green switch there, so you can achieve the desired effect and press the green button. So you can have even the coagulation part. Greatest dissector, according to me, is harmonic scalpel. But it is the most dangerous instrument which can lead to a lot of injury. That is why it is said that you don't use more than 7 to 12 seconds in one go. They say it is Japanese method. Cut 2-3 seconds and go. Cut and go. So there is a gap given. So your harmonic doesn't have the side effect. Otherwise it can have side effect. But it's a phenomenal instrument. Obviously all these are disposable. In India, there are many other ways in which we try and economize. Now harmonic, the important part is you can use the harmonic in multiple ways. We remember Deepak from Ahmedabad. He will use harmonic in such a way that he will just glide the harmonic with not much pressure and even the vessels will get under control. So every person has their own method of using harmonic. So if you use it too tight, if it is increased tension, it will cut. If it is then it will increase coagulation. The blade, as I told you, will cut. Oblique, you may cut more. So you have to have the node antinode principle. You have to remember there will be less tissue stickiness. It doesn't have current, so no neuromuscular stimulation. It is a sturdy instrument. It is a good dissector. It can be used to push tissue. It can have multiple things too. But remember, when your harmonic is hot, don't try and push a bowel or a bladder because you will cause burns. Then came, more and more wonderful thing. In rainy season, everybody remembers thunder because it is surrounded thunder and beat. So it used synergistic energy, both which was of oscillation and also the bipolar with the ultrasonic, with Viper jaw mechanism, with a specific probe design. It was versatile, fast, good dissection, the widest grip, good hemostatic seal. Now if you see over here, thunder is electricity and beat is waves of ultrasonic. So you can achieve coagulation by the bipolar part and cutting by the oscillation part. Now when you see this, here what happens is, if you saw previous lateral spread, this is salpingectomy which we do prior to hysterectomy. The moment, and it has two devices, you can just coagulate or you can coagulate and cut. So you can hold, you can dissect, you can cut, coagulate. You see the margin. It's a fantastic instrument, but I always call it as a delicate darling, because not more than 2-3 cases can happen with it, because it is not designed for more than that. But it uses lot of good principles, and the brain unit of many of this can be more useful to have bipolar, monopolar, bipolar of hysteroscopy, the vessel sealing effect, and plenty of other things. So there are a lot of energy devices which makes your life much more easy, faster, and people do get glued to it. Now this is the wiper jaw mechanism. Nobody realizes in our car why our wiper cleans the tip and the base equally well. That is wiper jaw mechanism. See, if there's a structure which is a little bigger, which you have, so then the base, the wiper jaw mechanism will take the upper blade more anteriorly, so it gives systematic compression to the entire tissue. On top of it, it has anti-sticking insulation coats. However, the lower part is like the harmonic itself. So we have to remember that the lower part should not be touching any tissue, which is when it is in action, except that when you are cutting. Then we moved, and all of us are in love with ligature, because what happened is about the thumb, about the delicate darling, etc., etc. Everything changed because we had this a dedicated unit wherein you need not purchase an entire unit. So you have the same low voltage, same formation of a platelet plug, protein denaturization. The silicone boots help to prevent any spread. There is a nichrome wire which comes. So you have a good seal, and now you will see a nichrome wire which comes at 300 to 400 degrees, but it is self-insulated. And this is sturdy. So this can be used for dissection, this can be used for manipulation, this can be used to just seal. You don't press the cut element, but when you are at the uterosacral, ligature will not work, NSIL will not work. You may need harmonic, or you may need some other device. Now coming to the last part, which I will not dwell too much more, hysteroscopic surgery. I am not showing too much a film of hysteroscopic surgery. All of us are aware about the two type of energies we have. One is the monopolar, which for years and years, somebody like me, Prakash Trivedi, Noser Serier, and the entire world of urologists still use monopolar, still use glycine, still we may have 12,000 hysteroscopic surgeries done. Nice, clean cut, but obviously the disadvantages have been told. Out of 15,000 cases, we had 22 fluid overload, no mortality. But when you're using that, if you're using for fertility and enhancing, it has to be minimum amount of pure cutting current. Obviously, more and more people have moved on to bipolar when it comes to hysteroscopy, Versa Point or new bipolar or even PKS. One catch I would like to tell, in which Vijay Shetty and the anesthetists will agree, you have to remember that quite often people use simple saline, D5, etc. and all. And the blood mixes when you're resecting. So the resection is not as comfortable as a monopolar because the blood mixes. More important is when there is fluid overload, there is hypokalemia and pulmonary edema, which is not rare. So don't count that just because you are using bipolar and because it is not glycine, everything is safe. So finally, I would like to conclude by saying that the simplicity, ease, and expertise with which skilled animated techniques show the benefit of advanced bipolar, vessel sealer, harmonic scalpel, which can be used in difficult and complicated surgery by expert surgeon, is the root cause of genesis of phenomenal morbidity, mortality, of its universal application by untrained person, poorly trained person, by expert and pioneer the moment you are overconfident and you become a little bit casual. Finally, you have to remember in this world, and especially in Ganpati days, knowledge comes, but wisdom lingers. Technology comes and goes, but skill persists. So you have two hands and one brain. Just always keep thinking that what you would like to share, what you would like to use. So basically, energy source in your hand is a tool in the hand of a fool if you don't know how you are using. But energy source is the third eye of Shankar, which can be used most wisely, most judiciously, and most effectively. There will be problem, but energy sources are here to stay. And it's a great pleasure and honor to be in this platform with this wonderful third eye phenomena. Thank you very much, Somil, and thank you very much, everybody.
Thank you, Dr. Trivedi. That was a really energizing talk on all the various modalities of energy, and that was very insightful as to how best apply what kind of energy sources in what situations. And you have brilliantly covered the mechanics and how exactly each energy source functions. I'm sure it has been very beneficial for the audience. Moving ahead to the next speaker in the session of energy, we have none other than Dr. Shailesh Puntambekar, who is the Director and Consultant Laparoscopic Oncosurgeon at Galaxy Care Multispeciality Hospital in Pune. He has patented the technique of radical hysterectomy, which is called as the Pune technique of laparoscopic radical hysterectomy. He has conducted, and with great pride I say this, he has conducted India's first laparoscopic assisted uterine transplant. A baby girl was delivered on 18th October 2018, which also happens to be Dr. Puntambekar's birthday itself. He's the only Indian to be the board member in AAGL and the faculty member of AAGL Oncologic Committee and operating faculty in IRCAD and various other international organizations. I can go on about his CV, and I think we'll take till 9 to finish it, or probably even more than that. So I would invite Dr. Puntambekar to share the dais and deliver his talk, which is on unpleasant and tricky encounters with the energy sources and how best to use them. Dr. Puntambekar, over to you.
Thank you very much. Good evening to everybody. Thank you, Saumil, and thank you, Dr. Trivedi, for giving us this opportunity. And I will now share my screen with you. So 1 minute. Okay. Why is it not going? 1 minute. I think I'll have to again. Can you see my screen, Somil?
Yes, sir. Yes, sir.
Yeah?
Yes, yes.
Yeah. So it's a great opportunity to be here and then to follow up with Dr. Trivedi. I'm going to talk about how you can use your energy sources. Of course, his videos have been very clear about it. We have seen that approximately 40,000 patients suffered from electrosurgical related injuries every year. And 70% of these go undetected at the time of injury. So causes are multiple. Majority of them are basically because of misadventure that takes place in spite of being in the surgeon's field of vision, and majority of them are because of iatrogenic injuries. What Dr. Trivedi said about the lateral thermal spread is not a myth, it is a reality, and it can be caused by various causes which has been already enumerated by Dr. Trivedi. So we all know that there are certain parts of the instruments which are out of the field of surgeon, which you should be very careful about, and they should be very much well insulated. Otherwise, you are going to land up into problem. And this can happen especially when you are using the energy sources like monopolar hook or monopolar instrument. I am not a big supporter of monopolar, but I do use it because I cannot be an hypocrite. We use only monopolar energy source and a bipolar when I do robotic surgery. So monopolar energy source is being still used by me when I do robotic surgery. And this can lead to various problems. You can lead to injuries away from the area where you have applied, and this can be a problem. We know about it, and bowel injuries are very, very common. Every month, at least once, we see a bowel injury caused outside during cholecystectomies or during hysterectomies and being referred to us, and we are doing this. But what we have realized is that there are alternative sites of injuries, and these are actual photographs that we have of certain patients in whom initial days we use monopolar injuries, and there was not good earthing facilities at various hospitals. So you can see that suddenly you have burns which are not at the place where the current was applied, but at some other place. So energy sources, of course, have made laparoscopy easier, but at the same time, with the development, there are certain amounts of complications which have increased. Lateral thermal spread, it is already covered by Dr. Trivedi, but the most important thing one has to see is that there is always a likelihood of spread. When we did open surgery, we never talked about this term, but with laparoscopic surgery, because of the various magnification, we are now talking about this term in a much more way. And these are the differences between the electrosurgery devices and ultrasound shears. You can see this from the SAGES. Heat generation is very, very high, even in terms of ultrasonic energy. So please understand that ultrasound energy also generates heat at that particular level. And you can see the efficiency. These are the various reliability criteria, and you can see that the ligature as well as the NSEAL stands as the maximum effectivity for vessels more than 7 millimeters, and therefore they are being used more and more efficiently on the uterine arteries, which happen to be about 6 to 7 millimeters. So prevention, you should use monopolar energy source, but you should be using them very, very with big caution. Use of newer energy source should be also be done, but with less lateral thermal spread, and always check the energy source before starting the surgery. So you need to check everything, whether the pads are correct, whether the insulation is correct, and these are various things in which you can do it very well. Harmonic scalpel, I'm a big lover of this, but one has to be very, very careful. If you touch your finger with the harmonic on, you will feel the heat, and it can go up to 360 degrees centigrade for a certain time, and you have to be very careful, because this can lead, when you are withdrawing your instrument, can lead an injury to the ureter. So we have to use this very carefully when we are using it near the ureter. And this, as I said, is an area where the gray area of the surgeon comes into play, and the experience of how much you use, how much amount of pressure to be used, and what should be the correct way in doing the dissection. So I'm going to show you some appropriate techniques to use the energy sources. Now, this was a patient of stage 4 endometriosis. You can see that both the rectum and the ovaries are kissing one another, and here using a bipolar energy source on a harmonic at times is disastrous, because the rectum is very, very densely adherent. So can we use a cold scissors? I'm using scissors without any energy source, and you will see that applying small amount of bipolar burst is enough to give the entire area completely well. And you need to follow the anatomy, because what is more important in surgery is not just using the energy sources, but also adhering to the principles of anatomy. Here you can see that we are going with the principle of fat belongs to the rectum, stay above the fat, and you can see with a very, very cold energy. Now here, if you use any kind of harmonic or bipolar, then there is a huge risk of a little bit of damage. Even with a bipolar energy source, then you have to use it with a very small burst, but it is safer to use no energy source and just keep on dissecting in the right plane, and you will be able to find the planes very well. Now, when you are doing the dissection very close to the ureter, you can see the ureter here. And now the bleeding is taking place. The natural tendency is to go and grab the bleeder. But understand that if you have dissected the ureter, it is advantageous. So little amount of bleeding, just forget it. Don't try to be immediately trying to take care of the bleeding. Just retract the ureter, catch hold of this. See the distance where you are holding the bipolar, whether the distance is more than 1 centimeter, so that even if there is a lateral spread, there is no damage to the ureters, as you can clearly see. So this is what is very important. Always don't try to be rushing into taking care of the bleeding. You can use bipolar energy. There is nothing against bipolar, but you have to make sure that you are almost a centimeter away from the ureter, and you can go ahead and do this. Sometimes it is better not to use any kind of energy source. Now again, this was a case of endometriosis and very badly stuck. You can see this patient was operated 3-4 times before she was referred to us. And in this situation, I would rather prefer to use the suction cannula. Again, I would insist, and I would of course say that you stick to the anatomical principles and go according to the principles. Try to restore the anatomy in a distorted area, and you will be in a correct situation. Now, when you do this, again, you can see when you are dissecting this was a patient of a simple radical hysterectomy. We were dissecting the pouch of Douglas. You see the bleeder. Whenever it is spurting, that is the best chance to catch. Now, the reason I'm showing this is not the correct way of doing it. We are directly going and coagulating with the bipolar. There is a chance of rectal damage being taking place. What is more preferred is that this patient, when we dissected and found out later, there was a thinning of the serosa there. So even with a small burst, this can happen. Not every bleeding has to be taken care of. This was a bleeding which took place because of the harmonic doing a nodal dissection. You can see that there is a oozing which is taking place, and this kind of bleeding that you get, then you don't have to use any energy source. A plain simple packing is more than sufficient after doing the nodal dissection. So do not forget that every bleeder that comes into the play is not required to be coagulated. You can use a small gauze piece and then just coagulate, and that should be the end of the bleeding from that side. Now, the use of LigaSure, Dr. Trivedi has shown. But one thing I've realized with LigaSure is that there is a overconfidence with LigaSure which takes place. And as a result of which, what happens is that when you use this LigaSure, there is a chance of this getting very sticky. Now, I am dissecting the ureter. This is a radical hysterectomy. I'm trying to take the infundibulopelvic ligament. We try to take it in 3 areas. And in spite of coagulating very well, what happens, you see, when I cut is that there is still a bleeding. And if I try to take this away, then sometimes the bleeding persists. With a small burst, you have to again go, and still it keeps on coming. So understand that when you are coagulating with the LigaSure, it is not 100% guarantee that it will take place. So, and it sticks very badly. So whenever you are using the LigaSure, you can see that there is a chance of this getting damaged. And when you're coming close to the ureter, you can see that when you're coming close to the ureter, you have to be very, very careful. Now, this is one of the injuries that I would like to show is one of the injuries which took place when I was dissecting with the harmonic scalpel. Just when I was trying to do the nodal dissection, the bleeding started because the blade of the harmonic touched the lower part when we were doing this. And this is where we got a lot of bleeding, just a small blade which was coming in. And this bleeding was directly from the internal iliac vein. And then the most important thing, again, whenever you have a venous bleeding, not a single good energy source works. Please understand that no harmonic, no LigaSure, and not even bipolar works at this present juncture because there is a big hole in the internal iliac vein. At this area, you have to pack it. Once you pack it and take it out, then you will see the bleeder over there. Once you see the bleeder over there, this was caused by a plain harmonic little bit area. You catch the bleeder with your left hand. You can use a bipolar, but then this is again not a surety of not bleeding at night. In this situation, the best policy is then to use a suture because you have already dissected it out. So a plain harmonic scalpel, trying to do nodal dissection, which is a routine thing that we do, and sometimes you can land up into problems which have to be taken care of. Now, these are the areas where is you can do this is something, this is, it's not opening. I think my computer has got hang. Okay. I will again, okay. Are you seeing my screen still?
Yes, yes, sir. Yes, sir. We're seeing the screen, but we are seeing the slides.
Yeah, yeah. So I will just go ahead with the because there was the screen got hung, and I will push it a little bit further. So this is the energy source. Without using the energy source, if I want to do a bladder dissection, now this is a very common situation that we face when we are doing a radical hysterectomy with 2 or 3 cesarean sections. I would prefer not to use any kind of energy when there is multiple cesarean sections which are done, and then you can see you can land up into a very, very completely wrong plane. So we are going between the peritoneum and bladder, and that can be disaster. So whenever you are faced with situation, again come back to the basics. Try to understand what is the most important principle of anatomy. Fat belongs to the organ. I am going above the fat, completely wrong plane. In spite of doing these surgeries on a routine basis, there is a little bit of wrong perception. Then you realize that you are in the wrong plane. Come back and then go below the fat, and then you will find that there is the cervicovesical fascia. So important thing is not about the energy source. Important message that I would like to give you is, which I repeatedly say, is stick to the anatomy, and there is nothing but the anatomy which will make you understand, staying anterior to the uterine artery and the vein, and of course remaining below the bladder. Now this is one area we were doing. I'm going to show you how the energy source can be a disaster. This was a para-aortic dissection being done. There is a bleeder. The bleeder has taken place, and we are continuing with the harmonic. A dangerous situation that we know that we are very close to the aorta. We are very close to and there you see the bleeding. And in spite of the bleeding, we are trying to control it with the harmonic. Now you know that this is a bright red blood, completely spurting, and then you apply a clip, which is another disaster. And then we realized that once we completed the entire para-aortic dissection, the injury was caused by harmonic. You can see that when you use harmonic in a wrong way, we were very confident that we have not damaged anything. We traced the ureter, and to our biggest surprise and of course shock, we realized that we had cut the renal artery. You can see the renal artery being cut there. You can see the renal vein over there. And not only had we cut it, we had again glorified our area by applying a clip. So first mistake was to use a bipolar very close to the kidney vessels, and then to use a harmonic. We broke the renal artery, and additionally we put in a clip. All disasters into one area. We saw the pulsating artery. Most important thing is we realized the mistake. Had we not realized the mistake because we thought we had done a great job, what would have happened is this woman would have lost her kidney. We realized it. We took out the plastic clip, which is not very easy. Fortunately, we realized that there was a mistake which was taking place. We allowed the bleeding to take place, and with the use of 4O proline, we could suture the renal artery back. So we were just plain simple lucky. Important thing, we missed the anatomical landmarks. We realized that we were close to the aorta, but then we did not, and the overconfident moments, and these moments can last from 1 second to 30 seconds in the operation theater. A little bit amount of distraction can lead to problems, and which is what we realized, but we could suture this. The patient did not lose her kidney. We were fortunate, and that is the most important thing. But every time you cannot be fortunate. Now this is a patient where we were doing a dissection of the para-aortic region, and I had used a bipolar. I wanted to use the ligashore over there, and we tried to catch it. We could not catch it, and then we realized that we had damaged the renal vein, so which was very, very big. You can see we have taken hold of this. We are about to use a ligashore. We were trying to take the bipolar in my left hand and trying to take it when it burst open. At this point of time, we opened the patient and we salvaged the patient. But then this was a mistake which took place. But then this is an old video. You can see an old harmonic scalpel. It was a very huge kind of harmonic scalpel, and the blades, because of these blades, you could get little amount of bleeding, and there such kind of bleeders which are coming from the spurters, this is purely because we had used the area very close. We had used the energy. What we did was just a plain simple packing, and that helped us to control the bleeding. So every bleeder that bleeds need not be caught and did not be taken away. You can take care of these situations by just packing. But when sometimes you have caused this, now this was a patient, I wanted to show you a bipolar energy source was used by another surgeon. This patient was referred to us, and not only had they used a bipolar on the rectum, they had also placed a drain without checking the rectum. This drain migrated through the mucosal opening and led to rectal perforation. So first of all, there was an injury because of the bipolar. This patient was referred to us with peritonitis. This is not our doing, and whatever is our doing, I have already shown you, but this was one patient who was referred to us, and you can see that complete charring of the tissues. This is the bipolar forceps which caused the injury. So these bipolar forceps cause avascular injury, and these patients present later. Management is sometimes can be laparoscopic, sometimes it may not be laparoscopic. Then this is an injury which we caused ourselves. When we were doing the dissection, you can see there is a big mass which was the leiomyosarcoma, and the ureter happened to go through that. And once we were trying to do this, what happened was there was a ureteric injury which took place. And this ureteric injury which took place was of such a nature, you can see that we were causing the damage because we caused a little bit we went very close to the ureter, and when the bleeding took place, we realized that we had used a bipolar. So at this point of time, this injury was recognized on table, but fortunately, after recognizing the injury, we decided to put a cystoscope. We could not put a DJ stent immediately, but then we put a guide wire. You will see the guide wire being passed. This was the injury which had taken place. This was recognized on table. We passed the guide wire. Over the guide wire, we passed the double J stent, and through the double J stent, we then placed a complete, we placed some sutures. You will see the double J stent coming in. This is the guide wire going from the top. We placed the double J stent over there, and then of course we sutured it again. But this was an injury which was not caused inadvertently. It was caused because of the presence of pathology over there, but we could recognize it and we could of course suture it back. So this was an injury which you can recognize. So having an injury is not a crime, but not recognizing is definitely a crime. This is what we did. Now this is a patient I want to show you. We did an excellent radical hysterectomy. Everybody is very happy. You can see a nice and good ureters over there. But if you see on the right side, this is where you see that there is a loss of the mesentery of the ureter. There was a loss of the mesentery. We looked at all the places. Everything looked perfect, but there was a loss of mesentery on the right side. We realized that, and we decided to stent the ureters in the post-operative period, in the immediate before we took it. And when we were trying to put a double J stent, we realized that in this time, because of the use of harmonic, and I used harmonic very, very extensively, there was an injury, a small injury which had taken place. But then when we inspected the ureters, we realized that there was an injury, and this injury had caused almost 2/3 of the damage. So then a simple thing was done. We reimplanted the ureter. The point that I want you to make is that these energy sources, you can see the use of energy source. This is ligature. You go with the idea of doing a good anatomical area, but these energy sources, you never realize that they can cause thermal damage. So these are the examples wherein a good dissection was done, but because the mesentery was missing, because we had checklists, we realized that we had damaged the ureter. We tried to pass it. Then, of course, it's a very simple way. We did a psoas hitch. We did the hitching of the bladder, and then we implanted directly the ureter, which is, again, you must have seen it in various videos, and that is not the topic of my contention today. I'm just going to show you how we can get this. And again, this was a patient operated 6 times and then referred to us for endometriosis. The patient was young, wanted a hysterectomy desperately because of severe pain. She had lost she had attempted suicide also, and therefore we decided to do the hysterectomy. But having been done 6 times, there were no planes. In this situation, even if you don't use the energy source, it is good enough. We decided to do the dissection, but you can see that the ureter and the infundibulopelvic ligament were a single mass. We continued the dissection, and see, we did not follow the rules of dissection. We continued the dissection with the scissors. We were not using any energy source, but then we could not identify the ureter from the infundibulopelvic. I was trying to separate that. I thought this is nice and good infundibulopelvic ligament, but after a while we realized that there was no such thing as infundibulopelvic ligament, and it was a dilated ureter which was going there. Ideally, when patient is operated 6 times, certain mistakes that you learn, this patient should have been stented first, but we realized that we had cut the ureter at this area. We traced the ureter. So it is at times not the energy source, but lack of planning which can lead to this, and this is what we realized. And then this was the ureter. Again, we reimplanted that, but not a big deal to do this, but we could have avoided this situation very, very easily. And then, therefore, nowadays, when I do the ureteric dissection, these are the following principles. You can see that there is one artery, uterine arteries branch, which always supplies the ureter. The bleeding never takes from the uterine artery, but from the branch, and therefore cut the branch with the scissors. It will bleed a little, but at least it will bring about the separation. Never take the uterine artery close to the ureter. Take it away. Once you take it away, again you see this is a wrong way, very close to the ureter. Not a good idea to do this, and you can see the dissection, but I want you to see the dissection when we go into the ureteric tunnel. When you reach the tunnel, this is a nerve. Here again, don't use any energy source, because the nerves which are going into the bladder can land up in, you will preserve the nerves without any kind of functioning, because you will be damaging those areas because of the energy source. So in this case, you can see the vein, you can see the area, and do the dissection without any energy source. So these are the areas where you have to be very, very careful. Do the dissection carefully, just the suction, or use this, and then you can do the dissection very well. And I'm going to show you that we are back to using the monopolar and bipolar. This is unfortunately the energy sources which we condemned for a long time. But now we are again with the robotic, which is a new robotic system that is in place. When you use a harmonic in robotic, it is a non-articulating instrument. So you are back to using monopolar, and you can see that when you use monopolar current, how easily you can do it, but it is a most dangerous current. I am going to take you forward to show you how we do into the ureteric area. So when we delve this area, this is the ureter here. And when we dwell into the ureteric area, you have to be very, very careful. This is the lower portion that we are taking into, but I will show you that we are going near the fat, and here also we are using the energy source. You can use it, but follow the principles of anatomy. And now when you come near this area, you have to be careful. Again, we are using the hook, and in the first 2 or 3 patients that we used this, when we used the Da Vinci system, we had problems. Never use the energy source so close to that area. So we have now started using scissors when we go there, and we can see whenever you want to use a monopolar and bipolar, make sure that the ureter is away. But these are the energy sources now still being in use. We are going back, but even then you have to be careful when you close to the ureter. And there, this is the best way to use the harmonic. So I'm going to show you how you can use the harmonic very well. Here, when you want to do the dissection, never do the dissection on the ureter. You should always do the dissection on the anterior part. Now you see the nerves, and there if you do the dissection with the harmonic, these are the nerves which can get damaged. So harmonic should be used just for dissection. No use of energy source. You should not use any energy over there, even if there is a bleeding, because this can lead to damage. Again, never use a harmonic on the uterine vein. We have stopped using it on the uterine vein. We always use the clips. We may dissect the uterine vein, but we never use a harmonic because it works on the principles of oscillation, and because the veins don't have adventitia. So you do the dissection, but never use any kind of energy source very close to this area. You can see, you can cut the uterine, but when you comes to ureter, always dissect the ureter on the anterior side, because the mesentery of the ureter lies on the posterior side. So coming close to the ureter, always use scissors. This is what we do. We always use scissors, and with this scissors, you can dissect the ureter without using the energy source. This is the most dangerous part of the ureter, and you see the vein coming from below. So ureter is like a hamburger. The vein comes from below, the artery comes from above, and coagulation of the vein normally leads to the injuries which I have shown you with the in the previous videos. So we use vein, we use clips. You can use ligature, but we prefer to use clips because if the veins retract, then the dangerous part is to do this area. So once you do this, you see the nerves very, very clearly. Again, on the nerves, we don't use any kind of energy sources because these nerves can carry this dissection. And when it comes to the anterior cervicovesical ligament, this is the most dangerous area where the ureter gets compromised with its blood supply. Even during a total laparoscopic hysterectomy, I do not use the ureter. You can see the mesentery is always on the medial side. So we do the dissection on the anterior side of the ureter, and I use 2 veins. So you can see this is the ureter, the clips on the near the nerve. Never use the harmonic. There may be various opinions, but this I'm telling you with experience that dissection, if it is done only on the anterior part of the ureter, never damages. Don't do the dissection of the ureter on the medial side or on the lateral side because there is mesentery. So go and do the dissection and use cold scissors. It is a much, much preferable methodology. I'm not going to show you. You can, of course, do a total laparoscopic hysterectomy also with the harmonic. So you can see, I'm going to show you how the vessels are taken in a total laparoscopic hysterectomy. Can you do it with this? Of course, you can do it with this. But then when it comes to veins, it still bleeds. As you can see, there is a venous bleeding which takes place. You can take it on level 1, but the veins are very, very dangerous. You can see the bleeding taking place. So plain laparoscopic hysterectomy becomes unfortunately difficult when the bleeding starts, and always have a bipolar in your hand. So I'm not going to show you the para-aortic dissection which causes this, but this is the same dissection which I showed you. And now if you use the area with the harmonic scalpel, I'm going to show you how we can do this. If you want to use the harmonic very close to the ureter, this is the way you should be doing the dissection. You do the dissection with the harmonic. The inactive blade of the harmonic should be always close to the ureter, and only then can you use the harmonic. Use it in 3-clip method, and this is how you can easily do the surgery. So certain principles that you need to use when you want to do the dissection is always and always you should be having the inactive element, which is, you can see the inactive element close to the ureter and the dissection of the ureter. So there are various concerns now. We are almost on the way of our publication. We have done more than 200 laparoscopic surgeries during COVID time. Smoke is the biggest problem which we are facing now. So electrosurgery causes a lot of smoke, and we have converted our majority of the surgeries to using the ligature because it generates the least amount of smoke. But one has to understand that it is a various, we have no evidence to show that there is a smoke which causes the spread of the virus. So thank you, Saumil. Thank you, Trivedi sir, for this opportunity. And I think I have finished more or less on time. Thank you so much for this. And if there are any questions, I will be more than happy to take it.
Sir, that was a fantastic presentation on what all can go wrong with energy. And I think you've covered each and every facet so beautifully, and also taught us the best application of various energy sources and various situations. Now, just one little change is that we have a surprise guest with us. That is Dr. Haresh Vagasya. Dr. Haresh Vagasya is a practicing consultant gynec endoscopic surgeon in multiple institutes in Mumbai, including the Apollo Spectra, Bethany, BSCS, and Jupiter. He has conducted numerous almost close to 68 training workshops in hysteroscopy and laparoscopy, is the course conductor and laparoscopy trainer recognized by EGES, Foxy, and Karl Storrs. He has worked with numerous people, a lot of whom are in the esteemed panel today. That includes Dr. Sanjay Patel sir, Dr. Sailesh Puntambekar himself. He is trained with Dr. Stefano Bettocchi and Professor Keckstein and Luca Minelli from Verona. Now, a special reason for including you today, Haresh Vagasya sir, is that for people who don't know, he is one of the designer and the main person who came up with the shearer. And there are a lot of young people who, in an attempt to economize their surgery and who cannot afford the expensive harmonics and the vessel sealing devices, are preferring to use the shearer as an energy device. So I want to especially ask you about what was the thought process behind the genesis of the shearer and what are the mechanics behind the laparoscopic shearer.
Okay, thank you so much, Saumil and Trivedi sir, for including me. And it's a special thanks. And again, I'm on the platform wherein the stalwart like Dr. Puntambekar sir himself and Dr. Trivedi sir himself are there. And they have already covered most of the things in electrosurgical things. Now in 2011, I bought my Gen 11 harmonic first. And at that time, I did not realize, but I had to actually decide between buying a Fortuner and buying Gen 11. And I thought maybe it will add to my financial goals, and eventually I will buy the car that I wanted. But actually, it did not happen because the next year, Johnson & Johnson came up with something called as a counter in their handpiece. And then I met Dr. Zoravin in one of the conference and had dinner with him, and he was suggesting that they might come up with a counter or something like limitations into the harmonic probe as well. And then I just asked myself that harmonic probe actually is supposed to be used once, and we are using it multiple times. Now, will we use this on our mother? There are no ways that you can clean this instrument to the standard way of doing it. Otherwise, the company would have written it, that it can be used twice or thrice, 5 times. Only in the countries which are having a low socio-economical backgrounds, or the poverty population is really very high, we think of reusing so that our own and the patient's own pockets are preserved. Now, I said rather, why not have something which is really an Indian? I mean, that time Make in India was not a concept at all. But have Dr. Prakash Trivedi, Dr. Sailesh Puntambekar, Dr. Sanjay Patel, wherein all foreign surgeons come and learn. I've seen all of these people have taught all foreign people who are saying that they are pioneer with holding their hands. And I said, why not we have our own things? Then I just had a talk with a company called Allen, and we formulated some waveform of an electrosurgery bipolar, and the modulation was such that we initially tried on a multiple jaw. So initially we used to have Bissinger or a Robbie, or as Prakash Trivedi sir mentioned, various jaws which will have a good grip on the tissue. Rather, we came up with something else. I said, if the electrosurgery has to do the work, there should not be the grip standard, or should not be the factor. So we came up with an idea that when two circles meet, they meet at one point. Okay, they never meet on a line. So when a current meets at a shortest point, the effect is nothing but evaporation or vaporization. So that's what makes this tissue cut. And most of the surgery is nothing but cutting. Like when we were resident, we were always saying, when you're not getting surgery means you're not getting cutting. So the basic idea was to cut. In most of the surgeries we cut. Now we came up with an idea that only if this instrument cuts, it does not serve purpose, because there are many things a surgeon can cut and get away, as Sarvesh Mintambekar sir very well said, that when everything fails, nothing but a clear surgical anatomy works. Now I said that what is to be done? So we now have a different mechanism on which the same instrument works on two manner. One is coagulation or sealing, and another cutting. So if you are very well versed with most of the other equipments using two pedals, coagulation and cutting, right from monopolar to harmonic and all, only for bipolar we used to have one. So we have two pedals now for sealing and cutting. So then we got, we don't have to use continuously change the instruments, and that saves a lot of surgical time. So that was the principle. That's the main thing.
Right, sir. I would like to ask Dr. Puntambekar and Dr. Trivedi whether they have an experience with using this shearer, and also Dr. Vagasia to comment on the safety of the shearer as compared to the various other energy modalities discussed by the other two faculty. So, Dr. Puntambekar, what is your opinion about the shearer as a technology? Have you used it? And
I have used it. It is wonderful.
Right,
and
sir.
actually, I would like to congratulate Harish, because he has been using this. I have seen him using. I have personally used it, but when you become, the source is very good. You can use it very, very safely. I have used it on various cauteries, including Shalya and our this Valley Lab cautery. Unfortunately, I am too hooked to harmonic. Sometimes when you are 50 plus,
yes,
you get used to something and then you don't want to change. So that's how it is. But yes, two of my students are using it on a routine basis. Arvind Kumar from Delhi is using this shear on a routine basis. He saw Harish using it. And another person who is in near Belgaum is Dr. Srikant. Both of them have the shears which are by Harish, and they are very happy. And I've seen them doing wonderful jobs. So they are very good. But I don't use it on a routine basis, though I've used it.
Dr. Trivedi, your take on this?
I'm a poor man. Only if Harish Vagasia gives me, I can use it.
Sure, sir. I will do that. No problem.
No, I don't have experience. That's why I had a discussion with Harish Vagasia also about the principles and all. And it's good to know that people work on instruments. All of us work on instruments. But as Sailesh points out, at a certain stage, you really become used to certain set of instrument. It doesn't mean that bipolar and Caesar will not do anything. But once the comfort zone is there, and the companies are smart, so Sailesh, me, Sanjay, and everybody, company keeps upgrading the. And my method of this is just a general practical point. I think the Sailesh may be having better. Usually, I purchase all this handle in bulks, like 30, 35. So when you purchase in bulk, the company look you in a different perspective. And that was for NCL, that was for this harmonic. And when you purchase in bulks, of course, you also get bulky rewards. And now, today, I'm going to get one gift from you is the shearer out, how to use. And once you give me, then I'll use one.
Definitely, sir.
Dr. Vagase, coming to the safety bit of it,
Yes.
which has not been
Yeah.
addressed, I would like to know from you as to what is the element of lateral spread with the shearer. Is it as safe as the harmonic? And what are your comments on that?
Yes. I would just go slightly away from your questions, if you allow me. It is from both Dr. Prakash Trivedi sir and Dr. Pundambekar sir's lecture. It is so much evident that any energy source, as Trivedi sir very nicely said, that the tool in the hand of a fool, is going to be like, so is going to make him fool. So I don't think it is the tool which will make you any safer. It just facilitates a good surgeon to come to an excellence or an excellent result, or maybe facilitate to do surgeries at a much comfortable level, achieving a best result for the patient. Now, of course, using an electrosurgical thing was the thing. Like when I was with Dr. Sanjay Patel sir, and then I went to Dr. Puntambekar sir, they kept on saying one thing: there'll be only two advancement in endoscopy. One is the vision, and the second one is the energy. So I always got this thing in my mind that if I have to retire early, what I can invent. So I just kept on thinking about vision is not possible, so let's concentrate on energy. When we formulated everything, we have 3,500 pages of patent ready for it, but somehow bipolar is an energy. You just cannot patent an energy waveform. So we now come with a jaw and a different design and making that as an entire document to have a patent on. But meanwhile, you have lot many companies making this and manufacturing, and people are benefited with it. It's fine. There is no issue about that. The safety wise, we have used it on a dog tissue first, on a pig intestines first in vitro, and then we tried doing it on patients. Basically, there are no scientific studies, but only on the in vitro studies we have seen the measurement. Even a histopathology report of those tissue we have sent, and the standardization is maintained. So what I would say is that the thermal spread or a damage, if the surgeon is using it very well, then it is as compared to any other electrosurgical device.
Dr. Puntambekar, there's a question pertaining to something you have mentioned in the talk. So when the harmonic is hot, what is the cooling time or the cool down time for which harmonic should be cooled down before you touch anything important?
Actually, it is the time to contact. That is the most important thing. That is, if you have a contact time of more than if the contact time is more than about 3 to 4 seconds at one particular area, that's the time where it comes into a higher energy sources. So it's not about cooling. You don't have to cut and then cool down the harmonic. You just have to keep on moving, but you should not remain at the same place. So when you cut the harmonic, the uterine with the harmonic, you hold it there and make it into 3 clip method. So you're measuring for more than 3 to 4 seconds. If you really touch that area, it is very hot. And that is the reason we always say that whenever you are doing this, the inactive element should be on the ureteric side, because even if you are cutting just the uterine, just the temperature generated on that uterine itself can touch the ureter down, leading to a avascular injury. So that is one of the things, and then you are surprised that everything has gone off so well. And what is it that how can I have a ureteric fistula? So we had these problems initially, and therefore it is important to realize that harmonic is not a very safe in terms of energy. Up to more than 300 generation, you can just touch your finger once and you will find that there is a burn there. That takes place.
So can I add one thing? Let's have a patient of fibroid, anterior posterior wall fibroid, vasopressin given. When you're making an incision with harmonic, you are not worried. You'll go ahead, you will make continuously, you're going ahead. The issue, what is told is that anything more than 7 seconds, or accidentally if you touch the tip with your double glove also, you'll have burns. So the point is, suppose if you're say doing colpotomy or some other thing, wherein you can have little longer movement, but primarily it has to be shorter burst, clear work, give a little time. So you're not actually allowing it to cool. You're just giving a shorter burst, especially close to important dissection. Shorter burst, next little gap, shorter burst, and then most important, after short burst, don't make the active blade rest onto the intestine or the bladder, because again still it is hot. So you don't actually allow it to cool, but short burst under vision, then short burst under.
Now, this is a question which is asked by a lot of people actually. Now, if there was one energy source which you were to choose based on the indication, I think what would be your energy source of choice for a simple hysterectomy?
Sailesh.
And do we have a technology wherein just one instrument does it all?
No, there is no one energy source which you can choose, but one energy source which you cannot dispense of, in spite of having the best of the sources. I would put it the other way around, is a bipolar. So one energy source you cannot dispense of. I would rather put it, you can use anything that you want, but bipolar has to be handy. It is the only savior in majority of the times. That's what I've realized.
So the title today is third eye. So third eye means you need a ligature, you need a harmonic, and you need a very good bipolar. This is the combination. Obviously, you have Caesars. So basically, see, all of us, male and female, have a passion of cars and this and that. Females have a passion of jewelries and all. We don't worry too much about the cost when we go to that. So when people are investing on energy, they should not count that they have to recover it from the patient. Because if they try and find one definite energy for all, nobody in the world can find it out.
Sir, one question to Dr. Puntambekar and all the other expert panelists can also take it. I think you have addressed this in your talk, but circumstances wherein you will definitely not use an energy source. The second thing is many of the times injuries which you showed so many of them which gave an account when they have occurred with energy device or thermal damage. So many of the times these are things which can be missed intraoperatively. So how do you judge the viability of the ureter, of the bladder and of the rectum?
Yeah, that is a very good question. So I always say that there is a checklist. We always follow a checklist before the surgery. We should also follow the checklist after the surgery. After the surgery, three things are important. Number one, you have to make sure that there is no hole in the rectum by pushing the air. Number two, fill up the bladder, especially not in all the patients, but where you have found the dissection to be very, very difficult. And third important thing is to inspect the ureters. In one of the films I showed you, when we inspected the ureter, everything looked perfect. But then we knew that there is a loss there. In the middle part, there was a loss of the mesentery, and would have 100% led to a fistula. So inspect the ureters. And I would also give one more advice. If you have any difficult situation where you have struggled on the ureters, do not have the ego, just stent the ureters in the post-operative. Just do not worry, just stent them. It doesn't make you a bad surgeon, it just makes you a safe surgeon.
In terms of cystoscopy and bladder integrity, any points particularly to look for?
I do not believe in cystoscopy because worldwide they have shown that cystoscopy, you may get the ureteric, you may get a urinary burst at that time, but it is the avascular injury which actually presents on the 6th or 7th day because of the injury. So it will show the gush because it's finally just the fluid which is coming in. So I think it's not a good idea to do it.
Sumil, one answer to the question is you have to remember the word procrastination. In laparoscopy, usually what happens is, suppose if there's an area which is little red, then the camera is immediately moved away. So what happens is, when you doubt that something is normal, you or somebody always tries and makes a decision of not taking a decision and goes to the other area. For example, I have doubt on the right side. You start dissecting on the left side. So procrastination is the root cause of all these injuries which can be missed. So you have to be proactive. A, first to avoid. B, you have to listen to your assistant, your anesthetist or your OT OT tech, because sometimes, the other person, third person's opinion is very important. Most important, whenever you have doubt, clear your doubt rather than leave the doubt.
Coming to a very pertinent question, but we can have an entire seminar on this. So I would restrict you to limit it to 2 minutes. What is the safety of energy sources and your preference in the current COVID times?
My preference is Ligashore. It generates the most minimum amount of smoke. And bipolar, of course, we have to keep it ready, but it still generates the smoke. There is no evidence to show that smoke is having virus. Right. But we are all worried about it. So in the last 4 months, our use of Ligashore has increased considerably, where our use of harmonic has gone down. I think we are becoming bolder day by day. And in the last 15 days, we have also started using the robotic system with the smoke evacuation. Right. But in the first 3 months, when we didn't understand the virus, Ligashore was our choice. And still today, our people are using, and I am also using a lot of Ligashore because I am not happy with the smoke that is generated.
I think in terms of quantification, I've read a few papers which state that harmonic generates almost 6.4 millimeter of plume, and that with the Ligashore is probably around 2 millimeters. So that is just something for the benefit of the audience, which I would want people to consider in the current times. But obviously, I don't think the safety of endoscopic surgery is as such under debate. I believe you would agree to that, sir.
Amil, can I add a little thing?
Yeah.
This is an UPLIFT program. We opened the third eye. Just give me a month. We have already found what and how to do surgery, laparoscopic surgery, with all the things you are using, which is under publication. So it is like sub judice, I cannot declare it. But by next UPLIFT, it will have the technology, and then the same technology as a multicentric will be used by Sailesh, Sanjay, Harish, you name everybody, Alka, and so many other people. Then India will be the first country which will have absolutely foolproof method of how you can do laparoscopic surgery during COVID times.
Fantastic. Now, coming to another avenue altogether, we have discussed about the safety of energy sources in laparoscopy. I think Dr. Trivedi mentioned in his presentation about the use of energy in hysteroscopy. So my question is to Dr. Vagasya, who I think does a lot of office hysteroscopies and prefers using a mechanical energy whenever feasible for complex hysteroscopy as well. So your take on the use of energy, your preference in terms of monopolar, bipolar, and what impact it can have in fertility enhancing surgery.
Okay, so it's a fantastic question, and we have master resectoscopic surgeon on earth. One is right in front of us, and another one is in Egypt. There are many in Italy and world over, and of course one in Paris, who's the father of resectoscope. So if you ask all these fathers, they would say monopolar is the best current. And if you see the cutting quality of monopolar, it is still versatile. It cuts like a blade. So, if you are sure about a small myoma, if you're sure that, you're not going to do too much damage to the endometrium, I think it is more, again, on a surgeon dependent thing than choosing one thing. But if you ask me today what you should buy, bipolar, I would say, is the answer because it has multiple advantages. One is that the thermal spread. It definitely works, within the cavity. The current doesn't spread. There is no chances of leakage. However, the hybrid resectoscope, what people are using in India, makes the entire resectoscope as a return plate, cannot be used in office hysteroscopy because patient will have something called as a sort of a feeling wherein patient is really having a stimuli continuously in the vaginal area. So patient will jump. And with the electrosurgery on, if the patient jumps, it's going to be disastrous, whether you're using monopolar or bipolar. Another advantage bipolar gives is you don't have to change the fluid. So that's, I think, is one of the bigger advantage, wherein if you have, there is no dearth of normal saline in the OTs, but if you are not carrying normal saline in the endoscopic unit, or the facility wherein you have the patient, you have the pathology, you have good anesthesia, but you don't have too much of glycine, then you are in a fix and you have to do something, so the bipolar, I would say, is the best in hysteroscopy. Another thing is that bipolar, when you have this bipolar is slightly higher in amount that what we are thinking as a bipolar which we use for laparoscopy, because the water is a medium in which we are using, while other which we are using is in a carbon dioxide. So carbon dioxide does not hamper the thermal property of the current which is being used. However, water or glycine changes it a lot. If the glycine is at room temperature, means it is colder than the body temperature for sure. So if it is colder than the body temperature, means you have to adjust. There is a thermal coefficient which is calculated, and then the setting is made on the generator. There is elaborative thing which actually we don't have to know about it, but if you know it is better. So the current at which you use is much higher than the current that is used in laparoscopy. That one has to keep in mind. So every time you do the action of cutting, it should be rapid. It should not be for long period of time. Like if you're activating a blade for a longer period, it will make the entire fluid in the uterine cavity hot, and that can affect the endometrial viability. So I think these are certain points. Of course, it can go on and on for a lot of time, but then this is the gist. These are certain principles that you have to adhere to.
Dr. Trivedi, your take on use of energy in hysteroscopy? Especially in pathologies wherein probably, like, say, a septum or an adhesion wherein something like a Caesar or a mechanical energy can work. What is your preference?
I'll clarify it in an elaborate fashion. Myself, Moses Sherrier, and the whole world of urology didn't need extraordinary gadget. So I have no problem when you have, in fact, last AGL, you remember we had Bitoki in our OT, Bigatti in our OT with 4.5 centimeter fibroid, and both of them told guidelines, this, that, etc. In the meantime, I finished first, then I finished the second one. Now the point is, if you are a resectoscopist since 1993, now if you see urologists don't do so much of changes in their approach and all. So I don't have any problem as far as glycine and monopolar is concerned. The cut is superior, fluid control has to be managed. When you come to bipolar will mix with blood, and bipolar fluid goes and changes the level of potassium and also leads to pulmonary edema. If you are to do a 5 centimeter fibroid with a bipolar resectoscope, and this, just pardon me for using the right name, but some expert was using in Pune, he had pulmonary edema, somewhere else also had pulmonary edema. But what Harish is telling is correct. If you have miniaturization of pathology, septum, then if you have a smaller fibroid or polyp, or etc., and you're beginning your career in resectoscopic surgery, there is no debate you have to take a bipolar resectoscopy.
Right. Sir, only thing about the urologist thing which you mentioned, because in resectoscopic surgery involved in the uterus, fertility becomes a big challenge,
yes,
which probably the urologists don't have to deal with. So, I think the world is now moving to mechanical energy, and I personally am a big fan of monopolar myself, but that's because unfortunately I'm only 34, but I am also getting used to a certain thing. But I think in terms of evidence,
one small point, Somil, all this evidence that Caesar benefits in infertility, that bipolar is superior to monopolar, none of this are evidence based. There are no evidence to suggest. So if you use the least amount of pure cutting current with monopolar, if you use a good bipolar in proper setting, or you use Caesar, outcome are same. There are so many complications in meta-analysis. It is only that it is difficult for people to purchase a new bipolar, so they have to show the advantage. And of course, glycine had a big disadvantage. In fact, that is one area. But at the same time, I think so we have to move with the technology. And what I would suggest is the resectoscopic surgeon should become to an advanced level to use any energy, left hand drive, right hand drive, it is all right.
So I think what you mentioned is very correct because, sir, in expert hands, a monopolar works fantastically. Now the problem is when someone who is a novice surgeon who is attempting resectoscopic surgery, as Dr. Harish Vagasya also very rightly mentioned, you have to be very rapid with taking the cuts and everything. Sometimes when the area of contact is and the time of contact is too much, which sometimes can happen with a novice surgeon, that is when all the hazards of the energy probably set in. Dr. Vagasya, your last comment on this, and then we'll move on to the next session.
Yeah, okay. So what I understand from most of the theories, practical and experience of all the stalwart is that the bipolar generator remains same, the harmonic remains same, the unipolar or any other generator remains standard. It has its own principle. What is the difference is the surgeon. Right. Surgeons are variables. If we consider, say, 1 billion population of a surgeon, every component is going to be different. So, we have to get standardized into technique rather than technology.
Right.
I feel that will make the entire difference. And that's what sir said, that, you can do that. And if you can do that, that will be wonderful.
Saumil, thanks. It was a great session.
Yeah. Thank you, Dr. Puntambekar, Dr. Vagasya. I would
Thank you very much. Thank you.
I would request you to join in for the extended Q&A, sir. So if you're available, then that would be great. Now moving on to the next facet and the next session of the today's Third Eye program is a very intriguing session. It is very titled also very aptly. We are divided by speciality but united by the eye of endoscope. And this session is a true epitome in the current times wherein we can so easily liaison with our cross-speciality colleagues and there are so many cross-specialities involved in gynecology itself wherein we might need help from our urology colleagues, from our general surgery colleagues or the gastrointestinal surgery colleagues. And so there are sometimes really situations wherein they come in handy in cases which are assumed to be of difficult pathology in planned surgery and sometimes wherein they actually come to rescue us in certain complicated scenarios. So the next speaker that we have is an extremely talented consultant that is a GI surgeon, that is Dr. Lakshman Khiria, who is graduated from SN Medical Jodhpur and has his MCH in GI surgery from AIMS. He's currently the senior consultant at Apollo Hospital in Ahmedabad and is performing all kinds of complex and advanced GI surgery. And he would like to share with us his inputs on endoscopic surgery along and beyond the gynec expert. So over to you, Dr. Khiria.
Good evening, friends. Thank you, Saumil and Dr. Trivedi, giving me this opportunity to share the experience. Can I have the slides, please? So today's topic is working with gynec expert and beyond. As such topic is very philosophical and I'll try to be as pragmatic as possible with the topic. We all know that laparoscopy advanced to a significant level in last 3 decades. And it evolved from the diagnostic procedure to one of the most complex procedures up to transplant can be performed with the laparoscopic technique. As far as working with the other expert is concerned, it is the anticipation of the primary surgeon whether he need the help of cross-specialty expert. That is the most important. And if you realize that it is required, then it is always advisable to call for help at early stage rather than at a later stage. I worked with Dr. Sanjay Patel for a couple of years and we have developed such a rapport that our life is very comfortable when we work together. There is a minimal or zero stress when we work together. Environment is very friendly. So this is the one thing. if you develop a good rapport with cross-specialty experts, it is always good. I will try to cover this topic in 3 headings. One is GI complication, why they occur, when they occur, and how to diagnose and manage them. In the second part are the tricks of working together as a team, what one should know and how to behave in that particular scenario. And if you work in the synergy, then what can be achieved. Next. So we all know that complications are bound to happen as the indications are expanding for laparoscopic surgery. Now more and more complex and advanced cases are being performed laparoscopically. So there is increased incidence of injury to the adjoining areas as well as in the remote areas, which are in the blind areas of laparoscope. The reported incidence is variable from 0.2% and 0.3%, and this can be because of the various reasons. Major laparoscopic surgery associated with higher complications up to 18%, but the actual incidence may be more due to different definition of complications used and the different level of surgical skills and the different study population, various kind of patients at different level of surgeries, complicated surgery, diagnostic surgery. So there is a difference in the study population, and there is inherent bias of reporting. Many surgeons would not like to share their bad experiences in public. Next, please. So why do they occur? There are 3 basic important things which can be difficult anatomy, difficult pathology, and difficult surgeon. These 3 are the confounding factors which are responsible for any sort of injury. Difficult anatomy means there are previous intra-abdominal surgeries or abdominal sepsis which has resulted in extensive adhesive formation, or there is a long vertical laparotomy incision. So there are gluing of the intestine to the scar site. The difficult pathology means endometriosis, advanced grades of endometriosis, pelvic infection that can lead to frozen pelvis, large masses, more than 500 grams, they are difficult to handle with laparoscopic instruments, and the bowel distension because of the anesthesia or preoperative bowel preparation or inadvertent injury to the gut that can lead to bowel distension. Then the difficult surgeon. This is the most important thing one should realize and understand, that one should put the ego aside and accept the limitation of the skill and their setup. One should not boast about that we have the best of the setups and we can do the advance of the surgery. In the primitive setups, if you venture at difficult surgery, there are going to higher risk of complication. And the difficult surgeries are generally not difficult. We make them difficult. Next, please. So how do they occur? Majority of injuries, more than 50%, are related to the access to the abdominal cavity. That is the pneumoperitoneum creation and the initial diagnosis. And that can, various options have been devised to minimize that. So Varys needle is one of the technique, that is a blind technique. Another is open technique to minimize the access related injury, in which Hessen's technique is used. And the third is optical trocar technique can be used, but studies have shown there is no difference in the access related injuries. But the important thing is when to suspect that there is going to be a potential GI injury or associated injury, then there is asymmetrical distension when you create the pneumoperitoneum, when there is high insufflation pressure, when you aspirate bowel content through the Varys or in the port, or if there is a foul smell, one should be suspicious about that and one should not neglect that. Second thing is intraoperative manipulation. Incoherent movement, uncoordinated movements can result to the crushing of the intestines by the graspers. That can lead to that because of the thermal damage to the surrounding organs, inappropriate use of thermal energy. It is the master who is responsible for the slave's activity. And here the master is the surgeon who uses the energy judiciously, and based on that, his experience, he can utilize them to their optimum utilization. Then there is an accidental overshoot of the instruments that can result into the perforation of the bowel or the surrounding vessel or to the ureter, bladder, whatever is in the adjoining area. So one should have appropriate ergonomic movements while doing surgery. Next, please. So the various sites can be affected in the injury of the gastrointestinal tract. Small bowel is the most commonly affected area, followed by large bowel. Stomach injuries can be there, but they are rare. Mesenteric vascular injuries are reported, and the solid visceral injury, rarest of the rare. They are more common with GI surgical procedures rather than gynecological procedures. Next, please. So how to diagnose? The diagnosis is the key, because if it is delayed, it increases the morbidity and mortality significantly. So one should diagnose as early as possible, but unfortunately, they are diagnosed only in up to 50% of the patient. I wish here we should have third eye so that we will not miss them. As the topic says, the third eye of the endoscopy. Here I genuinely wish that we should have that third eye so that we will not miss anything which can be detected post-operatively. So the intraoperative diagnosis is very important, and for that you have to be vigilant about the smell, bowel content and the various aspiration, bowel lumen visible or the mucosa visible while laparoscopy. The post-operative diagnosis is suggested by the peritonitis or abscess formation, abdominal distension, vomiting, unusual post-operative course of any patient. One should be suspicious about that. Patient who is having pain, fever, tachycardia, tachypnea, there is drop in urine output. Labs suggest leukocytosis, raised in CRP level and procalcitonin level. Whenever there is a doubt, one should go for the CT scan with oral, rectal and IV contrast. And that is the gold standard for post-operative assessment of the patients in which you suspect a bowel injury. Next, please. So the key to the management is early diagnosis. But unfortunately, the thermal injuries, they are detected later. On an average, small bowel thermal injuries are detected 5th day, and the large bowel injuries are detected on the 10th day of the surgery. Majority can be managed laparoscopically, depending on the surgical skill of the surgeon or the availability of the experts. Injuries caused by various needles generally managed conservatively if there is a single puncture, because the muscularis will seal the mucosa. But if you see the site of the puncture and mucosa is spouting from that puncture, then it is always advisable to repair it with the 3-0 Vicryl or PDS, whatever is available. Bowel laceration and perforation management depends upon the size of the injury, the type of injury, whether it was a mechanical injury or the thermal injury. Mechanical injury means laceration caused by excess related to the trocar related injuries or various related injuries, or intraoperatively due to the seizures or the instrument related, and the thermal injuries. In the mechanical injury, the repair is generally with the margin fractioning and we oppose with the suture, while in the thermal, as the topic is nicely covered by Dr. Trivedi and Dr. Puntambekar, there is a lateral thermal spread, and up to 5 centimeter has been reported in the small bowel or in the large intestine. So whenever there is a thermal injury with perforation, it is always advisable to do a resection anastomosis. Whether it is covered with diverting stroma or not, that is a secondary issue. Then the third point which is important is location of injury, whether it is the stomach, small intestine or the large bowel affected. Stomach and small bowel has a very good vascularity. They can be managed with the primary repair, but the large intestine as such has very limited vascularity or the doubtful vascularity, and the wall is thin. So it is better to do a segmental resection with or without covering stoma. And the fourth important is bowel preparation status, which itself is a controversial topic. Many surgeons advocate bowel preparation. Many do not. They just go ahead with the surgery. But if bowel is prepared and there is a perforation, you can get away with the primary repair of the perforation. But if bowel is not prepared or partly prepared, then you have to do a diverting stoma in these patients. And the most important thing is, again, surgeons' experience, how experienced they are in dealing with this type of complication. If you are not experienced, then call for the help. Don't hesitate. Put your ego aside. Just think about the patient. Next, please. Small bowel injuries, primary closure in 2 layers is a standard procedure. Resection anastomosis is advised when more than 50% circumferential loss of the bowel or injuries associated with vascular compromise. When there are thermal injuries, it is always better to do a resection anastomosis. Large bowel injuries, primary closure in a prepared bowel, as I already mentioned. In the right colon, they require primary resection anastomosis without diversion, while the left colon, primary closure with proximal diversion is a standard procedure. Next, please. So the second part of the topic is more of a philosophical topic, working with a gynec expert. What I have been observing for a couple of years while working with Dr. Sanjay, I have realized that we should have a sound knowledge of the anatomy, not only of the primary organ for which we are operating, but also for the surrounding structures. When you are operating on the uterus, you should know the anatomy of the ureters, vessels, urinary bladder, rectum, and the small bowel. The coordination of expert is a must. You should be on the same page rather than thinking differently. Your thinking should be unidirectional. It cannot be a diplopic vision. It can confuse. So always work in coherence with the primary surgeon. Do not contradict. Just try to be polite and be firm in your opinion and anticipate the need of the surgical procedure so that you can facilitate the procedure in a smooth manner. Always motivate the primary surgeons. Do not be arrogant. Do not be overconfident. Try to be submissive and encourage the surgeon to proceed further. You are not in a competition to prove your supremacy. Always be submissive and helping. There are different type of difficult surgeons. So try to avoid intimidation or a disruptive behavior, which I mean you should avoid emotional or verbal outbursts in the operation theater. You should be working in cohesion with your primary surgeon. Next, please. So by working together, what can be achieved? I'll share some videos of the advanced laparoscopic surgery in which segmental resection and anterior resection we did together, discoid resection, and the colonic perforation repair. Can I have the videos, please? So this is the first video which we are showing a visualizes in a young lady who had recurrent intestinal obstruction. She had primary disease of endometriosis. She has tenesmus was the main complaint, and digital examination of the rectum showed irregularity and the fixation on the anterior wall of the rectum. So we did the shaving of the nodule and repaired seromuscular sutures. You can see that it is infiltrating deeply into the rectum. So the mucosa is opened and ultimately it was converted into a discoid resection. And this was repaired transversely with 30 Vicryl interrupted sutures. So this can be an accidental opening into the rectum if it was not anticipated beforehand. And in that case, it will be an unplanned surgery and the outcome may be different. But if it has been planned beforehand that this can be a possibility, so we were together, we managed it nicely, and the outcome is safe. We checked the integrity by air insufflation and there was no leak and the vascularity is also good. This is post-operative specimen. This is a hard endometriotic nodule. This is the second patient who had difficulty in passage of stool. She has grade 4 endometriosis with non-functioning left kidney, and this is the procedure which is showing nephrectomy on the left side. Small contracted non-functioning kidney been removed. This is rectal mobilization. You enter into the holy plane. In endometriosis, the technique is slightly different than conventional low anterior resection. Here, we normally dissect the ureter and the pouch of Douglas first, rather than directly dissecting the inferior mesenteric artery. Here, we have to safeguard the ureters first, dissect on both the sides, and then we'll clip. This is nephrectomy part. Ureter is clipped at the lowermost part and specimen is separate. Uterus is densely adherent to the anterior abdominal wall. It has been separated with using the harmonic. We use most of the time harmonic. We are comfortable with harmonic, although anything can be used, but we feel more safe and secure with the harmonic. The rectum is mobilized. This is the lateral rectal fold. This is the most difficult dissection in the endometriosis when pouch of Douglas is obliterated by endometriotic process and it becomes a frozen sort of thing. It requires a lot of experience, and Dr. Sanjay is the master for this dissection. I really envy him that I should learn this technique, how to go directly into the pouch of Douglas and safeguard the rectum, and we can bring it down. It directly attacks on the Denonville fascia, separates the rectum and the vaginal fornix. So the rectum is mobilized up to the normal looking area of the rectum, which is easily distensible and safe. You can see the healthy rectum visible. So this is the inferior mesenteric artery pedicle, which has been isolated and clipped. Many of the gynecologists do not do this step. They just attack on the affected area and they remove the segment, small segment of the rectum. But what we do is we just resect the upper part, dissect it, and divide the inferior mesenteric artery to get the more mobility of the segment, so that anastomosis is with least of the tension. If there is a tension at the anastomosis, then there is an increased risk of leak from the anastomotic site. So you have that good laxity of the lax upper segment. All the fat of the mesorectum is denuded from the rectum, healthy looking rectum, and we divide with the endo-GI stapler. 1 or 2 firings are required. And this segment, affected segment, is delivered through the colpotomy or the vaginal opening after hysterectomy. I freshened the margin. We put the purse string suture, examined the specimen, applied the purse string, put the anvil inside. Purse string in place. Now anvil is placed and then the suture is tied. So it will be nicely, snugly fitting around the anvil. This part is repositioned back. Fat is denuded from the anastomotic site. Repositioned inside. And one should ensure that it should not rotate. Anterior surface should be anterior. Anterior tinea will be the guide. And position in that way. Stapler is introduced per anally and it is engaged with the anvil, approximated and fired. You can see nicely, easily fitting mobilized rectum without any tension. It is assuming the contour of the sacrum. Otherwise, it will be just like a bowstring in the sacrum that will be under tension and that can lead to the leak. And nicely, donuts, complete. Again, we check the integrity of the anastomosis by air insufflation, ureters, ureter, urinary bladder. And he's my mentor and guide, Dr. Sanjay Patel,
My guru.
with whom I normally work. Whenever he invites me, I enjoy his company. This is another patient. This patient had fibromatosis or leiomyomatosis. He underwent myomectomy and morcellation was done, and there were multiple implants of the fibroid all over the peritoneal cavity, up to the diaphragm and under surface of the liver. We removed all of them. There were few deposits on the rectum and the rectosigmoid. We excised them although we were taking all due cautions, precautionary measure, we did rectal insufflation also, we put a drain, but unfortunately in the post-operative period, post-operative course was not smooth and there were signs of intra-abdominal sepsis. We investigated with rectal contrast study which showed leak from the rectosigmoid area. We did a redo surgery, that was a laparoscopic surgery. We mobilized the rectosigmoid, identified the perforation site, repaired it. You can see the mucosal pouting here. So remove all the flags and try to visualize the opening. We remove the flags and you can see the opening here. Yeah. We put 3 interrupted sutures, closed it and did a diverting stoma. These patients need copious irrigation with normal saline so that to minimize the infected fluid into the perineal cavity, we identify the ileal loop and taken up as a diverting loop ileostomy. So there is nice spouting above the anterior abdominal wall. And this finishes the surgery. Thank you very much.
Thank you, Dr. Lakshman. Those videos were really a treat to watch, and it really goes to show what we can do in liaison when we work, as you rightly pointed out, the philosophical bits of working as a team and leaving the ego aside. It is wonderful what wonders we can achieve for the quality of patients and the good healthcare of our women patients when we work in liaison as a team of gynecologists and GI surgeons. Lovely videos, and please stay back. We'll be having a lot of questions after this too. So coming to the next speaker, the program, our program has a hallmark and a highlight. We always end with a bang. धमाका हम हमेशा end के लिए छोड़ते हैं. And proving this point is the last speaker for today. That is none other than Dr. Sanjay Patel, who is the director of Mayflower Women's Hospital in Ahmedabad, which is a center of excellence in endometriosis and gynecological oncology. He's the first gynecologist in Asia to perform laparoscopic Wertheims, the pioneer for bowel resection for endometriosis in India, and has one of the largest series of tubal microsurgery and adenoma resection. And he is going to be presenting his dhamakedar video on management of major vessel injury, the story of survival. So over to you, Dr. Patel. Aag laga dijiye.
Thank you, Soumil. Thank you for the kind words. First, I would like to thanks to the Dr. Trivedi and heads of you, Dr. Soumil. Today, I am very happy because Dr. Harish Swagasia with us in this forum, and due to this, Dr. Trivedi is allow us allow to Harish to speak related to this innovation related to this year. But I tell you, Harish has worked with me since 4.5 years with me. He told always, he learned so many things from the me. But I tell you, rather than he learned from the me, I learned so many things from the Harish Vagasia. Please stop. Second important point I tell you related to Harish, whatever you look the today, even though this all the graphics and all the my presentation, this credit to the growth to the Harish Vagasia rather than the Raju and me, because my IT department is also learned from the everything from the Harish Vagasia. And this very long story, I tell you the one fact. I am the person to operate in the European School of Gynec Endoscopy at Verona in 2007. This is also credit goes to the Harish Vagasia, because I tell you, this is the real Guru Dakshina for me from the Harish side, and I operated 4 cases there. Another one part I think I tell you in this forum, apart from the Dr. Prakash Trivedi, Dr. Prasant Mangeshkar, Harish is also one of my guru. Next, please. Second, always I am telling Saumil, during the time of endometriosis surgery, please stop. You need the third eye. You pursue below to the tissue. Whenever the alter anatomy, you have you have to develop some different kind of the third eye to you look the below to this adhesions below to the tissue. And today is the webinar related to third eye. So I tell you how we diagnose related to some abnormal situations and how we treat with this such kind of the abnormal complications. Next, please. In our institutes, every yearly the fellowship program is going on. And this is our protocol. For 3 months, we give only observations. And after the 3 months, we started with giving the primary trocar incisions. Next, please. Next, please. This is the very simple case. During the time of COVID era, with the primary infertility, was posted only for the diagnosis, histro and laparoscopy. And due to this simple surgery, we couldn't cross-match it. No blood product is available. And due to the crisis of this corona, even though in the blood bank, there is a scarcity of the blood. So this patient have the AB positive. I tell you later on during the time of video. Please, next please. Only the positive history in the, look here, once we put the trocar and we realize the whole abdomen full of the blood. First we thought related to, I think, perforations of the uterus because we do the hysteroscopy, but we realized that such a huge blood loss is never happened with the perforation of the uterus. Please stop it. 1 minute. The first sign, I think Dr. Sanjeev Upadhyay, he is my chief anesthetist and dear friend of mine. Why I tell you the anesthetist is our Krishna. I convey this sentence to the Dr. Sethi Saab, Dr. Pena and Dr. Sanjeev. The Mahabharat victory couldn't possible without the Krishna. Such kind of the complicated cases, I think if you couldn't have the stable anesthetist with you, it's not possible. Because without blood, without cross match, you deal with the aortic trocar injury, it's next to impossible. Even though its literature is shows that the survival rate is out of 1,002 cases. Next, please. Please continue. So we try to make the suck out. Another one we are lucky because at that time the next case is related to bowel resection and Dr. Lakshman Kheria with us. He is heading our GI department in Mayflower. And he is the great surgeon, I tell you. We suck out all the blood. Even though this is the head-low positions, there is a lot of blood in the upper abdomen and we look related to aorta. Immediately, without wasting of time, we switch over on the laparotomy. Please stop, 1 minute. The first signs, what we get it. Sanjeev is telling immediately us, something is happened wrong because at that time the blood pressure is from the 110 to 70, suddenly is dropping down 40/20. So I think during the time of discussion, how at that time he managed this improve the blood pressure with the colloid or maybe some other material like noradrenaline. This one is the later part we discuss it. But we took the decision, me and Lakshman immediately we took the decision to open this patient. Now again, please start. We open it. We couldn't took the more than 5 minutes because always in our institute the laparotomy drum is keep ready. If whether it's a simple or complicated surgery, this is the one of the things always we tell that first the laparotomy drum is ready. In spite of that, we waste only 5 minutes. The huge blood loss in the abdomen, we took outside. First we press over it and wait for the blood. It took the another 30-40 minutes to blood is coming in our OT. And even though we try to make the contact at that time with the cardiovascular surgeon, but it's not possible. So we press it. Meanwhile, Sanjay Bhai stabilized this patient. And then we step by step, we try to make the open. This is the huge hematoma. It's more than 1.5 inch. Any time of the adventitia of the aorta is damaged, it creates the dense hematoma, and even though you couldn't palpate the abdominal aorta pulsations or even the common iliac pulsations, we check everything. We try to make the suck out the whole the blood. Then we palpate. But due to the huge hematoma, we couldn't find out the pulsation, and it's also very dense. Again, we extended furthermore because exposure is the very important part whenever you deal with the such kind of the patient. Once we have the 2 bottle blood with us, then we try to make the opening the peritoneum with the monopolar needle. Because it's absolutely alter anatomy. I think if you do the laparoscopic aortic lymph node dissection, at that time, if the vena cava injuries happen, you try to make the manage with the laparoscopically. But any time, if the aortic injuries happen, I am not telling related to small capillary breakdown over this aorta. If the aortic injuries happen, immediately try to make the open because the pulse pressure is so high in the abdominal aorta, it's more than 120 millimeter of mercury. So it's not possible to even though deal with the laparoscopically. This is take home message. I think inferior vena cava is the different, vein is different, but aorta is different. Second important part I tell you, we have the laparoscopic vascular clamp, but it couldn't work over this aorta. So I think never try to make the thing for that and don't waste the time. Why we survival this patient, the moral of story, we couldn't waste a single minute and single second behind this surgery and immediately we open it. First we try to remove the blood clot because it's very important. But I think this is the huge hematoma. This, just like the sinuses is formed. It's splitting the adventitia and fiber pattern. So once you open the peritoneum, you find out sputter of the blood. Okay. So you thought that might be this is the area of injury, but always is not in the cases of the aortic injury because it's the splitting and it's formed the sinuses, and sometimes the sinus it's bleed like the vessels injury. So we try to make the first we take stitch. Second, take home message. Whenever there's so much edema and blood, never use the 5-0. The books is telling to use the 5-0 or 4-0. Always prefer to use the 3-0 proline with the big needle. So it's very easy to identify in the blood and it pierces betterly in such kind of the situations because we go deeply. So we try to make the 2 or 3 stitches. Somehow we control this bleeder. But we realize that this is the false track. This is not the right area where we injure, particularly this aorta. So furtherly more, again we took the further stitch and we control this bleeding. Meanwhile, we get the 2 bottle blood. So we little bit bold enough and we further dissected more. to try to make the identify the injury, because this is not this simple varus injury. This is the trocar injury. This is the true cut injury. So it's a, you couldn't leave it like this one. So further we try to make it identify the common iliac artery. We very carefully look it. Also we observe related to inferior mesenteric artery, because this is very important. Sometimes we ignore to injury of the inferior mesenteric artery, because sometimes people is try 2-3 times to put the trocar. So we check properly related to any injury of the inferior mesenteric artery. We further mobilize. We dissect parallel to the common iliac vessels. This is on the left side. And we try to remove the clot over it. Look here. This is the big clot. We again dissect it properly. And we try to make the reach near to the aorta. Because it's not possible to immediately find out in the big hematoma. You have to have the dissect properly. We remove all the fibrofatty tissue affiliated with the blood. We try to make the excises properly and try to make naked this aorta. But also it's not possible what we observe, because this is the second time we encounter like major surgery. I show you in the next case. In the first case is what's happened. We try to make the dissect furthermore. But this one is the so pulsatile nature of the aorta. The tissue is so dense, I think. It's very difficult to clear naked. We do the common iliac vessels and aorta. We also check related to pulsation of the aorta. And further we more dissect it and we remove all the debris over this aorta. So this is the small things is very important. In this situation also you couldn't find out thought for the related to apply the vascular clamp over it. Even the majority time in the vascular clamp in the museum, when we needed, we try to make the find out this vascular clamp, we never get it. We check it, pulsations. This is called the third eye. This is the blind procedure. Because we couldn't clear and naked the proper, and this is the we clear, whatever we clear it, it's the totally inferior mesenteric artery. Okay? This is mesenteric artery, we dissected properly, and medially we thought that this is the abdominal. So we properly try to make the find out the pulsations, accordingly that we dissected. And this is mesenteric artery. We further dissected more and we find out the sputter. So this is its bulging is happening immediately. Anytime if you find out the bulging of the tissue, that means this is the right side for the injury. So small things is very important. This is the take home message. Anytime if you dissect and remove the hematoma and you find out the bulging, this is the right side for the injury. This is the trocar injury. So I think it's not like the perpendicular what we put the knife over this aorta. It's the triangle injury. So we suture properly. At that time, Sanjeev is also looking for the dorsalis pedis artery. Because sometimes we obliterate any common iliac vessels, it creates the problem. Also, we do the color drop during the time of surgery and we check related to vascularity and pattern. We furthermore stitch, we token it. Then the most important part, we remove all the things, we check properly, we calculate the mob. Because in such kind of the crisis, always we forgot related to counting of the mob and we leave it. So we calculate the mob, even the gauze piece. Then the major play role. Don't immediately jump for the close of it. Meanwhile, at the end of this one, we get another one bottle of AB positive. This is ureter, also we check it. But it's the surrounding staining tissue with the blood. So we couldn't properly identify. So this is the mesenteric vessels and also lateral to this one we find out the ureter. The next step, because we secure the bleeding, we wait and watch. Further, we try to make the dissect, because sometimes we get the temptations, we try to make the clear everything in the one sitting, but it's not possible. We also suture little bit more, go deeply, and tremendous bleeding is again start. Look here. Somehow we manage it. We took the figure of 8 stitch, we controlled the bleeding. At that time we couldn't, because there is no place to be applied the vascular clamp, because we not dissected properly common iliac artery and aorta. So there is no place to be put the vascular clamp over it. So we decided that whatever we done, this is the life-saving procedure. We put the pressure over it and we wait for the half an hour. Just me and Lakshman, we sit there, wait for half an hour, and again we check it. So this is the life-saving procedure. We remove everything, we check it, mind. But one thing we kept in our mind, this picture abhi baki hai, we show in the next Bahubali movie. So this is the first part of the Bahubali movie. We check properly, there is no bleeding at all. And the hematoma also couldn't spread much more. Absolutely all the situations controlled. We put the snow gel over it, and also we discussed with Sanjeev Bhai, and at that time Sanjeev Bhai is telling now the blood pressure is approximately near to the 90. Patient is absolutely settled. We put the drain, we put the snow gel over it. Big drain is required. The another one take home message. The big drain we do the loop suturing with the single layer closer, because the picture abhi baki hai. This patient is absolutely uneventful for the 7 days, but we kept in our mind related to one part. This is aneurysms. Anytime if you go for the such kind of the surgery, you kept in mind related to pseudoaneurysm of the aorta. And always you go for the CT angio. On the day 5th, first our BG came to survival for this patient. This patient is absolutely settled for the 5 days. Stop pitch. This is the second story of the Bahubali picture. Please start. Patient is absolutely uneventful. At day 6, we go for the CT angio because we kept in our mind for the pseudoaneurysms. And the last meeting of the Dr. Trivedi Sahib, Alka is telling the role of Teflon. Now I show you. So this is the aneurysm. This is the neck is 0.7 mm and 2.5 to 1.5 centimeter size of this is aneurysm. It looks like it's the bomb, is volcano. Never leave it. So this is the only 3D picture related to. Please stop it, 1 minute. I think then we discuss with our interventional radiology department. The two options we get it. One is the stenting. This is very simple approach, only the costly affair. But particular for the stenting, you have to have the required 20 mm size of the lumen. If this patient is very young, the outer diameter of the aorta is 14 mm, inner diameter is only 12 mm. And this is near to the bifurcation of the common iliac artery, particularly on the left side. So we require the Y-shaped stenting. And in such cases, there is a displacement of stenting is very common. We couldn't know the pros and cons of the stenting related to future. And maybe patient is require long-term anticoagulant in such kind of the cases. So also in the same day, also discuss and we do the meeting with our very close team of Anil Jain, is one of the eminent cardiologists, and Dr. Vishal Gupta. We sit together with him and we decided not go for the stenting in this case because it's near to the common iliac vessels. If this one is the upper aorta, I think if you put the single stent, a very simple procedure and the whole story is closed. But in these cases, we require to the again surgery. Next, please. So I think we took the support of the vascular team, vascular surgeon Dr. Vishal Gupta and Dr. Anil Jain team with us. And again, we do the exploratory laparotomy. We counsel with the patient and patient relative. We couldn't leave it because literature, 1 minute, stop it. Literature is shown that in such kind of the aneurysm, every 6 monthly or 1 yearly you go for the CT angio, you look up to the expansion of the pseudoaneurysm. If this one is up to the 5 centimeter, I think you wait and watch. And if it's more than 5 centimeter, then you go for the surgery. But I think such kind of the pseudoaneurysm is work as a bomb. It's a volcano. It's any time maybe create the catastrophe. So we took the decisions. We counsel with the patient relatives and patient, and we go for the redo surgery for this one. Please continue. This is the pseudoaneurysm. This is the 3D CT angio. We open it. Now we have all the facility with us. Cardiothoracic surgeon, vascular surgeon with the open clamp. And Vishal Gupta and Dr. Lakshman Kheria, again this open it. These people do the proper dissections. First is clear the common iliac artery. Remove all the debris over it and look our old stitch where the injuries happen. And even the false track is created, and we also took the right side, right side of the aorta, we took the stitches, sub stitches. So this is the whole area of the pseudoaneurysms. It's create the fibrosis. Also very important, if you leave the such kind of the hematoma and it's create the so much fibrosis, sometimes look here, this is the old stitches we took it. We ligate both the common iliac artery and we lifted it. Okay, we dissected properly. We dissected proper aorta, abdominal aorta, and this is the part of the whole aneurysm is formed. Because it's splitting of the aorta, it's dissecting the aorta, and that's why the pseudoaneurysm is formed. That's why any vascular injury of the aorta, never think to deal with the laparoscopically, better you open it because the pressure is so high, and you use the Teflon because Teflon is very important. It's guard the aorta and it prevent the cut through and proper approximation. This is the pseudoaneurysms, I think. So we dissect properly this pseudoaneurysm. In spite of that, look it. There is a 2 clamp, vascular clamp over this common iliac artery and 1 over this abdominal aorta. Before that, these people is hyperinized. Sanjeev bhai, dialysis coverage? 5,000 units. And then, and this is the, I think, aneurysm site. In spite of that, these people is block the circulation from the aorta and common iliac vessels. Aorta have, first time we realized that even though we ligate the not partial, complete aorta, there is so much collateral perfusion of the aorta from the lumbar artery, and that's why the bleeding is happening. So it's very difficult to, even though such a high pressure aortic injury, we deal with the laparoscopically, it's next to the impossible, accordingly because I encountered this injury and I realized that. The inferior vena cava, vein and common external iliac artery is the different story, but aorta is absolutely different gamble. We use the Teflon, and really it's required the dedicated teamwork. We excise the whole pseudoaneurysms We naked the neck of the pseudoaneurysm and then we suture properly. With the 5-0. Now there is a role of 5-0 proline. But it's with the severe hematoma, particularly at that time, there is no place of using the 5-0 because in such a huge hematoma, you couldn't go deeply, and that's why I always prefer to use the big needle and use the 3-0 for the primary saving surgery. So we apply the Teflon, we suture properly. Alka Kiplan is telling related to this Teflon in the last webinar of the Dr. Prakash Trivedi sir. We remove clamp, we check properly, also we remove the aortic clamp. We watch very carefully related to any kind of the bleeding. Then also we remove all the ligated common iliac vessels and we check furthermore. We remove the fibrosis. Stop 1 minute, please. Stop. Another take-home message for the audience: if you leave such kind of the fibrotic tissue, maybe create a lot of problem related to vascularity of both the limbs. Sometimes patient feel the tingling and numbness in both the legs. Sometimes neurological problem due to the pressure effect due to this fibrosis after this, and that's why it's very important to remove and excise all the fibrotic tissue over it. Continue, please. So it's the end result, and this is the end of this story. So this is another case many years back. Please stop it. Please stop it. Go back one slide. Go back. Please run. I need this.
अरविंद स्लाइड पे पॉज कर दीजिएगा.
Slide पे pause कीजिए please. And we save this patient, and this patient is absolutely uneventful, and patient till now there is no complaint related to this part. So one of the things you learn the story from this one, the communication is very important. Never hide the complications. Whatever the fact you tell to the patient relatives, I think this is sorry. We are extremely sorry related to this part. This is very simple surgery, but unfortunately, this thing is happen. It's very rare complications, but it's maybe happen in some of the cases. So this is our bad luck. This is your bad luck. But we try to manage this case on the proper way. And I think try to do the better communications with the patient, better communications with the patient relatives, explain the situations. Sometimes the patient relatives have a lot of arrogance. It's bound to be happen in such kind of the cases. You counsel on the better way. Whatever the things will be happen, we feel extremely sorry related to this part. But I think our motto and mission related to we tackle in this situation in the better way. And I think the first priority we given to the patient, we try to make our level best to save this patient. And whatever the situation is happened, later on we discuss, and whatever you feel that you do it. But I think this is the primary focus related to, we focus on the patient. So counseling is very important part in such kind of the cases. The next case is case of the bowel epidural. Use the seizure with the monopolar. I think I give the seat very carefully, because the monopolar current is any time is jump. This is the very old video, and we encountered the external iliac artery injury. Please continue. So I think we use the seizure with the monopole, and suddenly it's shoot this monopolar, and it's cut the external iliac artery. We try to do the pickup. It's I think more than 22 years old video. And we try to do the bipolar. At that time, we couldn't have the much more knowledge. And it's the hematoma will be increased. Ultimately, we open this case and we manage very carefully this case. And also we save this patient of the external iliac artery injury. Thank you, Dr. Prakash Trivedi sir and Dr. Saumil for the wonderful webinar. and we heads of you, Saumil.
Thank you so much, sir. That was truly something which only a Bahubali can do. And it's not just Bahubali, but I think you have to have a really big mind and thought process in managing such difficult scenarios. And the presentation said the story of survival. I think in this, it also meant the story of survival of the surgeon himself. Because in so much of anxiety and panic, hats off to your team to document this and make a video out of this complication, which is so rare because in such situations, there is a lot of panic and chaos in the operating room.
We tried to find out the video, but we couldn't find out any single, I think, how we people is, I think, open and I think treat such kind of we never find out. And
Yes,
even though the majority time, I think the postpartum time patient is find out the sunohereditary burst or maybe a vascular injury. Majority time, the survival postmortem time, the survival of such kind of the cases is very rare. And we thought that whatever we, I think, learn from this case, I think the whole people is, I think, learn related to this part. And whatever we do the mistake in particular this situation, our protocol, our principle to try to make the save this patient, and next time what we can do there. So I think that's why we feel that I think everybody sees this one and everybody is learned from this vascular injury.
Fantastic talk, sir. Fantastic video, fantastic documentation. If there are people who were there during the last webinar, I had jokingly made a statement that the only complication probably which we have not covered is wherein there has been an trocar going into the aorta or a aortic injury, and we are fortunate to be learning from you so many tips and tricks of actually managing such a complex scenario. Hats off, sir. And also another point which I would want to say about Dr. Sanjay Patel, he said that this is the third eye. Now for all the audience, I want to say that Dr. Sanjay Patel is already blessed with a third eye. What the two eyes of the entire operating room team cannot see, Dr. Sanjay Patel with his third eye can pick up. And I said during various previous webinars that वो जहाँ पर भी सीजर डालते हैं वहाँ पर planes अपने आप खुल जाते हैं. So that is the blessing of God to Dr. Sanjay Patel, which I feel is already blessed with the third eye. Thank you so much, sir. We will be having, I would request all the faculty, if they are there, to please join in. There are obviously certain questions which are directed to Dr. Kheria and Dr. Patel, but we'll be taking the general extended Q&A session right now. And there are a lot of questions, and I'll be coming to each one of you gradually. Dr. Kheria, actually my first question is to you. Many times in many of the international conferences, and especially in many European countries, especially when dealing with complex pathologies like endometriosis, there is a very big shift towards radicality. As in, if in 10 cases, if in out of 10 cases, probably we would be required to do a bowel resection and anastomosis in one of them. The indications in Europe or some other countries, I think they are very radical with their approach. Out of 10, probably, like they might deem 4 to 5 people appropriate for a bowel resection. So what is your take on it? Are we too conservative in managing endometriosis because we do not have the multidisciplinary team approach in India? Or are they too aggressive and we are over conservative?
I think in the European countries, they are too aggressive. Here in the Mayflower, we are more pragmatic. Because if you are overkilling the things, then complications are bound to happen, because each surgery has its own inherent post-operative sequelae. If you do anterior resection in all patients, these patients, some of them develop anterior resection syndrome, which is there is increased frequency, poor continence. So if you are doing too much of anterior resection, then that type of one disease is replaced with another one. So you have to be more judicious and pragmatic. Here what we do, if the size of the deep infiltrating endometrioma that is less than 2 centimeter on the rectum, then we try to shave it off from the rectum. If it is not possible or going into the mucosa, or we open the mucosa, then we convert into the proper discoid resection of the rectum and close it. But as far as resection is concerned, if it is a stricturing endometriosis which resulted into the total stricturing, which is not allowing passage of your finger or endoscope, in that case you have to do a resection. Or multiple endometriomas dispersed over a short segment of the rectosigmoid, say around 3, 4, 5 endometrioma on the sigmoid and the rectum. In that case, it is not judicious to do shaving. So it is better to resect that and do the anastomosis. This is how we tailor-made our approach in the endometriosis.
Right, sir. Dr. Sanjay Patel, the same question is addressed to you. In your vast experience, as everyone in the country and in the world is probably aware of endometriosis, if you can give me a percentage figure as to how many times a bowel resection and anastomosis is actually required in endometriosis, because your guidance would really enlighten this audience as to what is the correct practice and things to be done.
Saumil, I tell you, I think another needs of 5 years. Majority people is switch over on the civic technique, or maybe majority is the discoid. Because one important part related, it's the benign disease. It behave like malignancy, but it's not malignancy. Whatever the part I think we remove, it's related to, it gives the quality life of the patient. Okay. Whenever you go for the resections, I think it's created a lot of problem. If you look there, because me and Lakshman, we do the lot of bowel resection in our institute, but the ratio out of 100, only the 5 cases we selected for the bowel resection. In spite of that, it's the tertiary care center for the endometriosis. Right. So one important part, tell you, the 2 criteria we selected for the bowel resection, it's the circular stricture. Sometimes with the colonoscopy is not possible. It's the circular ring we find out, surrounding. Even the holy place is also involved. Suppose Dr. Lakshman is showing in these cases, this is cardinal involvement, we perform the nephrectomy. And also it's a very dense fibrotic area surrounding to the ring. It's a ring is formed. In those cases, because it's the hourglass appearances of the stricture, in these cases require the bowel resections. When you find out multiple nodules over that, if you find out just below, because it's the posterior cervical pathology may be extended in the vagina, and here you find out just below to the cervical pathology. Sometimes you find out over the sigmoid multiple nodules, because what's happened? What we get, the patient previously operated 2, 3, 4 times. So sometimes due to the incomplete surgery, it's maybe nodules, main nodules on the posterior cervical side. But I think some other nodules we find out where the ovary is, I think, adherent with this nodule, or the lateral side sometimes we find out in the middle pararectal space with difficulty, and we find out this one is the nodules in the colon. Sometimes we find out due to this whole the uterosacral involvement and this nodules is piercing in the colon. So multiple nodules whenever we find out, in those cases we selected for the colonic resection. Otherwise, the single nodule less than 3 centimeter size, I think we prefer to use the discoid. And second important part, we do the PR. If the mucosa is not involved, in those cases, me and Lakshman has developed the different technique. We try to make the save the muscular exposures. We try to make the preserve the mucosa. If you preserve the mucosa, the morbidity and post-operative complication is much more less. In the next day, patient start the oral and we give the discharge within 40. But in those cases, we go for the discoid, the hospital stays increase up to the 5 to 7 days. Sometimes it maybe create the leak. Sometimes we need the post-operative sitting with contrast, rectal contrast. We need it to find out the check of leak. Sometimes in some cases the leak is happen. Out of I think 100, another 2 to 5% patient in the discoid. In those cases, if the mucosa is involved and we go for the discoid, 2 to 5 cases we need to convert it into ileostome. So I think it's very important. So if the mucosa, if we preserve it and we remove the nodule from the muscularis portion of the colon and just you suture it, the outcome is wonderful. But I think we do the very vast experience, we realized that this is the benign disease. Optimum surgery is the key of success.
That's it.
Do the optimizing surgery for the endometriosis and give the better quality of life of the patient. It's the key part. Rather than we do the bravery, apni baduri dikhane ka we go for the colonic resection and patient is fine. It's the wrong method. Because whatever patient is we underwent go for the colonic resections, I think first 6 months patient has the frequencies of the stool, sometimes the dragging pain, sometimes the patient is feel every time something is coming out from the rectum. Dyschezia, whatever we done for the dyschezia, the same problem patient is faced for the last 6 months. And that's why we need a lot of counseling in such kind of the cases, that this thing is happen, it's automatically set out. Or also once we use the circular stapler, we I think try to make remove all the nerve ending of the rectum. Because we dissect the Holy's place, we surrounding it clear, we remove all the pararectal fat. Because once if you not remove the fat, there is a anastomosis is not perfect. There is a ample of chances of the leakage of this anastomosis. So we remove the fat. So we compromise all the neurology of the pelvis related to colon, and that's why I think I personally feel that in those patients it's reserved for the limited cases, not for the all cases.
Sir, do you base your decision to shave or to do a discoid or a resection anastomosis? I'm pretty sure you have a very good preoperative imaging and planning as to what persons will require what. Are there any surprise situations wherein you have gone in with a strategy and intraoperatively then suddenly you have decided that this patient is not very optimal? And how do you screen in terms of imaging and your decision making as to what is the procedure of choice?
I think one is the transvaginal sonography. Second, if needed, transrectal sonography. And good PB examination is the best things, and PR examination. In the certain cases, we took the support of the MRI. So only we faced a problem related to MRI reading. Everything is in the film, everything is there. Now me and Lakshman, we decided we never look related to report, we look the film. And we try to make learn the reading of this MRI plates. Because we try to make train so many MRI center. We do the surgery, then we sit together with these people, we explain it. You write down only this part, colonic adhesions, but this is the invasion of the muscularis portion of the colon. This is maybe extending the cardinal ligament, and that's why the patient is presented with the hydronephrosis. But we do the exercise for the many years, and we fail it. So in the last 1.5 to 2 years, we decided we do the reading ourselves. And majority time we gradually, because everything we need to the learning curve. It needs the time to learn everything. But optimizing up to the 70 to 80% we read properly. We read better than what the MRI people is give the report. And accordingly that we counsel. But I think sometimes we told that only the 50% information we get with the MRI. Real picture we look after once we put the scope. And we explain everything. If we find out in this situation, the counseling is very important part. We do the audio video recording. You know that from me. In Mayflower, we do the audio video recording, and also in all the advanced cases, we took the consent of the ileostomy or colostomy.
Right.
But we explain on the better way. Out of 100, only the 2 cases we require the colostomy. This is benefited for the you. If we leave I think this is left behind, it's maybe create the bigger problem in the future. So we counseling on the different way. We, I think, told on the percentage side, the percentage ratio is very low. And the most important part to create the counseling team, particularly whenever you deal with the endometriosis cases.
Right. Do we have Dr. Sanjeev Upadhyay with us? Dr. Sanjeev and I think Dr. Parna Thakkar is with us. So there are quite a few anesthesia related questions from the audience. This is a question by Dr. Jamuna from Tirupati. What is the maximum risk-free possible surgical time with pneumoperitoneum for laparoscopic procedures of ASA grade 1 patients? So what is the maximum safe time, operating time that you would feel comfortable with, or are there any guidelines?
I think there is nothing like that safe time.
Right.
As long as we can maintain our hemodynamic, as long as we can maintain our gaseous exchange, And as long as we can take care of our intracerebral pressure, surgery can last whatever the time they take. Right? In between, suppose surgery is very lengthy, then in between, what we do that when the surgeon take rest or they take some coffee break, at that time we deflate the abdomen, we keep patient in the supine position, or sometimes we may give some head up position, and we try to normalize everything. If from very beginning we feel, suppose like in robotic surgery, that surgery is going to last very long, at that time we take very precise care of temperature monitoring, and we put arterial line, so that in between we can do ABG and we can realize that patient is not getting acidosis, patient's CO2 is absolutely normal. If otherwise patient is having a good urine, temperature is maintained. So I think time is not a bar as long as the surgery is concerned, or as long as the anesthesia is concerned.
Right. Dr. Parna, are you with us?
Yes.
Yeah. Hi, Dr. Parna.
Hi.
I am not sure if you heard the question, but
No, I've heard the question.
Yeah, are you comfortable, or do you draw a line in terms of extended operating times as to there is some limit as to how long a laparoscopic surgery can occur?
See, there have been times when it's gone on almost for 12 hours, 14 hours, and in difficult surgeries, it can happen. So in anesthesia and in surgery, 1 + 1 is never 2. You can always have surprises, and any ASA 1 case or ASA 2 or 3 can get extended. But in that case, if you keep restrictions on the time limit, what would you do? Would you open the patient? No, if it can be done laparoscopically, and if you're safe, and as sir rightly said, in between you give break and remove the head low. And there have been times where the CO2 really goes up because the soda lime is exhausted. So that's when you change the soda lime and you ventilate the patients well. And then after 10-15 minutes, you can restart the surgery. And before extubation, always see the edema of the face. If the conjunctiva is edematous, and if the face is very edematous, if the tongue has become very edematous, then you can expect a lot of airway edema. And in those cases, maybe extubation might be difficult, or you have to be very careful at the time of extubation. And maybe you can take help of leak test and then extubate the patient. So you have to be very careful when the time is extended. And we've done surgeries for 14 hours or 12 hours. I think it's fine. Yeah.
Last Whipple surgery, it lasted 16 hours. But what the precautions we need to take, we have to take it. But yes. I don't think there is a time limit that up to this time you can do.
Yeah.
There are all possibilities that at the end of surgery, by chance, if your patient is hypothermic, correct, or your patient, you feel that you send the ABG and you feel that patient is slightly acidotic, maybe respiratory, then you can ventilate them for few hours. You don't extubate on table. You shift them to ICU. You ventilate them for few hours. But there is no timeline that this is the cut-off time, as long as my understanding. That this much time you can do laparoscopy, otherwise you open. Or you don't.
So actually that was the next part of the question, that is need of elective post-op mechanical ventilation in such cases.
So there are, I tell you, if you start surgery with pre-existing disease of the patient, like suppose you are doing laparoscopic surgery with low cardiac output patient. So if you are doing a laparoscopic surgery with COPD patient, so in those cases there are all possibility. See, the main problem for to restrict us to extubate the patient is, one is hypothermia, second is high PaCO2. So these are the two major problems that we face during laparoscopy and in anesthesia. So by chance, if you but the answer is one ABG, electrolyte, your hemoglobin level, and you see that your temperature is normal. If your temperature in between went down to 33 centigrade of 33 degrees centigrade, ideal to extubate patient after once the patient become 35 degrees centigrade. right? So these are the things where you need mechanical ventilation post-operatively, where your temperature is down, you feel that patient, means ABG shows that patient is acidotic. These are the cases. Very long surgery and you end it very middle of the night, you complete the surgery, then you don't want to extubate this patient in middle of the night. So you can place them for ventilation for few hours like that.
What is your cutoff for the CO2 levels wherein you will ask the surgeon to halt? And you would ask...
very important thing, that your EtCO2 always not reflect your PaCO2.
Right.
Right? Many cases, like what I suggest, what I enumerated, low cardiac output, even COPD patient, primarily respiratory or cardiac problem. At that time, it is a long surgery. Frequently, you should do your ABG level. See, the normal level, your PaCO2 and EtCO2 difference is 5 millimeter of Hg. But that is in otherwise absolutely all things are normal. Many of the time your EtCO2 does not reflect your PaCO2. Means the CO2 in the blood is much higher than what is there in the what you see in the EtCO2. So all those cases, the solution is you send one ABG, arterial blood gas analysis, and you check whether your EtCO2 and PaCO2 match. Roughly, in general, expected means acceptable PaCO2 is 45 millimeter of Hg. If it is more than 45 millimeter or maximum 47 millimeter, because nowadays there is a concept regarding permissive hypercapnia. That is why I am telling you 45 or 47 millimeter of Hg, that is the accepted level. If it is like that, you can extubate patients safely. If it is beyond that, you ventilate them till the PaCO2 less than 40.
Right. Dr. Puntambekar, are you with us? Dr. Shailesh Puntambekar, are you?
Yes, I am here.
Yeah.
Hello, Somil.
Yeah, sir. Yeah. So there is a question addressed to you, and I think this we were having a discussion during the question answer sessions at that time also. What is your preferred energy modality for lymphadenectomy? That is number one. The second thing is, we were discussing this, when will you switch from an energy source, not use an energy source at all, and use cold scissors? Dr. Puntambekar?
Ask question to anesthetist.
I think we are having some trouble with the connection with Dr. Puntambekar. I think he's back on. Yeah, Dr. Puntambekar. Yeah.
So, sorry, can you repeat the question? I had lost
Sure. So my first question is, what is your modality of choice in doing a lymphadenectomy, pelvic and para-aortic? And we were interrupted in the discussion when I had asked you earlier, when will you stop using an energy source altogether and switch to cold cutting or scissors?
Yeah, so the important thing is there are indications for para-aortic node dissections are only when there is a common iliac node positive on frozen section, or for endometrial cancer if it is more than 50% involvement. That is number one. Or number two is that on MRI or a PET scan you see the para-aortic nodes. So more than 50% invasion of endometrial cavity, 100% you have to do para-aortic node dissection. The second part of question is whether when should we not use the energy source? We should not use the energy source when you are close to big vessels like the anterior surface of the vena cava, anterior surface of the aorta. It is better to use suction, identify the tributaries, and then coagulate rather than blindly coagulating, because these vessels, if they are damaged, it's a disaster. So normally I do not use much amount of the energy source unless you dissect it off completely and you can see a clear plane. So when you see a clear plane, you can use harmonic or you can use bipolar. But unless the node is picked up from the anterior wall, which is the most dangerous area of the aorta, or IVC, because lateral, if there is a bleeding from the inferior vena cava or also from the aorta, just a compression will help. But anything on the anterior wall, the compression doesn't help.
Right. Coming to Dr. Trivedi, similar question, but in a different indication and scenario. This is a question addressed by so this is a question addressed by Dr. I think Deepak. What is the best energy for cutting the vault in a hysterectomy?
We used to have on a tube monopolar for a long period of time, and in the current time we have shifted almost to the harmonic scalpel. There are two, three reasons. Number one, all the other energy may not work. Like monopolar spatula or hook will definitely work. As mentioned, we have reduced the use of monopolar to a large extent that very often in our regular hysterectomy, irrespective of the size, the monopolar instrument is just kept, but we don't start. So first preference of choice is go to a sufficient distance after you pass your McCartney's tube from below. You are very sure about the margin. Then the incision is made with the harmonic blade. And one important small little message is that it is preferable not to anteriorly separate it. It is better that you go and separate posteriorly as much as possible and go circumferentially, because then you will find it easy. And the last part, which is on the right side, preferably is inside, is by the harmonic coming from the right side. But harmonic is because, as I told you, we purchase this in bulk. When harmonic was not there, a lot of people always feel that using harmonic on vagina is wasting energy. But I think so. What you're comfortable with is always better.
I think, sir, what they are trying to ask is why not use a ligature, because I think the healing of the vaginal vault and all is the question. So any comments on that?
Issue with ligature, there's one thing I didn't go into details. There's a full article on the compressibility of NSEAL and even ligature. So the compressibility, though ligature has a catch, the compressibility is little less than NSEAL. Now NSEAL is very difficult to use. So personally, we don't use much because we don't expect many bleeders. So once we don't expect many bleeders, still harmonic is better, because the uterosacral area ligature doesn't work. It is harmonic. And once you're doing harmonic, then the tube is on, then you will continue with harmonic and finish it off.
I think in terms of, sir, the vascularity of the vault is concerned, people advise not to seal it and not to overcoagulate, so that there is less chances of cuff dehiscence. So your take on that, sir?
The most important thing is, to be very honest, this is not that we are having any exaggeration, but we don't have cuff issue from 1993-94. We don't have any cuff issues because there's good dissection done, that cuff discharge, cuff dehiscence, etc., etc. I think so. We have never had. Only one or two times when we were not removing the tube may sometimes prolapse and it may cause a discharge, which is a rare case. But we don't face any cuff issues.
Coming to the next question, to Dr. Sanjeev sir and Dr. Parna Thakkar. Now, lately, many of the times there is this fascination of, and obviously it's very good for our patients if we can do daycare surgeries as far as laparoscopy is concerned. Now, my question to you is, what are the precautions and the steps one can take to facilitate a daycare surgery from the anesthetic standpoint? Dr. Sanjeev, you're muted.
Daycare surgery, if we really want to do the daycare surgery, so what are the prerequisites of daycare surgery? That during the procedure, patient should be pain-free, number one. After the procedure, patient should be pain free. At the same time, after the procedure, patient should not have any nausea, vomiting, which is very important part. So we organize or we manage our anesthesia in a way where we can avoid opioid as much as possible, because opioid is one thing which is a very excellent for hemodynamic stability, but opioid has got side effect of nausea and vomiting, and it has got some side effect regarding respiratory depression. So if by our anesthesia management, because now many drugs are available, non-steroidal anti-inflammatory, even paracetamol IV injectable made us available. At the same time, we can combine our general anesthesia with regional anesthesia, local blocks, prep blocks, many other blocks which are been there, where even pre-sacral local anesthesia injection, that also causes a lot of pain relief. So the aim is that patient should not have a clear-headed net post-operatively. Patient should avoid urine properly. Patient should have proper temperature. Patient should not have any nausea and vomiting. So the drug which we use, glycopyrrolate or atropine anticholinergic, sometimes they cause urinary retention. So if we are really planning that the patient to be discharged early, that drug has to be avoided. But we have to be very careful, because anticholinergic drug, it is very helpful to prevent vasovagal problem during the gas insufflation. So we have to be alert regarding that. So, and use short-acting muscle relaxant or intermediate-acting muscle relaxant. So, take care of proper hydration. All this will lead to early discharge, and we can discharge patient on the same day.
Right. Dr. Parna, I think you touched upon tab blocks in your presentation.
Yes.
Now, I have been to varied centers and all have various approaches to this tab block. Some do it blindly, some do it USG guided, some do it under laparoscopic vision. So can you elaborate a little bit about the tab block?
See, basically, whenever, am I heard?
Yes, yes.
Yeah. So basically, if you have a USG machine handy, then many a times, like for cesarean section also, before we are sending the patient to the ward, I give a tab block. Then, so if you have a USG machine, then maybe use it, and the anesthesiologist has to be comfortable using it. But there are people who have been practicing blind blocks since years, and like they have practiced it for almost all their patients, and they feel that there are no complications. So while you're giving the block, one has to be very careful that you feel the resistances with the needle properly. So that's one thing. Secondly, don't use too long a needle. So that will help. And there are many people, even in my hospital, like there are many surgeons who before closing, they give blocks, tab block, beautiful tab block, and before closing, they give it with a spinal needle. So you can see the needle below the peritoneum, and they work quite well. Even for so many bariatric patients, like so many bariatric centers, they are recommending tab blocks so that they can go down on the opioid requirement. So I think it's an excellent modality, but one needs to practice it. So the anesthesiologist has to be convinced, and the surgeon has to be convinced, and then you can give it very safely. Yes, Dr. Sanjay Patel. Yeah.
I want to tell you, madam, I am using tab block. I am giving tab block with the sonography, and tried giving blind tab block and then check it with the sonography.
Yes.
See, to enter into the plane is so subtle things, right? Even with the sonography, sometimes it is very difficult to realize the resistance and enter into the proper.
Yes.
I do not want to criticize who are giving a blind approach or by the laparoscopic approach. How can you be there between internal oblique and transverse abdominis plane while just taking out needle from the peritoneum? I am having real doubt about it. So see, the people are giving and they are having excellent effect. That is okay. But in my understanding, sonography is a gold standard to give the TAP block.
Absolutely. Sonography is a gold standard. If you can see it, nothing like it. But sir, like even in the city of Mumbai.
When you are coming out from the peritoneum, you have to enter not just below the peritoneum. You have to enter the plane between transverse abdominis and internal oblique.
Yes.
How is it possible to realize that you are in that plane? That plane is so thin, and you know that there is a variety of anatomy. Right? Some of them they realize it properly. Some of them you do not realize it properly. Whatever it is, my understanding that TAP block by sonography is a gold standard.
Absolutely.
So what you just highlighted is in fact something which I have started doing after my visit to Ahmedabad, and most of our patients post-operatively we inject sensorkin into the presacral space, or which is sometimes called as a superior hypogastric block. I have found excellent results in terms of the pain profiles of our patients. I wanted to understand whether these TAP blocks and these modalities do facilitate an early discharge.
Yeah, definitely. If it is given properly, definitely it works for the early discharge. Because what is the main thing? We can avoid opioid analgesic, right? Non-steroidal, this is a multi-modality approach. The only TAP block or only presacral block or only non-steroidal anti-inflammatory does not work. When they combine together, it works and it helps in early discharge. Main issue of the daycare surgery is, as far as nowadays, there is a big topic regarding opioid-free anesthesia. They are doing opioid-free anesthesia even for the major surgery. We do not talk about it. There are some limitation about it. But for daycare surgery, the drug which are causing post-operative problem, that drug, if we can avoid, patient can be discharged.
Somil, can I ask a question, make a comment and ask a question with your permission?
Sure, sir.
One important thing is the issue about daycare is different abroad and different in India. Because abroad you get well paid for a daycare procedure. Because I remember Joel Schilder, who had a motorcycle accident at 47 years, very good onco surgeon. And we used to do onco surgery, and within 6 hours of onco surgery, he used to discharge the patient. Now here we have to remember that our group of patients whom you are discharging on daycare has to have sufficient idea to take certain thing on their own, certain guidelines followed properly. Second is, in our insurance system, if it is daycare, if there is no overnight stay, then they feel why you want to charge like a major. That is one dichotomy. One question I want to ask to Parna and Sanjeev Bhai, sir, and all. We have a huge problem about left lower port morcellation port side pain. Left lower port. Is there any method, apart from giving some local injection, is there any method by which you can, you can avoid? Because I think so everybody who morcellate elephants also, but the port is the same. So any method by which that can be minimized?
Sir, one thing I just want to say, if your incision size is lesser than your trocar entry, that part will give a lot of pain. I tell you, because that trocar will be there inside for some time, and if it is the incision is lesser than the trocar, then it will give very pressure effect. So that is my understanding, that when your incision site is slightly bigger, skin incision, than the trocar entry, then pain will be less. Other modalities, generally we are giving local anesthesia and sometimes the left side TAP block. That will help. But nothing else than that, what I can say.
That is what Somil also suggests, what you are telling, that is what he is suggesting. Go ahead.
Yeah. So my question to Dr. Puntambekar, this comes from Dr. Dilip Patel and Dr. Fasiha Tasneem is also asking a similar question. So can you elaborate about the collateral thermal damage done by different energy sources, especially when working close to the ureter?
Yeah. So all the time, whenever you are working close to the ureter, you have to see to it that you should always, there are certain principles that you should follow. First of all, never pick up the ureter. Should never handle the ureter with the instruments. There are certain people in the world, I've seen them using the Babcock to pick up the ureter, which is a disaster because that's not a good thing. Ureter carries its own mesentery. So first principle is don't pick up the ureter. You should dissect the ureter either bluntly with any of the forceps that you have, whether the ligation or with harmonic. You can dissect it off the peritoneal cavity. And the most important thing is when you are very going on the ureter in endometriosis or for that matter difficult endometrial cancer surgery, always dissect on the anterior part of the ureter. In endometriosis, the ureter is mainly stuck on the medial part. So what you should be taking caution is first dissect the complete anterior part of the ureter and then dissect the ureter regularly. The collateral damage is very common when you use bipolar, which is very close to the ureter. That is the time that you get this. Second area where you get it is a direct branch of the uterine artery which supplies the ureter, and at that point of time, if you just cut the uterine artery, then the damage can go over there. So ureter should be carefully dissected. Remember the principle, it carries its own mesentery. There is no segmental blood supply. The only supply comes from the branch from the uterine artery and one branch from the internal iliac artery, but there is no branch from the external or common iliac as given in gray. It is not seen and it takes its blood supply from the vessels which come from the ovarian, and that too at a very higher level. So always protect the mesentery. That should be the principle.
Another question comes from Dr. S. Krishna Kumar, and this is to the anesthetist panel again. Avoiding hypothermia during surgery, what are the best measures? Dr. Parna, you can start.
Yeah. So avoiding hypothermia, first of all, OT temperature is very important. In so many places, I see that the OT temperature is say 15, 16 degrees, 17 degrees. So avoid that low an OT temperature. Then when the patient is taken in the OT, you come to know whether this patient, like how sensitive he or she is to cold. So immediately if they complain of they're feeling cold, then you cover them up, and when you wake the patient up after the surgery, you know that this patient is going to be very cold at the time of extubation. So you make sure that you wrap all the all the exposed parts of the body, like you wrap the hands well, or you keep the hands on the not directly on the leather of the OT table, but there should some cloth or something over there, or you can give some warmed blankets or something like that. Warmer is the easiest thing which you can have in the OT, and give warmed IV fluids, not very hot but warmed IV fluids, and make sure that all the time the warmer is on the patient and cover the warmer up very nicely. Because what happens is sometimes direct injury or not covering the warmer also can have its own problem, and there have been cases of burns or skin rashes and things like that. So warmer is not a sure thing to prevent hypothermia. Use it carefully and prevent cover up all the parts which are exposed. Cover the head with the cap. So all these things are very important. Secondly, so many anesthetists have a habit of exposing the head completely. So like what I do is, once the head is covered, I don't open it up unless it's really required for me to see the tube, or it requires, for something I require it. So cover the head also well, and that takes care. Thank you.
Coming to the next question, and I think this is something wherein the gynecologists and the anesthesiologists have a lot of debates, and is the use of vasopressin. And I would want Dr. Trivedi also to comment on this, along with Dr. Sanjeev Upadhyay and Dr. Parna Thakur. As you have rightly pointed out in your talks, sometimes when vasopressin is injected, rather than the BP of the patient, the BP of the anesthetist sometimes shoots up, and people are very apprehensive and still to some extent conservative regarding the use of vasopressin. So Dr. Sanjeev Upadhyay, your take on the use of vasopressin, its safety, followed by Dr. Parna Thakkar, and finally some remarks by Dr. Trivedi.
In our institute, we are using a 20 unit of vasopressin in 200 ml of normal saline, and we allow 20 to 40 ml at a stretch injection of a vasopressin. But we see, we religiously see that aspiration is, they check the aspiration, there is no blood in the aspiration, then and then only they inject the drug. By chance, if we require more than 40 or 60 ml of vasopressin, then we wait for another 20 minutes. So we complete the work where the vasopressin is injected first, and then second dose of vasopressin generally we inject after 20 minutes or maybe 20 to 30 minutes, another 40 ml wherever they want to work. And in this manner, we have not found any major issue as far as the vasopressin is concerned.
Dr. Parna, your take? Any adverse events which you have managed, and obviously you shared a case in the presentation itself, but how often do you come across catastrophes with use of vasopressin?
In my 25 years of practice, only once I've had problem with vasopressin. I've been very fortunate that I've always worked with senior people and very sensible surgeons, and like nowadays you find so many young people also who are very knowledgeable and they know their limits, so they don't want to overdo things. So I think we are stretching the issue of vasopressin too much, and we are unnecessarily getting worried about it. And I think if you let the surgeons do what they want to do, I think that's fine. And sometimes if I'm in a new place, or if I know that the OT staff is new, or she's not a regular gynac staff, then I would ask them the concentration that she has made. So that's one thing that I make sure of. And also, when a surgeon is injecting vasopressin, I'm very careful. I never stop them or I never tell them anything, but I keep a note of how much are they injecting, and my job is to look at the monitor. So I keep on monitoring the patient. I'm very vigilant at that time. Also, if I have the privilege of keeping the hand on the pulse, like most of the people, they take the hands by the side. So there you can't feel the pulse except for the external except for the external auditory. But that time I keep my hand on pulse and I keep watching the monitor. If there are some changes, I inform the surgeon. But I've fortunately not found any problem.
Dr.
Here I have got some difference of opinion, Dr. Parnaji. No doubt that we should be well with the surgeon, but at the same time, interpersonal relationship is also very important with the surgeon. And surgeon should also understand, as and when we say that now, see, something, it is not like that once it happens and then only we realize. Whatever the written in the book, whatever the written the wiser people previously, that this thing you should do, and this thing you should not do. In Gujarati, it is said that Jerna Parkha na hoy. Means there are certain things which we have to follow what the previously been told us, and they are the safe practice. So whatever the safety, we must inform to the surgeon that this is the safe limit of volume we can inject. And most of the time, if you are doing well with the operation theater and everything is fine, they will never oppose you. They will never say that no, it is not like that, you don't know anything and let me do, I am doing it since very long. I have not seen in my career up till now. So it is I understand it is a interpersonal relationship and proper understanding of the adverse. By chance, if it happens, I have come across once for vasopressin problem during the conference time, and it is really a catastrophe when it go directly intravascular by any means. There is a severe bradycardia, there is a severe hypotension, it turn out to be ventricular tachycardia, it turn out to be ventricular fibrillation. We have to shock the patient twice and we could revive the patient. So what I mean to say, what I want to convey, that though everything is fine, there is some limit which is being told by our wiser people. So we have to follow that. We just don't want to wait. No, nothing is happening. Don't worry.
Yeah. See, vasopressin, I think so. I'll give you a very strong, clear view. Number one, it is one of the most useful drug. It is never the drug which causes problem. It is the misuse of the drug which causes problem. So 20 units in 200 ml. Normally we use from 1995. Not only Dr. Bajani, Dr. Deepika Desai, Dr. Gadge is least bothered when vasopressin. Obviously, we inform him the moment when we are injecting. And I use regularly in myomectomy. I use regularly in hysterectomy. I use it for dermoid. I use it for endometriosis. I use it for ectopic. Now, the whole thing about vasopressin, sometimes some anesthetists, I feel, they must have come across a very odd situation wherein they have faced a problem. Then they suddenly overreact. The overreaction is to such a level that if you are calling that anesthetist for your myomectomy, you are very sure that the pulse rate of that anesthetist is going to go before even coming to my OT. So point is, I think so you have to realize accidents do take place. Now about 20 units and 40 units, sometimes we have 18 fibroids. So we inject in 4, remove 4, do the suturing, the phase is gone. Obviously we watch, the anesthetist watches, and even our anesthetists in Fortis with the Shetty and other group, or in Jaslok Hospital, all the group, nobody were paranoid about vasopressin. 2 important point, there are some modified needles which come, which may apparently give you an idea. Now, aspiration is supposed to be done, which Somil does religiously. I'm a little lazy person, but in spite of that, it has not happened. I'll tell you a very important, relevant story. Especially we have this ambulatory surgeons, people running here, running there. And there was a very interesting thing which one of our very excellent surgeon who is fantastic. So they went to one place, myomectomy was to be done, and everything started. And in different places you go, because in a day you're doing 10 surgeries. They injected vasopressin. Vasopressin injected, no pulse, no BP, patient couldn't be revived. Accidentally, it was found that the sister by mistake had given adrenaline and not vasopressin. This is a real case. I'll also tell something which have happened in Delhi, which is one of my great friend. So she faced the problem. And because at that time it's a big hospital, so they realized, okay, there is a problem, and then they shifted from lapro, finished it quickly in open surgery. So you can face a problem, but there are certain patients who are hypertensive, this, that, and all. If you honestly ask me, my pulse rate is normally 84 or 86. When I use vasopressin, it doesn't change. My anesthetist also doesn't change, but most important is about the patient. So if you have occasional patient, but I see, as Parna was rightly mentioning, people over glorify, अरे बाबा संभालना, vasopressin है, ध्यान रखना, बोलना, यहाँ ऐसा हुआ था, वहाँ ऐसा हुआ था, ये हुआ था, वो था. Now if I inject vasopressin directly into a vessel, it will show an effect. So my overall take is use vasopressin sensibly. 20 units is the limit. You can use lesser if you want. And there is no such thing that you have to use all 200, because you can use 80 ml. Then for other fibroid or something, in hysterectomy, you need 60 ml. So I think so you can draw a line and cut out. There are certain countries where it is not allowed because they had mortalities. I think so there are so many countries wherein they have so many things. But largest number of fibroids in the world are removed in India. So obviously use of vasopressin will be more.
My question, next question, thank you for that updates on vasopressin. And I think we have a unanimous opinion that it is safe to use with caution. My next question is addressed since we are dealing with a lot of people in various other specialities. Now, as a gynec, to do advanced oncological surgery and say advanced endometriosis surgery, how important is some training in cross speciality? My question is specifically addressed to Dr. Lakshman Keria, Dr. Puntambekar, who obviously has vast experience in varied surgeries and gynecology, and also to Dr. Sanjay Patel.
So can I start or later on I tell you?
Sure.
Okay,
Sure.
let's start.
See, when you working in cross specialty areas, particularly you planned a surgery and during surgery you found a surprise that you need a GI surgeon, right? Or you need a urologist. It is an intraoperative surprise. So you assess your experience, you assess your skill, whether you will be able to handle it or not. If not, then call for help at the early stage rather than calling them when complications already happened. So it is not about the training in the cross specialty. It is the analysis of your problem and whether you need some help or not. And if you need help, then always call for the help in time rather than calling at later stage. Because you cannot train yourself in all the specialties. There is a limitation for everything. I cannot be a gynecologist overnight or in 2-3 months training. Right? And same thing applies to the gynecological surgeons as well, that they cannot become GI surgeon overnight. So if you found that you need help, then call for the help, and that is the perfect scenario.
Right. Dr. Puntambekar, are you with us? I think.
Hello, I am here.
Yeah. So my question was. I
got the question.
Yeah.
So I personally feel that I have a view that every gynecologist should be trained for some moment with a good either an onco surgeon and secondly with a gastric surgeon, GI surgeon. He may or may not be able to repair the ureters. That is a different story. But if you cannot repair a small bowel, because it's not always going to be a very virgin abdomen, you are going to get abdomens with laparotomies. If you do not know how to tackle small bowel or large bowel, which is fairly simple to tackle, if you recognize it, that is the most important thing. I think it is very important to be trained with or at least have 1 or 2 months training just to understand the anatomy. Oncosurgeons open pelvis from top to bottom in every case, gives you an idea about where the vessels and where ureter lies. And a GI surgery experience, at least how to suture the bowel is very important. Rectal injuries are very common during these surgeries. Small bowel injuries are common when you have adhesions. Even if you have the training to take care or handle the small bowel, or you have seen them, I feel it is very, very extremely important. And that is the reason I don't know what is the new training process, but when I was doing residency, I had 2 months of gynec and the gynecologist had 2 months of surgical training. There used to be a compulsory rotation. So I don't know whether the system has changed, but we had this system and which actually gave us an experience of understanding the anatomy. No harm in learning the anatomy.
Right, sir. Dr. Sanjay Patel, yes, sir, please.
Tamil, I think I tell you the one story related to Silas Puntambekar. He is the different kind of the genius person. Even though he put the scope in the thorax, I know that. I have seen. Even though he do the, lobectomy or everything with the, even though he do the thyroid gland with the laparoscopically, and even though he able to put the scope in the brain and he remove the tumor. But I think what we realize, Silas is the different part, even though I tell you, we work with the Lakshman since a couple of years and we realized that our journey started when I started the onco work. in 90s. I first performed the laparoscopic Vardim in 97 because I am from the Cancer Institute. Somil, can you hear me?
Yes, sir. Yes,
Somil?
sir. Yes, sir. I can hear you.
Yeah, we can hear you. We can all hear you.
I do the lot of open laparoscopic open Vardim and everything. I know everything related to this anatomy, and we apply the same thoughts in the laparoscopy. And we, I think, perform the total laparoscopic hysterectomy, extended hysterectomy, just mobilize the bladder. We remove the ortho joint of the ureter, and we try to make the as much as parametrium and what the Silas or other people is doing. I think, but its concept which generated in 97, and the lymph node dissection we done laparoscopically with the 98. I think I know the Silas. I think first time I seen Silas Budamekar, I think because this is the gynec event, and at Kochi in Lee Meridian Hotel, behalf of the Silas, I think Dr. Sathe is, I think, presented this work, and I spoke to the Silas. Silas, this is your video? Silas, yes, this is mine. Even though we together work at the Panalivellu event in 2002, 2004, might be Silas is, because now Silas is very big. It's beyond our boundary and beyond our image. Silas is so big. But I remember, I think first time I invited Silas in the Jamnagar, at Jamnagar. And I think the whole audience is mesmerized behind Silas. And I realized he's one of the person he popularized laparoscopic Vardim in the every corner of the India. Like the Prakash Trivedi is popularized the endoscopy in every corner of India. ये नहीं होते तो आज हम यहाँ नहीं होते, because he created the roadway and everything. But one fact story, I realized that when I started I realized whatever previously we do in the endometrium, just lifting, we do the adhesiolysis, and 6 months, 7 months, again 2 years later, patient is presented with the chocolate cyst, with the hydronephrosis, with the hydroureter, with the sometimes dyschezia, difficulty in passing the stool. And we realized that what we done in endometriosis cases in the 2000, up to the 2000, it's absolutely wrong. Then we started the ureterolysis. We realized the ureter is the first victim to, I think, affected with the endometriosis. And then we understand related to colorectal. At that time, we thought that this is the white lesion, this is fibrotic adenomyotic lesions. Dr. Trivedi is also knowing, because very few people in the world know related to endometriosis, what the people know today. But at that time in era, we tried with so many urologists, so many GI surgeons, and so many even the onco surgeons. But these people have a lot of difficulty because it's the new disease. The nature of the disease is different. The nodules, the fibrotic pattern of this disease is absolutely different one. So even though GI surgeon couldn't have the exposure with this disease, and even the urologist, sometimes what's happened? I think the complication is much more when I think we affiliated with some other faculty, and these people is find out that this is not the cup of tea, it's a different type of the adhesions, different type of things. Even though we couldn't separate the colon, I think it's very hard to us to understand the alter anatomy. We couldn't separate the ureter. Then we started working over it on the 2001 onward. We started with the ureterolysis. We dissect the middle pararectal space. Meanwhile, we learn our journey with not the straightforward like Saumil, you and other young people is doing the dynamic work better than us, rather better than the Silas or me or Dr. Trivedi sir. But I think what we, even though so many young youth, if you look the Deepak, I think it's the excellent hand in the harmonic. I think he's like magician. He worked with the harmonic, I think, and he is the great oncosurgeon. Even though he started this work in 2010, and within 10 years he reached up to this stage. No doubt, I think it's based by the Silas Potabekar, because Deepak is also trained with the Silas and he created the different glory and everything. But one more important part related to endometriosis, it's not the cup of the tea for the GI surgeon or urologist. We encounter many complications in the beginning when the two faculty is together. And what we feel the boundary, I think people is try to make the stretch there. And due to the not understanding the endometriotic pathology, it's end up with a lot of complications there. And that's why we started our own. Even though Dr. Trivedi is the eyewitness, in the one of the event in the IAG annual event, I started with the ureterolysis and I started with the middle pararectal dissection. And the organizer is shouting to me, I think, why are you doing this one? Then I try to make the explain in 2000. For the colorectal nodule, you mobilize the colon, you dissect the middle pararectal space, mobilize the ureter, and then we able to do the remove the colon. And he halfway, I think he told me not perform furthermore because you couldn't take the any consent related to any complications. So this is our scenario in up to the 2000 2008. Then people started understand because I am in the very black mode. I try to make the explain related to endometriosis so many people. But even though no one can ready to understand related to my thought, people is told that Sanjay have the surgical mind, and that's why he tried to make the remove the whatever he told the white lesion. We couldn't realize in the auditorium that this is white, and he removed the uterosacral and he dissected ureter. So this is the scenario. I think somebody with a different subject, even the GI surgeon or urologist need to be understand related to this different kind of the disease. Silas, might be you are agree with me?
Yeah, I agree with you completely. It is always a difficult problem, and you have to understand it from 3 dimensions. I completely agree with you, Sanjay.
So on that note,
Somil, one small little comment I'll make.
Sure.
See, it is very important as we in the gynecological endoscopy, we started becoming very friendly with Sailesh, Sanjay, Deepak, pediatric, etc., etc. Now, the important point is doing a radical hysterectomy, doing lymphadenectomy doesn't qualify you to be called as gynecological laparoscopic oncology. Now, that is point number 1. You can learn the art of doing a dissection till a certain level. That you should do it. Like our younger generation, they are doing, what of the people are doing. So basically, I think so, apart from certain training, you have to have real broad principles about oncology, that what else to be done, when radio, when chemo, when prior, when not, etc., etc. That was first. Because even when Sailesh, I remember in 2003, the open cancer surgeons were the maximum people who were, trying to tell. Now, about endometriosis, again, it's a totally different ballgame. For endometriosis advance, first of all, you need a huge volume. And on top of it, you should have the desire to persist on learning. So by the time people are learning, they may not have huge volume. So nowadays, we hear everybody talking about DIE, this, that, etc., radical hysterectomy and all. So it is becoming fashionable. But if you ask me, super surgery for endometriosis, maybe in the world, I think so, Sailesh is also there. There may be hardly 15-20 main people, of which Sanjay may be one, Sailesh may be one, Arno may be one, Marcello is one. So there are quite a few people. There are quite a few onco who can do a good endometriosis work. The duration of surgery should be optimum, wherein you're constantly in touch with your teacher, constantly, from where you have learned. Okay, this is the situation, this is what I'm going to do, what should be the method. And you should not be ashamed that, okay, you call them or you send them to those persons. So it is not possible for all the endoscopists to become advanced endometriosis surgeon and not necessarily oncologic laparoscopic surgeon. So I think so we have to understand, as you do so many things, you should have that much volume of a particular work to consider that you can achieve mastery. So I think so we have to draw a line and have all Lakshman, Sailesh and everybody, have in close proximity. But I agree with the Sanjay Patel. Okay, don't call the urologist too early. You start dissecting first, do it with a general.
Absolutely right.
Then let the urologist come later on, so that they don't stop your uretrovesical anastomosis.
I tell you one story, Saumil.
Yes,
because Harish is with us.
Right.
Because we started and we understand related to infiltrating attitude of this endometriosis, this invasive and corrosive nature of the endometriosis. हमने एक अपना dry variety and wet variety का एक classifications बनाया था. Still today is very simple. Today is Harish with this forum. I think Harish every time he is telling कि साहब आप 10 साल जल्दी आ गए हो. आप लोग आपको पागल ही समझेंगे. Because at that time we tell related to adenoma resection, Sadhana Desai madam is telling me that Sanjay have the surgical mind, that's why he told for the adenoma resection. This is the word. Even in the halfway, people is not ready to accept it. Okay, this is, I think, different disease, you deal with the different. हरेश ने 10 बार मेरे को बोला था कि 10 साल बाद में आपको आने की जरूरत है, 10 साल जल्दी आ गए. हरेश, are you with us?
Yes, sir. As I think.
Yes, sir, I'm here.
Yes. On that note, I think it's high time. We have much exceeded the timeline. I think we were scheduled to finish at 7:30. It's already 8:45. But what a wonderful discussion we have had, and truly I hope the third eye of everybody is open, and it's a great philosophical effort by everybody to understand how to function as a unit, as a team. And it has been a really engaging, a really holistic webinar. And I thank all the faculties, that is Dr. Trivedi, Dr. Puntambekar, Dr. Sanjay Patel, Dr. Sanjeev Upadhyay, Dr. Lakshman Kheria, Dr. Parna Thakkar, Dr. Vijay Shetty, Dr. Harish Vagasya, all of you, thank you so much from the bottom of my heart for taking out so much time on Sunday, that is from 3 to 8:45 almost, and it has been one of the most engaging webinars wherein we have covered a lot of bases with excellent videos and also heartfelt thanks and gratitude to all.
Okay,
Somil,
we will have some
congratulations.
cheers. Now we should have a webinar only on wines and whiskies, nothing else.
Somil, amazing.
Sir, I think this can be
What wine is a
this can
wine?
be a personal group chat.
Bye Sanjay, bye Somil.
Bye, sir. Bye. Thank you.
All right.
Thank you very much. It was a
Somil,
pleasure.
congratulations.
Thank you, sir.
And hearty congratulations.
Thank you. I think before everyone just leaves, I think Seshan, are you having some last winding up video that you will be playing? Seshan or Arvind, is anyone with us?
They must have gone for their session. Session
Okay.
with the.
So on that note, I would like to thank the event organizers, that is MCure, and also Science Integra for their support, and the AV Tech and the help. And once again, thank you to all the faculties. I think Dr. Vijay Shetty has left mention to him as well. And thank you, and hope you have a great night, and look forward to many such engaging sessions in the future. Thank you.
Thank you.
Thank you. It was a pleasure.
Thank
And
you.
congratulations.
Thanks.
Bye.